এটা হবে ঠিক মতন ওকে हाँ हाँ ठीक है good morning and welcome all of you to the breakfast session. I think there are few people, so maybe everyone can sit in the first row. If you can, all of you can come forward. That will be very helpful. So this is about meniscal repair, right? And this session is supported by Convent Limited. So once you have, we'll go through the technique essentially, right? We don't want to go through exactly what. Yeah, thank you. So we don't want to go through the theoretical aspect, because by the time you have come into this operation theatre, you've already been through a proper clinical examination, you have been through all the imaging, meaning thereby a good quality MRI scan, which should be at least 1.5 Tesla or 3 Tesla, the new machines, right? You have been through clinical examination, you have been through radiological examination, you have brought the patient into operating theatre already and done a diagnostic arthroscopy by now, right? And in the diagnostic arthroscopy, you have found that there is a meniscus tear which is worth repairing. What is worth repairing? I'll try and quickly go through the steps. So one is age is a criteria. So typically meniscal repairs we do below 40 years of age. Now 10 years ago this cutoff, I was taught in the Western world that this cutoff is 32, 33, but then gradually it started going up. Then it came to 35, 36, 5-7 years ago we heard. Now we hear that the current evidence suggests the cutoff should be around 40-ish. Maybe in times to come, the cutoff will become even higher. We don't know. That is for evidence to evolve over a period of time. So age is one criteria, we know about it. The other thing is tear pattern, which is very important, because complex pattern tears should not ideally be repaired. The essential idea behind meniscal repairs is that they need to heal. If you repair something, your repair is completely waste unless the two ends of the repair join, and that applies to any bone, any soft tissue, anywhere in the body, right? So the meniscus repair has to heal, and for that to happen, you need to have tissues which have got good blood supply. So then comes the zone concept. You've got the red zone, you've got the red-white zone, and you've got the white zone. So essentially the red zone and the red-white zone, where you have got good or decent blood supply, are the areas which are amenable to repair, which should be repaired. The other thing to look at is, there is evidence to suggest that if you are doing some kind of reconstructive surgery, for example an ACL reconstruction, along with a meniscal repair, your meniscal healing rates are much higher. Why? Because you are drilling into the bone, there's so much of blood, there's so much of repair chemicals falling into the joint, and that helps you not just with the graft incorporation that you would achieve in an ACL reconstruction, that also helps you in healing of your meniscus, right? Then I'll also take you through some of the techniques that you can do during a meniscus repair. If you've got an isolated meniscus repair, for example, you can do a bit of trepanation, you can generate a healing response. Those are some of the tricks that you can do to slightly improve your chances of healing. So it has to be, good blood supply, it has to be age appropriate, and it also has to be, if at all possible, it also has to be with some other reconstructive surgery to improve your chances of healing. Then there are other criteria about the length of the tear, which people have spoken about, 3 centimeters as the cutoff, and then there are other criteria about duration, which is a very questionable thing. Some people have said that more than 6 months old meniscal tears should not be repaired, but then that evidence is still, the jury is still out, we do not know for sure about the duration. Now this particular technique of meniscal repairs that we are going to talk about today, this is an all-inside technique. This is applicable to body and posterior horn tears. You can also use it in anterior horn tears, but then typically in anterior horn tears, if you are going to repair, we prefer the outside in because it's very simple, quick, convenient, and very fast. Just put in 2 needles, take your stitches, you are done with anterior horn. Body and posterior horn, typically the posterior horn is where we are using one of these meniscal repair devices, and this is an all-inside device, and then there are other brands as well of all-inside devices. All these all-inside devices are the most handy, most useful when you are dealing with something in the posterior horn, right? Now in the posterior horn, I would exclude the posterior root out of this business, because the posterior root needs to be reattached to the bone below, and for that typically we use typically the ACL jigs to create tunnels, take stitches to the posterior root and pull it down into the tunnel and tie it on an anterior suture bridge or a disc or whatever you fancy. So that is for the posterior root, but typically posterior horn tears and also meniscal body tears can be addressed with this. So without going into any further details, I hope I've just set the background. Do we have something like a camera can be put over here so that zoom kar lega na? That should help. Just make sure that whatever we are doing over here is visible on the screen. Okay. So so this is a silicon model of the thing. So how does it work? Do you have a pen by any chance? Yeah, so I would just look at it, say we are looking at this as anterior. कोई पेन है, कोई इंक वाला पेन होगा, it will be better. नहीं है? Thank you. ऐसे? Then it will be more visible to the camera, isn't it? Or should I face like this? Thank you. So what we are trying to achieve? नजदीक होगा, zoom कम करना पड़ेगा. Thank you. So yeah, we've got plenty of this silicone stuff over here. Now this I am marking as A, as the anterior root. This I am marking as P. Okay. So as I spoke about, typically tears around here, this area, the anterior horn, they're very amenable to those outside in kind of thing, and then you will be struggling to get an angle and appropriate direction with these devices. So I would use these devices typically in the body around here, and most importantly in the posterior horn around here. Why do we stress on using these all-inside devices in the posterior horn rather than in the middle and the body and the anterior horn? Reason primarily being, in the posterior horn, there's plenty of soft tissue around here. Yes, you can do your outside in and inside out techniques with the posterior horn, but then you'll have to have a lot of dissection. You have neurovascular structures nearby, so you'll have to dissect, you'll have to protect, and then proceed with your repair. Instead of that, these all-inside devices are safe, effective, and provide a very good quality repair, right? So let's look at something in the posterior horn over here. So let's assume, अभी आ रहा है क्या? Sit, okay. That makes it better, okay. Now everything is visible. Please let me know if something is not properly visible, not properly audible. We can change things, and just so that everybody can understand it better. So let's assume that you have got a tear here in the posterior horn of, say, the medial meniscus, and this is in the red zone or the red-white zone, just about maybe a couple of centimeters, fresh, in a 28-year-old boy, and you are doing a simultaneous ACL reconstruction with it. Wow, that's the ideal candidate that you want to do a meniscal repair on, isn't it? So what do you need to do? You've done your diagnostic arthroscopy, you've got two portals. I sometimes like to use 3 just to get my angles right and just to be able to maneuver my instruments. But if you have got 2 portals, that's generally enough. And then what do? You are looking with the anterolateral portal around here, and you have got this medial portal. You need to make it nice and low. The other thing is also a slotted cannula or a half pipe, and I would suggest that anybody doing a meniscal repair should not, I mean, you may use this device or you may use any other device. Anybody using a meniscal repair should not do it without this slotted cannula or the half pipe as it is called. Reason being that this will direct your needle in the right direction and will never take you off track. So, if I can place it here, is this, can you focus the camera over here please? So, you've got the, can you open one of those new ones? Yes, this is a new one. Oh, I thought, okay. So let's have a look at the device first. Can you see now? Yeah, okay. So this has got these markings 1 and 2. What is 1 and 2? 1 is 1 centimeter and 2 is 2 centimeters, right? So typically, we keep it around 18 or 20 millimeters, which is this mark or this mark. And what you need to do is, can see hai? हाँ, काटेंगे कैसे? खोल देंगे. अच्छा ठीक है चलो. So what you need to do is, you need to take this sheath out first. You need to cut this thing up to 18, 20, whatever you fancy, depending on the depth of penetration that you are looking at. Cut this sheath, put it back up again, and only that much part of the needle is now exposed. So, the idea is that whenever you are penetrating the capsule, you only go up to this point and not beyond, because then the risk of neurovascular injury. So that the pegs, the little anchors as you would like to call it, made of PEEK material, they are staying outside the joint capsule, and I'll show you here what it means. So you cut it at 18 or 20, whichever, because we can't cut it, we don't have a pair of scissors. So I'll just take it off. But yeah, you cut it, put it back up again, and how you, can you see this? Now, Nila, can you hold? Oh, you got the blade, brilliant. That'll be nice. So you can just cut it at here. There you go. Yes. We can keep it this here. This is the knee. You are holding the slotted cannula and directing me in the right direction. Okay. Thank you, Sunitha. Brilliant ideas. A surgeon always has a blade in his pocket. So, of the next subsequent stitches. First time it is pre-cocked. So you, I will just take you to, this is a wheel which moves the suture up and down. This is the ratchet mechanism which can lock the suture, and this is a trigger which fires your the PEEK anchors or the pegs, right? So you put in like this, you fire your first one, okay? And the mnemonic here to remember, there's just one thing to remember, is PRDT. Penetrate, okay, ratchet, rotate, sorry, penetrate, rotate, deploy, and then tension. Tension is with the ratchet mechanism. So PRDT, so you penetrate, first time you don't rotate, yes. First time you don't rotate, you penetrate, you come back, okay. Ratchet pe laga hua. This has to go on free wheel. Yeah. It has to go on free wheel so that the suture comes out freely, okay. Suture has come out. Next, what do? You put it on the ratchet, and can you see all this happening on the screen? Huh? ये wheelie दिख रहा है? handle, wheel, and then when you see there's a click. When you do this, that peak anchor which is sitting outside the capsule, it is getting tightened, right? Tick, 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 tick. I've had enough tension on this thread, right? And then I can unlock the device and move on to the next step where I'm going to create my first mattress. So this is my next penetration. So penetrate, and then you have to rotate it 2 full turns. 1 full turn, 2 full turns, okay, penetrate, rotate, and then deploy. For deploy, you have to cock it up first, okay. Revolver में पीछे करना होता है, इसमें सामने करना होता है. And then you fire, right? Penetrate, rotate, deploy, and then you tension. ये free wheel पर है, right now it's on free wheel, so you can take this out. Okay, you see there's a nice loop which has formed between the two. Can you focus on the loop, please? And then you pull it. Now you want to tension it. PRDT, penetrate, rotate, deploy, and tension. For tensioning, you latch this thing so the suture locks. Now the wheel is going to tension your first stitch. ये देखो निकल आया. हाँ. So this is silicone. In actual life, it doesn't come out. So you tension it up, right? And once the tensioning is done, your first stitch is complete. Then you release it again. Again the same story. Penetrate, rotate, 1 turn, 2 turn, cock, fire, deploy. इस बार नहीं निकलना चाहिए है ना. Deploy, हाँ. So it's deployed nicely, and then you tension it. And for tensioning, ratchet and this click click, and this time it will tension because the peg is sitting. इसको खींचो. Yeah, you pull it. Yes. Now it's going to tension. Tension it to whatever amount you want. You are comfortable. Now there's something very important in this step, which I've realized with this device and with other devices. You see, if you try to pull the suture very hard, these sutures are really, really tough. You can see that you are cheese wiring through the meniscus. And even before you know it, you have cheese wired more than what you should. I have learned over time that the trick to get away is not to get over enthusiastic with ratcheting and tensioning this thing. You bring the two, the two items that you want to bring together, you bring them together, but don't try to cinch or squeeze them, because if you try that, they are very good. These threads are very strong and very good at cheese wiring. It will cheese wire and your entire stitch will cut out. I've done that, so I know how it goes wrong. And then you are like, oh my God, right? So don't. So this is tension. Now let's go to the next sequential stitch. Okay. Release so that you have got enough thread. Again the same story. Penetrate, rotate, 1 turn, 2 turn, deploy. For deploy, cock, fire. And then you come out very gently, and now is the time to lock the ratchet. And see, this time the peg shouldn't come out. It's not coming out. So this will be a nice stitch. Can you focus on this stitch by any chance? Is this stitch visible? The one which is coming up? ऐसा करने से हो जाएगा. हाँ. Now you got it. ऐसा towards the camera. Yeah. You see it has. Yeah. So that's a nice stitch. So there we go. You have tensioned it enough. Now you can use a cutter. Cut it. They've got an expensive cutter with this. Yeah. So they always want to sell the expensive cutter. You can use the suture cutters that you use in your shoulder surgery, right? Or if you don't have that, use the punch, the nice, fine, sharp punches, crack, and it's done. I know, 4 we have done. And you have got lot of free suture. And you can cut this outside and use your standard suture cutter. Anybody wants to try a hand at this? They've got a sample over there. I think they've got a few samples. So you can come forwards and try your hand at this thing. See, the beauty is, if you get the stitch nicely placed, can you focus on this please? You know these peak pegs, they sit so nicely outside the capsule and they are so, you know, they are so snug. Even if I try hard, I can't actually take it out. And you can choose between the 4 and the 7 variants, and whichever one you like, use that. The 4 would be obviously cheaper than the 7 peg thing. Anybody wants to ask any questions, anything, any clarification? You are asking my bailout tricks. Misfire nahi. I'll tell you what goes wrong with this particular device. There are other devices also and things go wrong with all these devices. What typically happens with these devices, I'll tell you. Intraoperatively, boss, there are times when you are struggling to get this ratchet. Ye jo switch hai na, this sometimes jams. You can be absolutely brutal, use force. Nothing will go wrong. Okay, that is one thing which goes wrong. Ye फंस जाता है. And then you just push. Use a gauze piece, blam, and it goes. This is where it goes wrong. The wheelie, you know, this has never gone wrong with me. Touch wood. God is kind. And this thing you always have to, with the trigger will not misfire. But if you don't cock it, then it's not going to work. So sometimes in the heat of the moment, you know, you are, here it is very easy to demonstrate. This is not a real life situation. I have all the luxury to rotate my hand and do whatever I want to. In that tight constrained space, your assistant is holding the leg, you are holding the scope with one hand, and many times you are holding the scope with the right hand and doing it with your non-dominant side. In those situations, yes, you tend to forget. You have to cock it. And then fire. That's the trick. Okay. You can do that also. If something happens with the knot, then you can, you know, tie it again and cut it. So there are plenty of options. The other. Thank you so much.
So after this nice demonstration on how to repair the meniscus with your sequent, we have a nice lecture on how you can have an effect of double bundle ACL with a single bundle. I say it's nicely paper published by Dr. Mukesh Ladda. So I would like to request him to give us some insight into that. Mukesh, please. If anybody wants to try that sequence, they can try in their ConMed stall. They can use there's free samples out there. You can use try in their stalls as well.
Hello everyone. Good morning to all. I would like to thank Kolkata Arthroscopy Society for inviting me for this prestigious meet, and sincere thanks from the bottom of my heart to conduct this physical meet after such a long time. Thanks to all Kolkata Arthroscopy Society. So in COVID times we all were very free, so just thought ki kuch to let's do something different with our ACL technique. So this is what I developed recently, a new technique, how you can get a double bundle effect with single tunnel and how can you enhance the footprint of ACL. So let's go back to and see, if you see the routine ACL, the footprint of tibia, if you see it's mediolaterally small and anteroposteriorly, it's quite big ACL footprint as you see in this, and this is what the new rectangular oval tunnel will create. So we'll have a bigger area for collagen to put into the tunnel. So this is what I did on cadaver also, and this you see there's a small circular tunnel, but the footprint is quite big. So with that tunnel dilators, you can convert that circular tunnel into a rectangular or somewhat an oval femoral tunnel, thereby increasing the footprint area. Similarly, if you see the native tibial footprint after removing almost the complete stump of ACL, it's quite big, not circular, more so anteroposteriorly compared to mediolateral dimension. So this is what we regularly do, a circular tunnel in the center of the ACL remnant. And the tunnel dilator, which I used, coming slowly and changing the shape of the tunnel from circular to somewhat rectangular round tunnel. So this is what it looks after you completely make, and you see we are covering maximum original footprint. This is what it looks, the original tibial footprint. That's the single tunnel, single rounded tunnel anatomical ACL reconstruction we do, and that's the rectangular tunnel increasing the footprint. Now comes what kind of graft you put in it, because you need a graft which will take that shape. So the philosophy here is, if you suppose have a graft diameter of 9 mm, you first drill with 8 mm and then convert that 8, keep mediolateral 8 same, and then slowly convert that 8 into 8 by 10 using your various tunnel dilators which are size like 8 mediolaterally, which is fixed, convert it into 8.5 anteroposteriorly, 8 by 9 and then 8 by 10. So a soft tissue graft will take the shape because it will squeeze from one side and it will expand from other side because it's a soft tissue graft. So it will completely fill the tunnel. So for 9 mm diameter graft, you need to first drill with 8 and then convert it into 8 by 10. And once you do, you can see that you are covering maximum area and the graft is going and covering amount of posterolateral bundle as well as anteromedial bundle, because the part of the graft which comes on anterior on the tibia will go on the medial side of the femur and the posterior will go on the lateral side. So somewhat a double bundle, not exactly double bundle, but somewhat a sort of. And if you see the same graft from posteromedial bundle, and when you do flexion extension, you can see that the anteromedial bundle getting lax when you extend the knee, a sort of, and when you flex the knee, the anteromedial bundle will become taut. A sort of double bundle like effect when you view the same through posteromedial bundle after doing reconstruction. You can use the same implants which you are using in your routine circular tunnel. You can use an adjustable loop or fixed loop and the same screw down. And the other concern, because some papers were there where they have used it only on the femoral side and they have not used it on the tibial side. The concern was whether it will cause some impingement when you extend it. But I believe you are making a more oblique tunnel and it doesn't cause any impingement even on full extension. So the chances of impingement is also less because the tunnel is going more posteriorly and not anteriorly. Hence the impingement will not be there. And this is what I did on cadaver, where you can see that the anterior half of that ligament will go medially, creating a sort of anteromedial bundle, and the posterior half will go laterally, creating a sort of posterolateral bundle. And when you extend, you can see the differences what we normally see, the AM bundle tight in flexion and then lax in extension, which is clearly visible on this cadaveric ACL reconstruction with this new technique. That's the post-op X-ray. A simple mathematical calculation says that with this technique we can increase the surface area by 25% on both the femur and the tibial side. So am I the only one who was thinking on this? When I searched literature, there was a nice article in 2019 from Chinese group where they have compared anatomical single bundle reconstruction with rounded rectangular tibial and oval femoral tunnel, a prospective comparative study versus conventional, and they found that it is superior to conventional technique in terms of sports activity level, rotational stability, and early graft remodeling process. Another article also mentions the same, that the oval femoral tunnel yielded significantly better knee function and knee laxity restoration and more mature ACL graft. And the latest one in 2021 in a Japanese study where they have compared circular and rectangular tunnels, they found that larger bone tunnels achieve superior clinical results than the conventional rounded tunnel. So people are thinking on this front and they have conventional results. So my technique has also been accepted in Arthroscopy journal recently. So what I feel, this technique is a single tunnel, double bundle like footprint enhancing, better and fast graft healing it will give, will be a sort of more anatomical, will give more stability. Surgical steps are same because you have just changed the shape of tunnel dilator and not added any extra step. So no much learning curve, hence surgeon friendly, and you can use the same implants. So the cost also remains the same. Thank you everyone. Yes.
Yeah, one question, Mukesh.
Yes.
Nice technique, good thought philosophy. Do you think it will make sense if you twist the graft by 90 degrees?
Yeah, it will have more of.
Do you think the alignment of the fibers
Will differ
be
definitely.
better suited to this particular philosophy?
Yeah, because
Sundar, your views on this? Dr. Sundarajan, Secretary, what are your views on this?
Mike, please.
So we are trying to increase the footprint area, which is what we want. But like how we do with the bone tendon bone, we try and twist the graft on the tibial side by 90 degrees to get a better orientation. With this, do you think that would be advantageous, and what are your thoughts on this?
Yeah, I think that will add an additional, as Sachin said, will definitely add an additional benefit because this technique.
Normal what the ACL looks like. It will be more like a normal ACL both bundles.
And also,
If it twist.
I think looks like that the tunnel which you made it little oblique, definitely it increases the orientation better than the normal footprint which make it a round, because we know that it is an oval footprint with ACL. I think definitely it makes sense making this technique. Did they have any comparative study with the MRI?
Right now I have not done, I have just started, but the few papers which I have done, they are comparative studies of rounded and rectangular tunnel.
With the MRI, with the footprint.
With MRI and everything they have done.
When we talk of a flat tunnel, we mostly talk about the
PTP.
Bone powder tunnel.
Yeah, they have used SEMITI only. And one which was came in Chinese paper, they have not used the punch, they have used a bone file to change the shape. But they have not mentioned how to restrict that. Means how much deep you need to go. So there is no mathematical calculation they have done. And they have used SEMITI. I have tried this on bone patella, but it's really tough to get that shape of bone patella. You need to be very precise. You need to be a good sculpture for that, basically, to get that shape.
See, but what Dr. Sachin was telling, that ribbon effect, that will come only with a flat graft. It will not come with a quadruple.
Definitely.
And once you are using a bone patella, I don't think most of the studies have used a bone patella only.
Yeah.
Few you are mentioning they have used this graft. So, but with the bone patella, when you put a bone plug and you put a screw, it automatically becomes flat like that.
That's the ribbon concept, just came up by Dr. Simliski, but we all are using now SEMITI, maximum of us are doing. So, but if you see the cross-section area of SEMITI is also not rounded, it's what literature says. It's also somewhat flat.
Is there a, Mukesh?
Yeah.
Even previous studies also, in your studies also, how much surface area have been increased by using this technique?
25% the simple mathematical calculation, because the circular area we calculate pi r square, and this rectangular is width, length into width. So simple calculation, it's increased by 25%.
It was measured and analyzed by postoperatively.
In that paper,
CTR,
no, they have not measured it, but it's what I have started doing now. But it's too early for me to comment.
Though you have changed the configuration of the tunnel, from the circular to the flat one,
Yeah.
the cross-section of the graft and the tensile strength of the graft is similar to the rounded one. So does it really affect the biomechanics?
Yeah, because you are now adding more surface area, so more collagen and more native ACL you are giving. So it's like in rounded single tunnel, you may either create a more of AM bundle or in center of more of PL bundle. But here, once you make your circular tunnel, you can shift it either to PL or AM depending on where you have made your first circular tunnel. So definitely this will have more surface area and will behave and mimic like a more normal ACL.
Thank you, sir.
Okay, so that will be the last question.
Okay, sir. Very nice technique. Congratulations.
Thank you, Vivek.
So there are some papers where they say that while putting your interference screw in tibial tunnel, the shape of footprint changes. They also say that somewhat if you keep it medial or lateral to mimic the elliptical shape.
It's not about
do you think that in your technique the position of screw, interference screw in tibia changes? Because suspensory fixation it won't change, but with the interference screw will it change?
Interference screw won't change the position of the tunnel. It will shift the position of the graft. If you are somewhat anterior, some people try to put the screw anterior so that the graft goes little posterior. But here it won't change much because it's a rectangular tunnel. Only the entry of the screw at the distal tibia, it's little tricky. Little force is needed while you enter, but once you enter, then it's all cancellous bone and it will take its own course. It won't change.
So thank you, Dr. Latta.
Right, thanks.
With that, we conclude the breakfast workshop session, and we start off with the first session of the day, that is the patellofemoral issues. And I invite on stage our chairpersons, Dr. Ishar Pradhan and Dr. Arunanshu Bhattacharya, to take over, please.
Coming all to the first Sportsmedcon in Calcutta. Today, I am Dr. Arunanshu Bhattacharya. I am honored to chair the session. And I am today now the first session topic is patellofemoral insufficiency. At the outset, I would like to I'd like to say a few rules about the speakers and for the audiences. There are three, for master talk, there are three eminent speakers here. But for each speaker, we can, there are 8 minutes allotted for speaking and 2 minutes for Q&A. So, again, thank you all. And I am calling upon Dr. Gigi Kaur to make his speech on patellofemoral anatomy and other patellofemoral, speak on patellofemoral stabilizers, patellofemoral stabilizers, normal and pathoanatomy. Thank you.
So it's a warm welcome on behalf of Kolkata Arthroscopy Sports Surgery Society here. Okay, I'm online. So this background is abstract and it's changing, like your patellofemoral problems and patellofemoral stability. It also changes from time to time and during every bit of flexion. And you see, the normal patella is just like us, the normal guys. We do our job, and I think this has to be clicked. Yeah. So it flexes and extends along its own track, protects the front of the tibia and the femur, distal femur, and it also elevates the quadriceps mechanism for its mechanical advantage. That's its job, and after its job, it nicely homes back. But it is pulled in many directions. Like our lives, we are pulled in many directions, our clinics, hospitals, income tax, and our hobbies, traveling, etc. But we are sane people, we are normal people, so we basically cope up with all these distractions and stay focused, stay in track. Even IT band nowadays have attachments to quads and patellar tendons, not in Gray's Anatomy though. Here, Dr. Patella is very cross because something idiotic has happened there. Somebody is trying to arrest a skeleton. There's a slight analogy to our research methodologies, because most of the methodologies which try to delineate the different stabilizing factors are on dead bodies, not on living bodies. So it's not possible. Maybe someday some software will come up which will allow you virtually cut MPFL in a normal patient and see what happens, but still now it's not available. So we are with the dead bodies. Now Dr. Patella can get worried by distant factors also. For example, from the hip to the foot, everything can contribute to destabilizing the patella. We have loosey ladies, and long back, 35 years back, Dijon came up with these four main factors for patellar instability, like trochlear groove dysplasia, position of the patella, high up patella, distance between the tibial tubercle and the trochlear groove, and the lateral patellar tilt. After 33-4 years, he has come up with another book where he has put less importance to the patellar tilt because it is the combination of all the factors, and the additional factors have been put in, like excessive femoral anteversion, patellar dysplasia, VMO sarcopenia, loss of the muscle mass and this power, Q angle increase, femoral anteversion, and excessive tibial external rotation, recurvatum, and also the valgus. There are local stabilizing or the destabilizing factors like bone morphology, your dynamic soft tissues, and your static soft tissues. Those are also nominated as static, active, and passive things. But in vivo, there is a complex interaction between all these, starting from the brain itself. And this complex interaction has been highlighted in many researchers, by many researchers. For example, that abnormal trochlear geometry reduced stability by 70% at 30 degrees of flexion, where it is most important. Relaxation of the VMO or wasting of the VMO causes 30% reduction. And if the medial retinaculae are not there, ruptured, it has got the largest effect at 0 degrees of flexion, that is in full extension, almost 50% of reduction of the stability. So the patella is at risk of in all those cases. Combo offers we are very fond of, but combo offers are not always good here. If there is a combination of trochlear dysplasia plus high TTTG distance, then it's 37 times more prone to have objective patellar dislocation. If it is combined with patella alta, then the risk is even more. There are two kinds of patients, like in shoulder tabs and ambry. Here we have warps and stayed. We are not going into details of that because that will be covered in clinical scenario. There is also a PIS, patellar instability severity score. The sulcus saga continues. The continuation of the sulcus from top to bottom is like boat shape, and it also flattens at the top, and it becomes more close down because it has to accommodate the patella, which is broader at the top, and down it's narrow. These are the various angles measured at different degrees of flexion. These are the graphs that measures this. This is the sulcus angle. We are more concerned about sulcus angle earlier, and the sulcus angle varies like this in different degrees of knee flexion. As the knee flexes, the sulcus angle goes down. So it's not only a static thing, it's a dynamic thing. We have to remember that. And there are different types of trochlea. Dejor has emphasized on this type 1, type A, B, C, and D. And this is a very old book, almost 40 years old book of Scudery. And the Gal Scudery, this drawing is from that book. Much have not changed, only that the MPTL, which was not there in that original drawing, is now giving some importance over here. We have the lateral vector. Why? Because we have become bipedals. The quadrupeds don't have this lateral vector. So the lateral vector works in this way. You all know about the Q angles, and this Q angle causes some lateral push to the patella by nature. Because when we extend the knee, we have to have the screw home mechanism so that the tibia externally rotates, and naturally tibial tubercle also rotates laterally and puts the lateral vector. So initially, when there is no contact between the patella and the trochlea, MPFL is the only thing that keeps the patella centered. And after that, trochlea shape gradually takes over. It has to work, the MPFL has to work against the lateral vector. And once the patella gets into the groove nicely, it can relax. Overall, MPFL produces 50 to 80% of the restraining force. This is the MPFL in a cadaver. And if there is a patella alta, you can see MPFL has to stretch more. It has to elongate. And it has to guide patella through more degrees of flexion before it can go home. In objective patellar dislocation or instability, MPFL gets damaged. Even with other factors positive, dislocation cannot happen without rupturing the MPFL. If the check rein is gone, onus is on for the secondary restraints like your MPTL. And stretching of MPTL often breaks, takes out a tiny chip of patella with it. So there is a possibility of recurrence. Possibility increases if the instability factors are present even before the original injury. These are the orientations of VMO, so you can see at 0 degrees of flexion, VMO is not doing this work. It is only by the MPFL. It's not taking the patella towards the medial side. In 120 or even 60 degrees flexion, it is more or less agonist to the MPFL. There are risk factors. These have been isolated. Trochlear dysplasia, history of other side dislocation, young children, and the CD index is higher up. If none of the factors are present, there is a 13% chance of dislocation. If all the factors are present, it's about 90% chances of redislocation. So in a capsule, normal tracking of patella is a complex and dynamic process. Generalized factors, distant factors, and local factors all have to be taken into consideration when we are thinking about patellar instability and trying to treat that. MPFL tear is the essential lesion, but if we only correct the MPFL, keeping other factors as it is, it may put a lot of strain on the reconstructed MPFL, and it can rupture again. Thank you.
Hello? Is it visible? Audible? Yeah.
No, you're not audible. Audible to me, yes.
Anyway, I think you can. Thank you, Dr. Kaur. It was a very succinct presentation. Thank you for your master talk. It was a big topic, but
it's a big topic. It's a big topic.
It's not working. Yes, thank you. We still have some. We don't have much time, but at least one question. Anything from the audience? Any queries from the audience? Okay. If there are no queries, may I
thank you.
request the next speaker? Thank you, Dr. Kaur. The next speaker is going to talk on clinical radiological assessment of patellar instability. May I request Dr. Asutosh Agrawal please come and deliver his talk. Thank you.
Thank you, Iris, Saarc and Dr. Rajiv, my friend. Now, Dr. Kaur has, I think, told most of things. Now, my topic is the clinical relevant assessment of patellofemoral instability. The patellofemoral instability is a clinical syndrome due to morphological abnormalities in the patellofemoral joint, where the patella is prone to recurrent lateral dislocation. More common in young active individuals, females more common, second decades, and it's around 6 to 77 per 1 lakh population. I'm not going for the pathology because Dr. Carr has covered all. Now, I'm coming to clinical assessment. Now, the patient presents with anterior knee pain, mechanical instability, pain increases up and down stairs, sports like running, jumping, and changing direction, and the patella being deviated laterally where the patient is squatting and lunging. These are the main clinical presentation patient presents with. Now, go for physical examination. Go for lower limb alignment. See that there is joint hyperplexia is there or not. There will be palpable defect at the medial patellar margin. There will be tenderness may be present. There are few tests. We can do for patellar glide test. We can have a lateral translation results in gardening and a sense of apprehension in patient. Patient tries to grab your hand and will not allow you to do this test. Now, then other is measurement of Q angle. If Q angle is increased, there is increased valgus force is there, increased lateral orient force, increased instability. Next is J sign. Associated with patella alta, there is excessive lateral translation in extension, which pop into a groove as the patella engages in trochlea early in flexion. These are the few clinical examination and physical tests we can do to assess patella is subluxated or dislocated or not, is unstable or not. Now come about the radiological evaluation of patellofemoral joint. Firstly, X-ray, rule out fractures or loose body. The fracture of the middle patellar facet is more common, and lateral femoral condyle fracture. In AP view, we assess, it's best to assess the overall of lower alignment and version of lower limb. This will say that the patella is prone to subluxation or dislocation or unstable or not. Second, in the lateral view, it's just best to assess the trochlear dysplasia. There are few signs are there. In this we assess the trochlea is flat or is groove or not. We see the cross sign. The trochlear grooves lie in the same as anterior border of lateral condyle. It represents that the trochlear groove is flattened. Second is the double contour sign. Here the anterior border of lateral condyle lies anterior to the anterior border of middle condyle. It represents that the trochlea is more convex, and the groove is hypoplastic middle condyle. There is this supratrochlear spur may be present. It rises from the middle aspect of trochlea. With this lateral view, we can assess that the trochlear groove is normal or not. Then comes the evaluation of patella height. Whether it's patella alta or basa. There are two indexes are there, in Saarc method and Cartan method. In Saarc method, we measure the distance between the tip of the lower pole patella with the tibial tuberosity and the distal length of the patella. Normal is 0.8 to 1.2. Next is Cartan method. It is more practical. In this, we measure from the lower atlas of the patella to the tibial joint surface and the patella atlas surface. In this, the tibial tuberosity is not a fixed point, but here it is a fixed point. Secondly, from the lower pole of atlas of patella to the distal pole of patella, some patient has more of bone is there, and so the ratio may differ. So current radiation method is more practical and is more appropriate. Then the Blument spline, it should extend to the lymphopolar patella when at 30 degrees of knee flexion. Next is Plateau patella angle. It's found between 20 and 30 degree. Next is sunrise or merchant view. It best uses for lateral patellar tilt. The lateral patellofemoral angle normally is the angle that opens laterally. It's normal when it's more than 11 degree. And next is the sulcus angle. It evaluates for trochlear dysplasia. The value more than 140 degree indicates that trochlea is flattening. With all these radial X-ray investigation, we can somehow rule out or assess this any pathology in patella or not. Then come the CT scan. We go for TG distance. It measures the distance between the two perpendicular lines from the posterior cortex of tubercle and the tubercular groove. It's more than 20 millimeter, usually considered abnormal. Then the patellar tilt is there. It's angle formed at the intersection between the major axis of patella and the line connecting the two most posterior point of femoral condyle. The mean of the value measured in the two conditions. We measure in two conditions, relaxed or contracted cordyceps. It's considered pathological if it exceeds 20 degree. It's indication of medial patellofemoral ligament insufficiency. Next comes the role of MRI. It further helps to rule out any suspected loose bodies. There may be osteochondral lesions may be there, bony bruise may be there, middle patellar facet more common, and lateral femoral condyle. We can rule out the tear of Mpfl also, which you know usually at the middle femoral condyle. Thank you.
Agarwal for this very informative speech. Thank you. So may I call upon Dr. Sachin Tapasvi for his next speech on the topic treatment of
this topic we are discussing itself is a very complex, we went through the anatomy, pathoanatomy, and a very nice clinical radiological assessment by Dr. Arthroscopic. And now we have the master himself here to solve the puzzle of the patellofemoral instability.
Thank you, Kishore. Thank you, Ishwar. Thank you, Arnav, for your kind words. And thank you, Rajiv, for putting together this fantastic meeting. At the outset, I want to invite all of you to my meeting, which is going to be in September, which is the main ISCON meeting. I think it's very important that all of us be here for this completely stellar meeting, and I'm going to encourage all of you to register today itself. So I'm hoping all of you will be there in full force September later on this year. So I'm going to be talking about patellofemoral instability and the clinical scenarios, and if you can break it down, you will understand that there are 5 clinical scenarios where patellofemoral instability will present to you. First, this is a 33-year-old lady. She plays badminton. She had a flexion valgus injury and she presents with pain and swelling which came on immediately. What you see here is the presence of a torn Mpfl from the medial border of her patella, and you can see that along the entire course of the Mpfl you can see a signal which does suggest that it is dysfunctional. Please note that there is no osteochondral fragment. It is an otherwise stable knee, but when you examine her, she has got faulty kinematics with an abnormal thigh, pelvis and knee orientation, and these patients are treated basically with rehab alone. Case 2, this is an 18-year-old male. He plays recreational soccer. He's had 3 episodes of patellar instability, and that is when he presents to us. He is symptomatic. This is his 3rd episode now. And what is important to understand is that on clinical examination, he's got a deficiency of his medial restraining structures. So very nicely in the previous 2 talks, Dr. Kar and Dr. Agarwal have mentioned to us the importance of these dynamic stabilizers, which essentially are the soft tissue stabilizers, and the MPFL was the one which they pointed out that in absence of other anatomic factors which are significant, it helps restrain the patella for the first 30 degrees of flexion in the knee joint, in the trochlear sulcus, and when you have a tear of this MPFL, you can then land in issues with the same. So it's important to understand that surgery is not indicated for the first time dislocator unless there is the presence of a large osteochondral fragment. You will do surgery only if there are repeated dislocations, and the way to look at it is that when you do your clinico-radiological correlation, there should be an abnormal patellar tilt which is more than 20 degrees on the axial views. Later on we have presentations about the technique of MPFL, so I'm going to leave that out for now, and you need to do an MPFL reconstruction using some form of free autograft and correct any associated factors. Third scenario, an 18-year-old girl, she fell during dancing. She has persistent pain swelling presented to us 8 days after the initial injury. She's got locking, and of course when you do a good clinical exam, she has all the apprehension signs which have been discussed in the previous talk. What you see here very closely when you examine her axial sections is the presence of this defect on her medial patellar facet. And as you look in further, what you can see is that there is also a disruption of her MPFL, and you can see and note that there is the presence of a large osteochondral fragment which is lying in the lateral gutter. So what usually happens when a patella dislocates is that when the patella exits the trochlear groove, they get a bruise or an injury to the superolateral aspect of the trochlea, and when the patella enters the trochlear groove, that is when you get an osteochondral fracture, if at all, of the medial patellar facet. So we have a scenario where we have a first time dislocator with an osteochondral fragment. These are the arthroscopy findings. You can see the defect there, and the large loose body here. So what do? She's presented within 8 days. You make an arthrotomy, you size up the defect on the medial patellar facet, you retrieve the loose body, and then we've chosen to repair it back to its base using some tissel fibrin glue and transosseous absorbable number 2 vicryl sutures which are being placed in a cruciate fashion. Of course, we need to correct the other pathology, which was the torn medial restraints. So you do a free MPFL graft, and this is the technique that I use using fluoroscopy control, and this is it at the end of the procedure. So what should we do when we look at osteochondral fragments? Well, ideally you should fix them within the first 10 days because later on they will swell up, and once they swell up, they really cannot go back into the base where they come from. There are 3 strategies to deal with them. If they are very small and in the non-weight bearing area, you can remove them. If they are large, more than 2 square centimeters within the weight bearing area, and if they have at least about 9 millimeters of subchondral bone on the cartilage, then you fix them. But if they do not have subchondral bone, then you need to think of alternative methods of doing cartilage restorative techniques, which becomes a completely different topic in itself. Scenario 4, what we see here is that when the patella, when you ask the patient to flex and extend, on extension, the whole patella subluxes laterally, and this is what is called as a J sign. You can grade the J sign based on the amount of translation that there is, and what it really implies is that there is faulty entry of the patella in the trochlear sulcus, which is what needs to be sorted out. There are 2 causes why you may get a large J sign. Either the patella is too high, which is called as a patella alta. So normally, if you have a normal height patella, it will engage in the trochlear groove around 30 degrees of knee flexion. But if it is patella alta, it takes longer, or it has to go through a larger arc, maybe 45-50 degrees before it engages, and that is why you get a large J sign. The second reason is that if you have a very shallow trochlea, which is called as trochlear dysplasia. In this, you can see that the trochlea is completely flat. You're viewing at the patellofemoral joint from a superior portal, and you see the presence of a large superolateral bump, and this was what this patient had got. he had a completely abnormal trochlear groove and a trochlear sulcus, and he required a full-fledged treatment of all his abnormal pathologies by performing a trochleoplasty. There's another talk on that later on, so I'm not going to go through the technical details. But what you're essentially doing is that you're removing the abnormal superolateral bump. You're going to restore the correct location of the trochlear groove, and in this patient there was an abnormal TTTG, so the full house treatment was handed over to him in the form of an MPFL, a tibial tubercle osteotomy, and a trochleoplasty. And this is what it looked like at the end. You can observe that these are the anchors for the MPFL. This is the distalization and medialization of the tibial tubercle, which is what we want. Very nicely, we've heard about the menu a la carte, in which you need to look at the abnormal factors, and once you look at the abnormal factors, you need to treat them, and this is what you will normally look at. What is important is the last scenario, in which we have this young girl. She's 11 years old. She has persistent bilateral knee subluxation since the age of 4. She's unable to run, unable to climb stairs, and she's got loss of confidence. What we see here in her case is that her patella dislocates in flexion, which is a lot different from what we just heard of. What we heard of was the patella which was dislocating in extension, and when we have an abnormal finding like this, where the patella dislocates in flexion, it is a different pathology altogether. What is really important to understand is that the reason why the patella dislocates in flexion are tight abnormal lateral extensor mechanism structures, and these structures are the one which are at fault and need to be taken care of, and that is what we see in this particular instance. You see the presence of abnormal bands and tight fascial slings, and these people require a combined procedure wherein you would perform an extensive lateral lengthening, release the entire lateral vastus lateralis of the intermuscular septum. You would do an MPFL to restrain the patella within the trochlear groove. You will also do patellar tendon split transfer, like the Rue Goldwaite in an immature skeleton, or a tibial tubercle osteotomy in the adult skeleton, and you may also choose to advance the VMO like what we've done, and this is how her patella now tracks central in the groove and allows this to run properly. So this is the patella that dislocates in flexion, and it is usually a problem of the tight lateral structures, which requires a completely abnormal different approach. So these are the 5 scenarios which you need to look into, and I think if you want to learn more, I'm going to also invite you to our next meeting, which happens on the 29th to the 31st of July, which will be 3 days of good academics, and of course very happy to present Professor David Dujour to all of you to understand patellofemoral instability even better. Thank you so much.
Thank you, Sachin.
Thank you.
Excellent presentation.
Thank you.
Can I ask you one thing?
Sure.
You would want to do arthroscopy and repair the defect, isn't it? Would you combine that with the Mpf reconstruction?
Yes, I would. I mean, you would want to correct all the associated anatomic factors which are wrong, and depending upon the severity of the abnormal anatomic factor, you would want to correct either one or all of them at the same time. This is essentially because you do not want them to come back with repeated dislocations, and if I'm doing surgery, then I think I want to sort out everything at one go and have a complete normal biomechanical function in that affected
What
knee.
would be your technical plan for the Mpf reconstruction, since now you have done an arthrotomy and reflected the patella lateral?
You close the arthrotomy properly, and once you've closed it, you make again incision between layer 2 and layer 3 and just do a normal Mpf reconstruction as you would normally do.
With a graft?
Absolutely.
Thank you.
Thank you.
Thank you.
Yes?
Yeah.
Yes. So as I said, it has to be a large fragment, it has to be in the weight bearing area, and you have to have subchondral bone on that chondral fragment, then only it will heal. If you fix a chondral flap, it is the chances of it sticking back and healing are extremely low. So in that case, you have to think of some cartilage restorative therapy. So I think just 2 days ago, I was in a similar situation with a girl who was 12 years old, had a similar problem, and she presented 2 months later, and there was no way I could reattach that back. So I've just removed her loose body. We've taken a cartilage biopsy for doing an ACI procedure. And once I do the ACI, I'm going to do all the corrective, sort of anatomical corrections at the same time in the second go.
Sachin sir.
Don't run away. 2 short questions, okay?
Yeah.
Yeah.
Sachin sir, fantastic talk as usual. My question is, in these recurrent dislocations for a long period, there is something with quadriceps, they contract and orientation changes. What are the quadriceps plasty types of things we can do with quadriceps to align the patella?
Yeah, so you can do corrections both on the proximal and on the distal part of the extensor mechanism. So essentially, if you have to break it down, you have to start with all the anatomic factors both inside the knee and outside the knee. The quadriceps is a muscle which will start proximally up near the hip and go down till the tibial tubercle. So essentially, the quad muscle changes because of abnormality in the bony morphology. It cannot develop abnormally, or it cannot have abnormal muscle problems. So if you are facing, or if you feel that the orientation of the muscle is wrong, look carefully. You could be having abnormal coronal plane alignment, or you could be having torsion either on the femoral side or the tibial side. And once you correct those bony problems, then your quad muscle will fall straight in line where it should be.
Okay, last
question. The common scenario is typically skeletally immature adolescent female with everything is there, patella alta and trochlear dysplasia. So with physis, tibial tuberosity apophysis open, what would be your approach in such case?
Yeah, that's a great question. Thank you, Sheetal. So what is important is that there is no role of bony surgery before skeletal maturity. That's one. There are some reports now. I don't remember who's doing that study. It's supposed to be, So they are started doing trochleoplasty in the immature skeleton, but I would best avoid it for now. In these patients, a good counseling of the child's parents that I'm going to do an MPFL to reduce the number of dislocations. I'm not doing a definitive treatment. And once you get skeletal maturity, then your child will require a definitive procedure in the next 5 to 6 years. If you just leave them like that, then they will continue to dislocate more, they'll damage more cartilage. So you want to do something that will decrease the number of dislocations and provide a reasonably stable knee. Yeah.
Thank you. I think, okay sir, last one.
Mpfl repair in first time dislocators if you're going in for...
Yeah, so the results of Mpfl repair are good if you do them in 2 scenarios. One, if it is a femoral sided tear and not a patellar sided tear. Second, if it is a patellar sided avulsion, bony avulsion. So in 2 of these scenarios, the results of primary repair are better than that of reconstruction.
Okay, I think we're overrunning time. The next is a case-based discussion. For that, we have
So all, one of the panelists is missing. Okay. So can I have my cases here? हाँ मैंने already दिया हुआ है. Yeah, sorry. So, Sagar, ready? Okay, so after an amazing talk by Dr. Sachin Tapasvi, who is a master, I'll be presenting few cases. Though most of the things have been covered, but I have nothing more to say, so we'll just start with the cases. Can we have this screen here also? This one. Front screen. Good morning, Raju. Okay, so I'll be presenting the cases on patellofemoral instability. So this is a picture from my master's book, that is a patellofemoral instability, Dr. Sachin sir's book, so which shows that patellofemoral instability is more of a calculation and more of a mechanics than biology. So I'll directly start with the first case. So it's a 19-year-old male, history of fall while playing basketball. It was not non-contact fall, and patella dislocated but then spontaneously reduced. There was pain and swelling in the knee joint, and he presented to the emergency. There was no past history of trauma, so it was supposedly a first-time dislocator. So this is our emergency picture. So there was a lot of swelling. We have given him the brace, few analgesics. It was painful and range was almost 0. Can we play this video? How to play the video? This is on click, but click it's changing this. So there was a lot of swelling, pain, range was almost 0, so we could not assess the range, and there was apprehension. So we can see the lateral patella was going laterally. And this was the X-ray done. This is an emergency X-ray done. So my question to Sagar, what will you do next after seeing this X-ray and the clinical picture?
I can probably observe a defect on the patella, somewhere right here, there, yeah, that's the one, and that brings me to the suspicion of there being an osteochondral fragment. And in that scenario, I want to go ahead and investigate early with an MR scan and with a CT scan, and then organize the further course of treatment. Yeah, so looking at the X-ray, because this was an emergency X-ray, patient was in pain, true lateral was not done. So, but looking at the X-ray, a small defect can be seen. So we decided to go for MRI, and this was the picture on MRI. So we can see significant size. I would not say that it's a very, very big, but significant size osteochondral lesion in the loose fragment.
in the MRI. So, Sagar, what will be your next, how will you proceed further now?
So you have any other images for the same?
I have, but I've not got it. I have this MRI.
Okay. So can I have the MR picture again, sir?
Yeah.
So I'd like to have furthermore axial images for this patient. Also would like to size the lesion in this patient. It looks like less than 2 centimeters for me.
Yeah. So this is, the size is written here. So it is 10.6 into 10.2 into 4.8 mm. This is the size which has been given to us by the radiologist. And rest as a standard TTT distance is 20.3, insult salvati 1.3, and trap depth is 4.6.
Yeah, so the patient definitely has got a significant chondral lesion is what I feel. I would go ahead and give this patient an option. I would like to get a CT as well for this patient definitely before going ahead with any surgical intervention.
Yeah. So, Tapasvi sir, what would you advise to the patient now?
So firstly, I think I will not rely on the MR scan. I need a CT because the size of the defect will be better seen on a CT than on an MR. The MR may tend to overestimate it. And why is this important? For two reasons. One is that if it is a small fragment, then I might just do an arthroscopy, remove the fragment, counsel the patient that he may get another repeated dislocation, and if so, he may require surgical treatment. If it is a small fragment but the patient is engaged in sports, then I might think of counseling him for surgical treatment. If the fragment size is large, then based on that I would then need to decide as to what sort of treatment plan needs to be organized. And if surgical treatment is planned, then I would think of doing a refixation of the fragment, one. Second, I would do the whole patellar indices, which looks at around 23 different measurements that we need to do on a CT and on the MR. And based on that, decide whether there is significant alta and whether there is significant alteration of TTTG. And based on that, I would then decide if I need to do a medialization plus distalization of the tibial tubercle in addition to the MPFL and the fixation of the chondral fragment. So I'm afraid I will need more information before I go ahead and decide on my surgical plan.
I think the consensus is clear that the fragment actually is much bigger than what it looks on X-ray and MRI. So CT is must, though I don't have a CT with me. And many measurements are here, like insult salvati is 1.3, TGTT is 20. So, so patient is for surgical intervention. So I'll just go ahead. So this is actually what we found inside. And what the fragment was this big and with a bone on it. So it's a osteochondral fragment. We repaired it with a Icrs number 1, and simultaneously because we have done superficial quads MPFL repair. So my next question is, what will you do for a MPFL when you are doing a mini arthrotomy? Whether you would go for a graft thing or a superficial quad thing, a semi-T or a superficial quad thing, sir? Yeah.
I'm sorry to say I don't have a lot of experience with this, but couple of cases that I have done the similar ones with superficial quads reflected upon itself and then put on to the medial femoral condyle.
I also same opinion, but sometimes we can do the gracilis graft for this, and then fix the as usual reconstruction.
Sagar.
So I personally have no experience with the quadriceps graft. There are papers by Lateral et al. Where they do double bundle MPFL with the same quadriceps. I usually do it with gracilis. I would have gone ahead with
gracilis. Now, word of wisdom from sir. Sir, what will your take on this?
I think it really doesn't matter what graft choice you use, whether you use a superficial quad tendon or whether you use a free gracilis. The results are same as long as you respect the anatomical locations and the isometry. You're bound to get a good result, no matter what graft you choose. Both of them are absolutely comparable. Nothing to really prefer one over the other. The only advantage probably of using a superficial quad in a position like this is that you already have the incision, you already have the exposure. That's one. Second, the implant inventory that is required is a lot less, so you can save on some cost if at all the need be. And the advantage of a superficial quad also is that it has got a flat orientation, which then allows you to recreate the normal geometry of the Mpfn.
What you would have done
for
this case, like when you are doing an arthrotomy, along with arthrotomy, you would like to do a CMT or maybe a hamstring graft or a superficial quad.
I would probably also do a TTO for him, looking at the other parameters, looking at the CD ratio, looking at his TTTG on the CT, because the TTTG distance on an MR and on the CT has got different thresholds, so I'd like to confirm that. If I'm doing a TTO or a tibial tubercle osteotomy at the same time, then I would probably harvest the gracilis, because I'm going to touch the distal extensor mechanism, so I don't want to fiddle with the proximal extensor mechanism. Otherwise, if I'm not doing it,
MPFL do have healing potential. You just close the medial arthrotomy, don't do MPFL reconstruction, you won't see. He's an 18-year-old, sometimes you may have 30-year-old patient who had come for first time traumatic patella dislocation with osteochondral fracture. 30 years he didn't have any instability, and this was traumatic episode. So I am stressing more on traumatic.
Yeah.
If it's an atraumatic episode, definitely add other armamentariums. But if it's a first time traumatic patella dislocation, I would prefer to only fix osteochondral fracture and do closure of arthrotomy.
See, Mukesh, what happens when there is a patellar dislocation? This is a basketball player. He's an IITN. He was playing basketball. He has come to Jaipur for holidays and he was playing basketball and he has a patellar dislocation. Now it is very difficult for us to say whether he got a trauma or he got a dislocation and he fall after that. See, patellar dislocation history is like that only.
That's what I'm saying.
Yeah.
If you have a proper traumatic primary patellar dislocation with osteochondral fracture, fix only fracture and no need to do, because I have a series of 10-12 cases where I have
in a Indian female patient, 16 years old.
So if you're coming to fixation issues, what is important to understand that the insertion site on the patella is a broad area. It encompasses around 4 to 8 millimeters in width. So you essentially use whatever you need to get that surface area. Number of anchors I feel is secondary according to me. Normally to get this broad insertion site, I will need to use 2 suture anchors if you're using a suture anchor technique. If you're using a 2-tunnel technique, even that is fine. If you're using a pull-out technique, even that is fine. So fixation for me is secondary. I think getting the anatomy restored is important. And to get that broad insertion site, I would prefer to use 2 suture anchors.
So once we prepare this area, we usually roughen up with the curate to get a bleeding bone surface and put an anchor. So usually in all the techniques, it has been advised to use a 2 because it has to be a broader insertion. But looking at female patients, what we usually use, we use a single anchor. We use a single anchor. We tie semi-T on one side, and then with the this is a double-threaded suture anchor, and with the one suture thread, we take whip stitches like that till the upper border. So with a single anchor, we make a what we call a pyramid kind of thing. So this is how it looks with a single suture anchor. Now that rest is the bead pin and short point. We pull it out from here and fix it with this. So for MPFL, evaluation and treatment on stability is continue to evolve. Thorough physical examination and accurate diagnosis are important. There are many different techniques, and MPFL is the choice of recurrent stability with or without trochlear dysplasia. Mukesh, can you come with the next thing? I'll sit here.
Since 2 years, 7 to 8 episodes so far. First episode was due to trivial trauma, felt jerked and fell down. Since then, frequent episodes of instability resulting into fall and nothing to do with any sports related or trauma activities. On examination, there was a positive J sign. Apprehension was positive at 0, 30 and 60 as well as at 90 degree of flexion. Q angle around 20, crack test was normal. Byton score was 4/9. Rest other things were quite normal. So that was his limb alignment. Some crossing sign was seen and there was a J sign seen, and the patella was subluxating even on flexion. If you can see that. Right? So these were his investigations, which was showing the trochlear depth of 1.6 mm, supratrochlear spur, lateral sublux patella, sulcus angle less than 145, TTTG was 21, and tight lateral structures. So let's start from Saurabh. How will you plan it now? And one by one, the planning.
So trochlear depth 1.9 is very less, so ideally it should be 3 or more. And TGTT is 21. Okay, so maybe looking at this initial assessment, I plan to go for trochleoplasty with distal realignment.
Okay. Next one, please.
Here we have to go, first of all, Mpfl reconstructions and bony procedure trochleoplasty And as TTTG score is more than 20, then I can go for the mineralization of the tumor velocity.
Okay. So no trochleoplasty for you?
Trochleoplasty.
Yeah.
Definitely.
Okay.
Yes, same. I would definitely go ahead with trochleoplasty, tibial tuberosity osteotomy and medialization, and the Mpfl for this patient.
Dr. Tapasvi sir, what will be the sequence? Now I think you agree with this?
TTTG is 21 on CT or on MR? MR. Okay, so 20 is the borderline.
Yeah.
Right. So I think for me this is only trochleoplasty with Mpfl reconstruction. It will be lateral patellar arthrotomy, lateral retinacular lengthening, subluxation of the patella medially, removal of the supratrochlear bump, and perform a conventional trochleoplasty. And as you come out, you repair the lateral retinaculum in a lengthened fashion, with the help of a Z-plasty, and add Mpfl on the medial side. My choice would be to use a free gracilis.
Nothing distally?
Nothing distally.
How you decide on table whether you really want to go distally or it's totally pre-op? We are going distally and proximally or both?
Here. One is that there is no alta.
Yeah.
Second, if you look at his lateral image, the patellotrochlear engagement index looks to be decent.
Okay.
Third is that when you do a trochleoplasty, you change the trochlear groove. So your TTTG, which is 21,
will come down.
If you do a new trochlear groove, it is going to be around 14, 15. I don't know how many millimeters you shifted the trochlear groove, but usually you need to shift it at least by 5 millimeters. So that's going to bring your TTTG on the MR scan to roughly around 16, which is normal. So I don't need to do anything distally afterwards.
Right. Anything you want to add, sir? No, sir. So with the consensus, same thing. So the plan was diagnostic arthroscopy, lateral retinacular lengthening, sulcus deepening trochleoplasty, TTT I have decided, I'll decide it on table after I do, even if it's subluxating a bit, and Mpfl. So this was evaluation under anesthesia, which was very lax subluxating patella even in high degrees of flexion. And that was a classical view from the superolateral portal, where you can see it's completely lateralized patella and it's not engaging the trochlea at all. And it's engaging the trochlea deep into flexion. So this was like an intraoperative J sign. And you can see a flat trochlea with a bump on anterolateral aspect there. So the first step is to just go and do lateral retinacular lengthening, as mentioned by Dr. Tapasvi, a lateral approach arthrotomy, where I just did lateral lengthening. I mean to say you have to cut the capsule posteriorly and the retinaculum little anteriorly, so you have to do the lengthening in the anterior-posterior direction. And then once you open it, you will see the flat trochlea, and you need to mark and shift the trochlear groove about 4 to 5 millimeters. And then to form a sulcus of 47 millimeters, and then you fix it with knotless anchors. Either you can use a Vicryl tape, as it was not available. I have used number 2 Vicryl. The first one goes just at the apex of the PCL, and the one lateral, one in the medial, and one superiorly. And that's what you see after you did your trochleoplasty, the groove well created. Now once I finished this, I did my Mpfl structures, fixed it on the patella and just hold it on the femur, and took the knee to full range of movement, and it was still subluxating, so I decided to add only medialization of the tuberosity. So did medialization as well as Mpfl reconstruction. That was on table, the range of movement and the stability of patella after doing all the procedures in one go. And that was the final intraop scopy, where you can see the first it was subluxating, and now the whole centralized patella with a proper tracking into the groove after doing all trochleoplasty, TTO, lateral lengthening and Mpfl reconstruction. This was his immediate post-op X-rays. This was 3 months post-op, which shows the parameters getting back to normal. TTTG came to 12 and the trochlear depth was more than 4 millimeters. And this is his 11 months follow-up, where you can see completely healed trochleoplasty, even tubercle, and there is no J sign at all in the patient. He is doing well. So complications, beware, patellofemoral arthritis is the biggest complication, so you have to be very careful while doing trochleoplasty. Thank you. All done? Yeah. Thanks for that session. Thanks the panelist.
With this, this patellofemoral
Yeah. So, good morning everyone. After the Patella session, now we move on to the next session, that's on cartilage. So, first we have a
vis-a-vis that is on ice, that it is 7 times more slippery than the ice. And it can tolerate large amount of stresses, and it is durable and can last for lifetime if it is uninjured. And the property of this is simply because it consists of 5% cells, that is the brick, that is chondrocytes, and 95% of the matrix, that is the mortar. But remember, it can be easily damaged, and the inability to heal the cartilage was known way back even in 17th century, and Hunter once quoted that once destroyed is destroyed forever. Coming to the imaging modalities, X-rays are the initial workhorse for finding out the early chondral damage if possible, and 45-degree weight-bearing PA Rosenberg view is of more importance as compared to simple AP stenting. And if we are looking for patellar cartilage problem, then various views described by in the previous session like Merchant and Skyline view has to be taken. The MRI is gold standard to find out the exact chondral lesion, and we should ask our radiologist to have a proton density FET suppressed T2 weighted images to exactly delineate the chondral injuries.
Well, there are many options, but before embarking on those options, we should remember that we must address malalignment and instability if it coexists. The best results of chondral repair or other treatment methods are in the patients with isolated traumatic chondral and osteochondral defects, remember, in an area without surrounding degenerative cartilage. So various classifications have been proposed for chondral injuries, but the most prevalent one is Icrs classification. Not going into the detail of this, it has been divided into grade 0 to 4, and up to grade 3 it's a low grade injury, and grade 3-4 is a high grade injury. We will focus on grade 3-4 injuries. The strategies to treat are basically divided into palliative, reparative and regenerative strategies. Remember the modifying factors, that is the anatomy, size, location and depth of the chondral injury, that is whether it is full thickness or a partial thickness, pathology, whether it is traumatic or any other pathology, epidemiology of that particular patient, whether about the age and the profession of that particular patient. The concept is that we have to match exactly what the defect is. These are the various strategies available currently and divided into 3 groups. The debridement, arthroscopic debridement and lavage, abrasion chondroplasty comes in the heading of palliative, microfracture and osteochondral transfers are reparative, and regenerative are autologous chondrocyte implantation and some other recent advances. Sorry. This video is not running. Anyway, so debridement and lavage is basically indicated for chondral lesions of less than 2 square centimeters. Remove loose cartilage fragment and give a thorough washout of the joint. It is good for low demand elderly patient who may not tolerate prolonged immobility, and it is considered palliative, yet there is a quick recovery with quality of life improvement. Yeah, thank you. So this is what is the debridement and abrasion chondroplasty. Coming to the main workhorse, that is the microfractures. In this procedure, the lesion is debrided to stable, squared off edges. Zone of calcified cartilage is removed, but remember subchondral bone is preserved. The cortical penetration leads to medullary bleeding and superclot formation. Leave about 3 mm of bony bridges in between and avoid confluence of holes. The surgical awl needs to be perpendicular to the subchondral plate, and the defect it fills with the fibrin clot. Remember, vertical walls are the key, which reduces shear and compressive forces. The healing response is because of the clot formation, in which the undifferentiated mesenchymal cells mature to yield a fibrocartilage repair tissue, and there is a vascular ingrowth as well. The tissue is mainly type 1 collagen comparative to native hyaline cartilage, which is type 2, and it has got an inferior stiffness, poorer wearer characteristics than normal hyaline cartilage. There are multiple studies on the outcomes of microfractures. A very notable study of Stedman published in 2003 that 80% of the knees with isolated post-traumatic full thickness chondral defects improved at an average follow-up of 7 years, and there is a literature review of about 28 studies of more than 3,000 patients, which shows that there is a clear improvement of knee function at 12 months, but inconclusive durability at greater than 2 years. Coming to osteochondral transplantation, in which the technique harvests viable structurally intact cartilage and bone plugs from the less valuable portion of the joint and transplanting to the site of symptomatic cartilage injury. It could be an allograft or an autograft. Commonest is autograft, and there are 2 terms, mosaicplasty and oats. The mosaicplasty has the term given by the company Smith & Nephew, and oats, the term has been given by Arthrix. It is good for intermediate defects up to 4 to 5 square centimeter. And this is a small video in which you harvest it from the non-weight bearing area, and the cylindrical osteochondral grafts of about 12 to 15 millimeter are harvested and transferred to weight bearing area in a non-degenerative knee. Remember the thing. The best results are for a smaller lesion like less than 2 centimeters, and good results are for less than 4 centimeter square lesions. And it has been found that about 90 to 80% good to excellent results in mosaicplasty or OATS in various studies. It is useful, the allograft, when the defect is larger, the allograft is useful for the larger lesions more than 3+ centimeters square, but typically it is a second line treatment because of tissue matching, immunosuppression and chances of infection. We still don't know that what is the exact formula to reproduce normal hyaline cartilage, but amalgamation of stem cells, growth factors and the matrix makes a holy trinity. Hopefully someday, sooner, we will come with more certain answers to this long lasting problem. Coming to the autologous chondrocyte implantation, the cells, healthy cartilage cells, are isolated from non-weight bearing area, expanded in vitro and transplanted to the defect, covered with the periosteal flap. The main drawback is it is two-stage, bit costly and requires some time interval to heal. And this is a pictorial depiction how you do that. Take the cartilage biopsy, send it to the lab, grow the chondrocytes and put it under a periosteal flap and suture the periosteal flap till the chondrocytes mature. They have been divided into 3 generations. The first generation, the periosteum is taken to cover the defect. Second generation, collagen membrane is used, and in third generation, a scaffold is used to cover the chondrocytes. The drawback of first generation, since we are using the periosteum, is graft delamination, ectopic calcification, at times graft hypertrophy, which can produce a mechanical symptom of catching and locking. The second generation combines scaffold and cultured cells, and this scaffold provides structure for chondrocyte adhesion, expansion while maintaining the chondrocyte phenotype. Can be used to treat relatively large chondral defects, and various collagen material is available in the market by various pharmaceutical or implant companies. Third generation is matrix induced autologous chondrocyte transplantation, in which the healthy chondrocytes are transferred to a matrix in the lab, and once they grow, the matrix is cut to the size of the defect and sutured onto the defect. The fourth generation has a large question mark, in which the neocartilaginous tissue grown by the help of tissue engineering is used and available abroad with the trade name of NeoCart or NovoCart, but has got a very short term outcomes, and we don't know the final results yet. Some other procedures have been described in literature, that is minced cartilage. That is, one is cartilage autograft implantation system, in which the autograft is minced and mixed with biodegradable scaffold and sprayed over the chondral defect. Another one is PGCAT, Pediatric Juvenile Cartilage Allograft. An allograft has been taken from a less than 13-year-old children and mixed with fibril glue, but they have limited long-term clinical data. Remember, the return to sport by cartilage restoration surgery had about 80% return to sports at mid-term follow-up. The OATS offer a faster recovery and appear to have a higher rate of return to pre-injury athletics. Athletes may return to sport participation after microfracture, ACI, OATS or osteochondral allograft, but the microfracture patients were least likely to return to the sports. So the take-home message is that we still don't know the exact answer. Microfracture remains indicated for smaller defects in low demand population. Scaffold seems to improve the microfracture outcomes. OATS may provide more rapid improvement in terms of clinical outcome than ACI. The ACI may provide a more durable repair tissue if the defect is larger. And do not forget, when you are dealing with chondral defect, about the malalignment, the instability issue and the meniscal lesions. This is the busy slide which tells us about the basic criteria for what to do in the size of defects. We will cut it short. We will just discuss grade 3 and 4 chondral lesions. If the defect is less than 2 centimeters square, microfracture plus minus augmentation for a low demand elderly patient, and mosaicplasty for a high demand patient. If the defect is 2 to 4 centimeters square with bone loss, then a mosaicplasty, and if it is without bone loss, then ACI. If the defects are larger With bone loss, then again osteochondral allograft is the treatment of choice, and if the surrounding bone is intact, then ACI is the treatment of choice as of now. So there are various studies. We need to customize the solution as per the patient demand, and we should keep an eye over the horizon what next and latest is coming in this particular field. And thank you very much for your kind attention.
Thank you, sir. So any more questions from the hall? Maybe we can take 2 or 3 questions. Sir, I just want to ask one question. Have you ever got any chance to do a revision scopy and see how these cartilage lesions healed up anytime?
Yeah, not all the patient did do consent for revision arthroscopy, but few, of course, they heal, but not exactly as a normal pristine hyaline cartilage, with some sulci and gyrations are still there, and on probing there are certain amount of delamination is still present. So they do not heal to that normal potential. Yes, the oats, the cylindrical plug which we put, they heal properly, but there could be an interval between the 2 oats, and that particular area is bit rough.
Okay.
What is your take on donor site morbidity in the mosaic plasty? And to what extent you can take the plugs from the areas?
Yeah, so good question. So if we can take a cylinder of around 12 millimeter, we can take 2 to 3 cylinders at the most from the donor site. Depending on the size of the knee, of course. If the knee is bigger, then you can take 4-1 also. Otherwise, you can fill the defect with the cancellous bone graft, and some amount of fibrocartilage may develop on the top of it.
Do you ever go for the opposite knee also if the grafts are inadequate?
It's very difficult to convince the patient to take a graft from the opposite knee. One can go for that if that particular knee is, the graft is not okay, there is some degenerative changes, then you can go for the opposite knee.
Just to, my queries, is there ACI is being done in India or any of the centers?
Yeah, many centers. Exactly. Thank you.
Yeah, thank you. So now we move on to the other lecture, Ward's Indications and Techniques by Dr. Gautam Gupta.
Yeah, thank you. So I will be discussing on the indication and the technique of this Oates procedure. So the indication is very clear cut. It should be a symptomatic focal osteochondral defect. The size of the defect should be 1 to 2.5 centimeter in the diameter. And this defect must be grade 3 or 4. Once we have the correct lesion for the surgery, we must find the right patient. And the right patient is one whose BMI is less than 40, age is less than 50. There should not be any arthritic changes. For example, in case of knee, it should be grade 2 as per the KL scale. And any infection or inflammatory arthritis must be excluded. Now we have the right patient and the right lesion. Now we have to, before jumping to surgery, we must check something. We must address any malalignment issue, either in the tibiofemoral junction or the patellofemoral joint, any ligamentous issue or the meniscal problem. If these are present, this should be dealt either before or at the time of Oates procedure. Because if you don't do this procedure, our Oates procedure will fail in long time. Now the technique, coming to the technique of the surgery. To my mind, this technique is very similar like doing an uncemented acetabular cup, where you create a socket and then you press fit the acetabular cell. The primary stability comes by press fit mechanism. So this you will find the Oates is similar to that. This can be done by arthroscopic means or by arthrotomy means. That is by open technique. When we are doing arthroscopy, the first step of the arthroscopy is to access the lesion with a spinal needle, whether we can access the lesion at 90 degree or not, perpendicular or not. If we cannot do that, we must conclude arthroscopy and resort to the open means. So the open means, we can do it, it is preferred if the lesion is larger or it's posteriorly located. When this graft can be a single plug or it can be a multiple plug. When we are using more than one plug, it's called mosaic plasty. Now coming to the instrument set for the oats, there is one harvester. This is donor harvester. It comes in different size, 6 mm, 8 mm, 10 mm. Then we have recipient harvester. With this harvester, we will create a socket at the defect site. Then we have got alignment rod. With this alignment rod, we will check the alignment of the recipient socket. And then we have bone tamp. This bone tamp is used for this final setting of the osteochondral graft and fine tuning of this graft. There is a graft delivery tube which is transparent graft delivery tube, and there is a insertion device. Now coming to the steps, it can be broadly divided in 4 stages. The first stage is to measure the defect. Once we know the defect, size of the defect, we know how many graft do we need, what size of the osteochondral graft we need to harvest. The second is the preparation of the recipient site, and third and the fourth and the final step is the implantation of the graft. Now coming to the donor site identification. The donor site, it should be from the low weight bearing location, and the curvature should match the recipient site. And in case of knee, this is we can find this site at the trochlea, the superior medial aspect of the trochlea and the superior lateral aspect of the trochlea above the sulcus terminalis. And the lateral intercondylar notch can also be used to harvest if the osteochondral graft we need is 6 mm in diameter. Now coming to the graft harvest, for graft harvest, the donor harvester is placed perpendicular and flush with the articular surface. It is impacted with mallet till 15 mm. Now once we reach the 15 mm, we turn 180 degree to disengage the graft. For multiple harvest, we need a separation of 2 to 3 millimeter. Coming to the video, this is an open technique and this is an arthroscopic technique of harvesting. You can see my harvester is perpendicular and flushed all around. We are hammering in and going in till the depth of 15 millimeter. Once we reach to the depth of 15 millimeter, we can disengage the graft by rotating it 90 degree clockwise and 90 degree counterclockwise. We can also do it in some other fashion. Here we can also apply a little bit of force in the sagittal and the coronal plane. The graft can disengage. Once we take out the graft, we must check whether it's flushed with the harvester or not. If it is flushed, that means 15 mm of graft have been harvested. Now coming to the recipient site preparation. For recipient site preparation, we need a harvester which is used to create a socket. We remove all the sclerosed bone and we need a fresh bleeding bone all around. The harvester is inserted about 2 millimeter less than the donor graft. This is a video presentation. So my recipient harvester is placed perpendicular. We are going till depth of 13 millimeter. Once we reach the depth of 13 millimeter, we can disengage the bone plug from the recipient site. This bone plug can be used to fill the defect at the donor site. Now once we remove, we check the alignment of the socket with the alignment rod. And the final step is graft implantation. For graft implantation, we have to make 2 changes to the graft harvester. We have to fit the graft delivery tube, the transparent plastic tube, and we have to insert the graft pusher. With the graft pusher, we have to make the graft flush with the delivery tube. Here we have to go very gently. We cannot we should be dead perpendicular to the socket, in line with the socket. The insertion force should not be more than 400 Newton on a 8 mm graft. This is theoretical, and practically you should be very gentle and should be give slow, gentle hammer to the graft. Once we remove the harvester with the bone time, we can do the final sitting. This graft should be flush with the surrounding articular cartilage. It should not be proud. If it is proud, there will be necrosis. And if it is too much countersunk, more than 2 mm, again there will be necrosis due to lack of stress concentration over the graft. So the post-op protocol is like that. We give immediate full range of motion exercise. Patient is kept non-weight bearing for 2 to 3 weeks, and we allow partial weight bearing for another 2-3 weeks. In 6 weeks, patient can bear the weight. Thank you for your patience here.
Yeah, thank you, sir. So any more questions from the floor? Till how long you tend to perform this procedure, sir? Right from the injury to maximum time to do boards? From injury to the surgery time? Is there any time indication or a time limit?
There is no such time limit, sir, to in my knowledge.
Okay.
We can, when we get this patient, we can do it the surgery.
So you do a single stage procedure, or initially if you assess the patient and do?
No, we have to assess. If there is any ligamentous issue or cartilage issue, we deal with it.
Right. Thank you.
Thank you.
Thank you then. So now we'll move on to the panel discussion on the cartilage lesions. Now I call upon Dr. Santosh Shahanand to take over the chair.
And shall I call upon Dr. Basu Malik onto the stage, please? And the other panelist for this cartilage session, Dr. Sudeep Vaidya, please. Dr. IPS, please. Dr. Arnab Karmakar. Dr. Sushil Tapa. Dr. Sushil. Yeah. So I had good set of cases. I thought the morning session was on Patella, so we'll cover the Patella, but Patella has been quite well covered in the previous 2 talks. And other cartilage session, the talks on panel and oats and overview also had covered significant part. So we'll try to keep it interesting and short. Hope I can take till 11, 20 minutes. So we'll see 6 cases. This is the case of the right. You see the scenarios, the age, grade of the lesion, and the size of the lesion and location and the activity level. This will guide you in cartilage decision making. These are factors which are very important in deciding what you do. This is a case which you've already seen. It's a repetition. If there is a patella instability and there is a bone defect fragment. I'm not going into the details of this because I think we've covered enough in the previous discussion. Only thing I would like to ask from the panelists, what is the size which you would say whether you need to fix it or you will just discard the loose body? When do you fix it? When do you discard the loose body? It's open for anybody. Just as a discussion point, because that message has to be conveyed.
I think it also depends upon the size of the knee, the size from where the defect is actually coming off. So if you talk about the patellar defects, you could actually excise if it is maybe less than a centimeter or so. But if it is coming from a weight-bearing dome, probably then the size would change. So I think anatomical location of the size is important, and also the size of the parent knee is important.
So approximately more than a centimeter,
Yeah.
with the osteochondral fragment, try to repair it. That's the message over here. And the sutures are good enough to repair these lesions, as you've already seen. So as this was covered, I had to just put in another case, which is case 1.1. This is a case where it's a young 20-year-old male with a grade 4. He is come for an ACL reconstruction, and there is a concomitant medial femoral condyle grade 4 10/10 defect, and his activity level is quite high, where he plays recreational badminton. And you can see the weight-bearing X-rays, which seems to have a good alignment. That's the defect which you can see. And but if this is the fragment, and if this is the grade 4 defect, what would you do in your practice? What are the options you have for each of the panelists, please?
I think it seems more like a cartilaginous defect rather than an osteochondral defect. It's more like a peel off of a cartilage. So I can either do a microfracture, but his activity level is pretty high, so we can go for a single osteochondral plug, like an Oates, that would work.
So as you can see, my video is open. Okay. The edges of the defect, there is a small flap over there. If you elevate the flap might peel off. So I decided to add another cellular procedure to the osteochondral. Adding a cellular procedure to the mosaicplasty would probably give a good contour along with the good base over there. I would like to ask other panelists, Dr. Sushil, in your practice, what are the options you have, and in such defects, what do you do?
I got two options in my practices. The edges I squared off on one part, while on the other part the edges look quite lacerated, so I want to square up other parts as well. So I go for marrow stimulation procedures like microfracture, number one, and whenever I have the facility of mosaicoplasty, I go for about 1 or 2 plugs in this case.
Okay. What about Arnab?
Yeah, same.
Well, something I like to add, this 1 centimeter by 1 centimeter is something that we can't predict preoperatively, because we go in, you see that defect and you see the delamination. You have to take off all the unstable cartilage, and then you're probably left with something which is 2 centimeter by 1 centimeter, or maybe 1.5 by 1.5. So that might actually change the plan of management that you have gone in with.
Yeah. In this case, we were able to pick up with the MRI well, but in our practice, most of the time when we go in for an ACL, we do see surprising lesions like that. In those cases, we might not have the BMAC or the cellular procedures ready. In those situations, how do you deal with this?
For me, Oates is the default procedure.
Okay.
Microfracture, I'm not a bigger fan of anymore.
Okay.
Oates is the default procedure. If we can't get through Oates, then maybe think of other things.
Okay.
So even for large defects, we have done Oates and we have been happy with it.
Hypothetically, if we are not prepared for Oates, or if you're not having the set,
we are always prepared with Oates.
For benefit of other delegates.
For the benefit of the audience, this is a one-time investment for next 10 cases. Though the company would say that it's use and throw, if you get one which is 10 mm, you're probably going to use it for 10 cases. So don't throw it away. Keep it with you. It's going to serve you at multiple places. So
if at all they don't have it, is it okay to come out and plan it for a stage 2, or is it advisable to do a microfracture, come out and see later?
No. There's a strong literature contraindications that if you're planning an Oates, don't do a microfracture.
Okay. That's the message.
So probably go back and do a microfracture at a later stage, but don't do do an Oates at a later stage, but don't do a microfracture.
Okay. Sure. The edge, as all of them had told, you need to make the edges stable. if I keep debriding, the medial edge would be off. Then I had a cellular procedure over there available with me, so I wanted to keep the native flap over there. Because this is fibrin, I was able to stick the flap probably by adding this one.
So does it heal? What's your experience? Does it heal? You might add some fibrin, it might look good on the table. What's your follow-up MRI and all that?
Small flaps do heal.
Okay.
Just not this clot. There's additional clot going to form after some time. When we release the tunicate, you do see a bigger flap over. The only thing, we need to mobilize the patient a little early, otherwise there will be stiffness. But by mobilizing, that flap must be stable when you're mobilizing. That's the only concern when you stick it with fibrin glue.
No experience with this.
Okay. I'm with just 2 plugs, the contour, I'm not very happy with the contour of the couple of plugs. By adding this, I believe there is a better contour which we can give. I prefer, in this case it's flush. When there is a larger lesion, when you are placing 3 plugs, I prefer to sink it in slightly, so make sure the contour is not, okay. When we add this, I believe the contour is slightly better, but I cannot say with the results whether this is definitely better than without the cellular procedure. Put 1 plug, yeah. As this was available, I just had the luxury to do it, I would say so.
But I think most of us still follow microfracture. In practical life, we have to come out with microfracture. So whether only single fracture, which is there now, or multiple fracture at the edges, what's your take on that?
We have few more cases. I want to cover that point after. So we will cover those points with the next few cases. So in this case, we move on where the age increases. It's a 45-year-old female homemaker. We move on to the patellar lesions now. Lesion is the medial facet, edge of the medial facet. This patient had actually came in for a medial meniscus flap, and this was a concomitant finding where this clinical scenario, she did have pain on the retropatellar area with the retropatellar tenderness and pain on sitting in stack climbing along with medial joint tenderness. So you can see the defect over there. And if it's in such a scenario, what would the panelist feel and what would the management be? This is not the isolated problem. She had a median meniscus, which went partial median meniscectomy, and a medial grade 4 defect at the edge of medial facet. Dr. Sudeep?
What was her radiological finding on X-rays? Does she have previous osteoarthritic changes?
No. There's no joint line, joint space reduction, or there's no varus. It's neutral alignment. And lateral structures are not tight. It's pretty lax.
Okay. BMI is?
BMI, I would say, her activity level is low. BMI is less than 28.
Okay. Since she is 45, I would just go with the abrasion locally.
Okay.
And rehabilitate with the physiotherapy.
Okay. Dr. IPS?
So there are some studies coming up where you can actually use your shaver to get some cartilage out of maybe intercondylar notch, and then it can be preserved in something like a mesh. So this is meshed cartilage from the patient itself, and combined with the glue, you can actually implant it back. So there are studies in a low demand people which are going towards age of 40, 45. You can actually go ahead and do that. It would require a small micro arthrotomy. You can open it up, clean the defect nicely, take the meshed cartilage, and then implant it like that. So it might work as well.
Okay.
This is medial facet.
Medial facet. That's why I put the Mpfl over there. If it's in the edge of the patella, would such how do you contain the material which we place it inside? Fibrin glue and place it. Okay. Dr. Adna?
It's not a weight bearing right now. You don't allow flexion or shearing to happen. It sticks there and the cartilage starts.
Okay.
Especially in the not weight bearing area, it works.
Dr. Adnab?
Yeah, maybe for this patient with this profile,
maybe we're not going to do anything.
Anything.
Maybe we
Just,
press it here, because
yeah,
you have
because it's
already done the meniscal part that may help her to
just rehab.
resolve the symptoms.
Okay. Dr. Sushil?
Well, this looks like a chronic cartilage defect, and she's a low demand patient. So I'll of course go for abrasion chondroplasty.
Okay. Anybody for microfracture or microdrilling? Okay. Okay. What I did was micro drilling. The problem over here is accessing this part with micro drilling is very difficult. Here, this is a way which I am able to do it, where you go in from the gutter, and you need to flex the hips, raise the knee above, and when you access from there, you could get the wires. If it's in the edges, you can sublux the patella to some extent, and you would be able to drill few holes and get few access channels. Slightly better than leaving it alone, but micro fractures you would skive off and you'd make big holes. So micro drilling is slightly better.
Just a point here. I mean, patella is more like a flat bone. It's a sesamoid bone, unlike our normal bones which have got a medullary canal. So in that normal femoral condyle, probably micro fractures would work. It usually doesn't work well in a flat sesamoid bone. You don't get that amount of bone marrow coming out from there.
Yeah, role of microfracture I want to discuss in the next case. So this is a high demand national level basketball athlete who already had issues with the jump, and she was not able to go for a layup. She had already underwent microfracture 18 months back. So it's a 22-year-old, activity level is quite high, around 15/15. That's the MRI, 18 months post microfracture, and still she is not able to train or run. So what would be your options? Dr. Basmalik? This is what exactly you had told, not to do a microfracture, so that's the case.
So this now I think is slightly difficult. So we'll have to do some kind of a cartilage procedure. I'm not very sure only micro drilling is going to work or not. Maybe think of some matrix based cartilage procedure and hope for best.
Okay, some cellular procedure. Dr. IPS? So
it's not the answer. It's the best option that, it's not the answer. We don't know whether there is an answer or not, but the best option is a cartilage procedure.
Because she was keen on getting back to the sport, and she is 22 and she's not able to go back. So that was done. As you can see, that was a two-stage procedure. She was given the option of one stage and two stage. Two-stage ACI results slightly better than in a BMAC in such revision scenarios. As you can see over here, that's a patellar defect. So how would you approach this? That's the question. The case is how do you approach this situation? Do you do air insufflation for cellular procedure?
Do this open.
Open. Okay. Open. Okay. Okay, this is an arthroscopic way of doing it. Prone position, as you can see here, that's why that dependent first one is the first layer, and the second image shows the second set of injection given under the first layer, so you can fill up a good gel which stands out. And this was done on pronoscopy. As you can see, this is the prone position, and this is described by Reynolds-Seabolt, and it's already there in the literature. And that was the initial defect, which was freshened, debrided, and that was the final picture in the right. So it can be, because she was high demand, I was a little concerned about a fully open procedure. This can be done open. This can be done supine also, but only thing, sticking the gel onto the roof is slightly difficult. Getting a good contour is slightly difficult. And dry scopy, again, getting the space. Reynolds-Seabolt has given a good description of adding weights with threads around the patella to create more space and area. Carbon dioxide air insufflation will actually help and give more easier technical results.
Santosh, going back to your previous case, what's the evidence of micro drilling in patella defects?
No, evidence-wise, it's no big difference. Shall we discuss that later in the next?
Yeah, sure.
So, yeah. In this case,
situation, you are doing redo, so is the patella getting too much pressurized? So should we anteriorize? Any role?
Yeah, there is a role, but her measurements were okay. Her CD index and TTTG was fine. Again, as you were asking, we'll move on to this is the 2 years, 18 months follow-up MRI, and she started jumping, started her, she's not yet into the elite level, she started training and she is able to get back. So, we see it seems to be a good result. I was also concerned and whether she would get back or not, but she seems to be doing well. So again, we'll move on to a younger individual with high activity level. As Dr. Mukesh was asking, this is a cartilage defect with a CD index ratio of 1.2. Her TTTG was 22 on the left side, which is the affected side. Unlike the previous case, which the TTTG was fine, here TTTG was 22. So what is your cutoff mark for doing a tibial tuberosity transfer in the absence of instability? She does not have an instability. This is purely for a cartilage unloading procedure. So do you have any cutoff mark, or Dr. IPS? But there's no instability. Yeah, that's a tricky.
No, but
Dr. Mukesh.
this TTTG is for mediolateral instability. I'm
Correct.
talking about anterior-posterior, where you have to anteriorize the
Correct.
tuberosity Mpfn procedure. I don't know whether this parameters will help in anteriorizing it. It's, I think, more of a clinical and finding out whether it's on both patella or trochlea, both. Then
Exactly. It's an intra-op decision, actually. As you can see, this patella engaging sign, or they would call it the Patellofemoral index, the amount of area overlapping in the, she had specific pain when she was in 20 degrees of flexion, she's not able to jump. So at 20 degrees in closed chain activities, she had pain. So at that 20 degrees, if you correlate and see, we have a tracking dynamic CT study where you keep the knees in various flexion angles and study at what angles which part engages, and it seems that part was engaging. So we went in with the plan to decide to do a medialization or distalization depending on which part engages on those 20 to 30 degrees of flexion. And in this case, we did do it supine because I need to do a lot of tracking study and decide, and planning for a osteotomy. Prone is not a good way of doing it. It was done, and it was an anteromedialization. So anteriorization as well as medialization. So TTTG was reduced. I did add a distalization of 0.5 because of it was engaging at those angles. It was inferior part. So distalizing it did unload, seemed to unload that part of the cartilage. So this osteotomy is not for instability. It's purely an unloading osteotomy, like an HTO in a medial compartment. This is an unloading osteotomy to take off the load of the patella, especially in these high demand individuals. Unlike the previous case where she didn't have these change in parameters, I didn't want to mention them. In this individual, there were significant changes, and asymmetry was there. So which means that's why she is symptomatic on this particular side.
Santosh, has this patient gone back to sports?
Not yet. She is running, but not yet into the jumping.
Is there any literature on this of how these athletes do post tuberosity osteotomy? Because we don't know, athletes don't do well after an HTO. It might take away the pain,
Correct.
but it also takes away a lot of their skill and proprioception and jumping activity. So I've got no idea how these athletes do. Might take away the pain.
Yeah, French literature is there where they say they have good outcome and return to sport is possible. But in this particular individual, she's not gone back to that level, but she's been 12 months post-op, so I need to follow up. And, but symptom-wise and daily activity, all that is fine. She's able to run, so we didn't want her to get back to jumping quite soon because of the osteotomy over there. So we need to wait and see what happens.
Have you thought of measuring these parameters on her other leg?
The other leg was normal. TTTG was 16. So there was asymmetry in this case. Okay, moving on to the next case where it's a lateral patellar defect. So far we have seen majority of medial patellar defects. It's a lateral patellar defect. Age is 55. Again, lesion is a large lesion and activity level is less. We had gone in again for the medial meniscus flap. MRI was showing slight patellofemoral arthritis. There was lateropatellar tenderness, but this is for the meniscus which we went in. But when we went in, we were slightly surprised to notice this grade 4 trochlea in the lateral facet, and lateral tightness was there, but didn't expect to find such a grade 4 large grade 4 defect in the lateral trochlea. Patella was fine. Patella was hardly grade 1, but trochlea was grade 4. In such situations, what would you do, Dr. Varnab?
Maybe 55 it looks arthritic. Yeah, I'll go for microfracture.
Okay, in the trochlea. Okay. Yeah, here comes discussion where in the patellofemoral role of microfracture, Dr. IPS, role of microfracture in trochlea versus patella.
Yeah, I think this is the right area where probably microfracture is going to work.
Okay.
And I was with Brian Cole last year, and we were discussing about such defects, and he would actually add on microfracture and then take a BMAC, and after cleaning everything, he would just inject a BMAC, and he says he's got a very large series now with trochlear defects like them, and got follow-up with an MRI. Never sure whether microfracture was filling up that cartilage or BMAC is also adding on. So it's just a blind BMAC injected into the joint, which would bathe the joint and probably take care of.
Okay. BMAC from the same microfracture holes?
No.
Oh, okay.
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 I mean, you take 2 millimeters below, 2 centimeters below, just take the bone marrow.
So literature-wise, they just mentioned patellofemoral joint, but doing a microfracture in the trochlea has access to good marrow channels. But does that same thing happen in the patella is questionable. But I'm not sure. I just wanted to try micro drilling because I believed micro fractures are not possible in the patella, getting those angles right. So probably with this small holes, probably they would have some relief. I'm not sure. So
do we need to correct the alignment in this patient?
Alignment, this was the alignment X-ray. Yeah, I didn't think alignment correction was true. Lateral structures were tight. There was lateral patellofemoral compression syndrome. So what Dr. Sudeep, what else would you prefer doing for unloading the lateral side? Would you prefer doing an addition?
Maybe I'll take the weight bearing scanogram and decide to what extent the angle is, which is a varus or not. If it is a significant varus, maybe I'll try to correct the alignment with the...
Okay, what about the retropatellar pain, patellofemoral pain?
I think in my setting, microfracture is the only way to go. Okay,
Dr. Basamalik, anything you want to add to the, as the lateral structures are tight?
Yeah, I don't think I've got enough information from all this thing, but maybe I'm just thinking there's a possibility of doing arthroscopic lateral release to some extent.
Thank you.
Take off the lateral pressure.
That's what I did. Microfracture added with the arthroscopic lateral. As you can see, as you're releasing, it pops out and good widening. So tight lateral structures. So as you can see, as all the structures are released, that itself was the cause behind. But now the argument is, what about lateral release versus lateral lengthening? How many of you try doing lateral lengthening?
In this case, maybe for patellar instability, yes,
okay.
but this one I think release is enough.
In this age group, when it is tight, just the release alone should be sufficient, and that's the message which we want to give over here. Probably the lateral release is giving the pain relief. Microfracture is just an additional blood access so that some healing takes place over there. Here I cannot say is it good or not. We just adding, that's why I spaced it out. Microfracture drilling is also spaced out widely so that it does not give too much of pain.
So I have a question.
Sure.
That micro drilling and microfractures, do they work in these osteoarthritic knees?
When you are adding as an isolated procedure, not I wouldn't say yes. When you are adding it with the other procedures,
because here I think lateral release would be a better option. Microfractures just.
That's what.
I don't think it would work in an osteoarthritic knee. That's my take on it.
Santosh, I agree, because we don't have much options.
Options.
Once you see the cartilage lesions in this age group, we don't have much options other than doing microfracture. But we know that it is not going to work, because we see the surrounding cartilage. It is so thinned out. The figure which you have put a video, even the defect around the cartilage is completely thinned out. So it's basically a degenerative joint.
But the other joints, medial and lateral compartment, is very good.
Very good.
Very good. That's
but
a
you
surprise.
see that the whole trachea area, both medial, either side of the medial to the medial and lateral to the trachea, is completely thinned out. So basically, it's a degenerative patellofemoral arthritis. So this procedure is for our satisfactory. We are doing a microfracture. I don't think any evidence to show that it is going to work. I always, like this patient, I will say that this is not going to work. Except your activity modification, you should avoid your knee bending beyond 50 to 60 degrees, squatting, climbing staircases has to be avoided. Only the lifestyle modifications can cure the patellofemoral arthritis, because we don't know the other solutions yet.
I think just one more technical tip is that if you want to do subchondral drilling on the patella, you were mentioning that you can't get those angles. I use flexible reamers, the ones that come for drilling ACL femoral tunnels, and they will help you get all these angles pretty easily if you're doing subchondral drilling.
Your take on drilling the patella, sir?
My take on doing subchondral drilling?
On
yes,
patella.
Young people, good, stable, healthy cartilage, good. Traumatic. But for older people, activity modification, injections, and if they're still painful, then do an isolated PF replacement.
Okay. So
PF replacement will give you much more better results than doing all these biological procedures.
So when you do a PF replacement, how long do you tell the patients longevity of
15-year
template?
survival is around 80%, 85%, and they get back to decent quality of life.
Okay. So then.
What's your indication for doing a PF replacement? When do you take the call that this is a case for PF replacement?
So good
and not a cartilage procedure.
Good tibiofemoral joint, kissing lesion, both patella and trochlea, grade 4 lesion, correct? And you've tried conservative treatment, it has failed. That would be the ideal indication to do a PFJ.
And is there any age cutoff you have in your mind? At what age you
obviously
plan?
You don't want to do it for someone who is 70 years old. He'll be better off with a total knee rather than that. But someone who is younger, to buy time to bridge.
So maybe between 50 and 60, is it?
Around 50 to 60, 65 would be a good time to do it.
Any other options apart from PF replacements?
One more question. Yeah. Like when you have isolated patellofemoral replacement, like when you were in Australia or I was in Australia, I used to see a lot of patellofemoral replacements. Then because a lot of complications, early loosening, many people left out of doing a patellofemoral arthroplasty. So what are the complications? The design modifications or?
So if you see, there's been improvement in the designs now. What we had then and what we have now are different. And now with robotics, it's even more better. You can do a far more precise, get the trochlear sulcus properly and do a good inlay technique, which is really very useful.
The hypothetical scenario where it's a 45-year-old lateral facet, full-blown arthritis, bone on bone. Is there a role of lateral facetectomy, osteophyte excision, or something like that?
No matter what you do, they are not going to be very happy, if you ask me. And I think it's very important that we have this discussion that surgical treatment is going to help you maybe 5-10 years. Again, you're going to land up with pain, and it's something, as has been suggested, activity modification, lifestyle modification, weight reduction, and all those things still in my clinical practice will take up 90% of treatment for patellofemoral arthritis. Very skeptical to start offering them surgery straight away, even things like AMZ and all. Try and stay away, because suddenly the expectations change, and we still don't understand why there is pain from PFJ arthritis. There is a neural source which is very, very, very predominant. There is osteoporosis of the patella, which is again a dominant cause of pain. And I think by doing a surgical procedure, we are not tackling all these other causes, which is why these people still come back with dissatisfaction rates which are as high as 20 to 30%.
So
Santosh, I may add, what other procedure are useful in my hand is doing a patellar denervation.
Denervation, yeah.
Just arthroscopically denervate along the patella. And did you add anything like BMAC or anything on
No,
this patient?
no, sir, I didn't.
Yeah, there's a question whether a microfracture will hold. Just a microfracture or drilling will not work unless you add some biological. And the question of osteoarthritis, role of microdrilling and microfracture is a big series by Dr. Wang from Malaysia. For advanced arthritis, he does the drilling, the entire the condyle, medial lateral condyle, but he injects with BMAC or biological thing. In fact, even gives epogen 1 week before, so that the granulocytic factor, so a lot of pluripotent cells, he inject to that. I think he's undergoing FDA conducted trial. So the biological then maybe.
Denervation, you do it with the RF radiofrequency. So moving in the same lines, just the last case, where again patellofemoral arthritis associated with the medial joint OA and varus, as Dr. Sudeep was asking. If there is varus and there is advanced patellofemoral, but the age is 45, what would you consider doing? I mean, it's a relative indication for a HTO. Would you still do a HTO with the patellofemoral arthritis, or what would you think of? Dr. Sudeep?
Considering the age, definitely I'll go for the HTO in this case.
Okay, what about the patellofemoral arthritis? Would you do something for that?
Maybe I had no idea, but as Dr. IPS is saying, lateral release might help if there is a tightness on the lateral side.
Okay.
I've not tried, but maybe yeah.
I think HTO is a good option because it actually realigns the patellofemoral forces as well. And as we were talking, Mukesh was talking about some amount of tibial tubercle anteriorization. So if you can add on and do an osteotomy where you actually correct the varus as well as create less pressures on the patellofemoral joint, that is going to work in this case.
Yeah, that's a thing where you do a descending type of osteotomy rather than the ascending type, where you take the limb below the tibial tuberosity. This helps in medializing the tibial tuberosity. If the anterior cut is slightly oblique, it will help in anteriorizing as well. So when you do a ascending type of osteotomy, the patella does move down further, and it would increase the patella. It might, especially when the patella is low. When there is patella baja, descending type of osteotomy is better, and we have a few series which they are better. 6 months to 1 year post.
Santosh, we can also do a closing wedge type, right? So that
will
also decompress the EA in these cases.
Correct. Only thing when you want to revise into a total that's only.
In HTO, we know that bone-to-bone arthritis, HTO may not work very well. You know, even the prognosis of even at the grade 2, grade 3 is around 70%, 8 to 10 years survival rate. When you have a grade 4 osteoarthritis, you have a patella, he has got a patellofemoral arthritis. Even though age is 45, it's a gross varus deformity. Why don't you go for a knee replacement?
No, options must be given to the patient. When you discuss with the patient, option is to wait and do a total joint replacement, or try and buy 10 years. It's up to you to choose. So it must be explained to the patient.
Bone to bone. You might have done the scopy.
Yeah.
You might have seen it's bone to bone, no?
Yeah, the one side was bone, other side, I mean, femoral side was grade 4. This was grade 2 to 3. No, not a big bad.
70% pain relief for 7 years is good enough.
Yeah, probably next time I will add that.
Extended HTO, so HTO with a patelloplasty kind of thing.
Yeah. So thank you. That's the end of, and I take this opportunity to welcome you all for more healthy discussion in Coimbatore.
Gupta, repair or reject?
Very good morning. I would like to thank IS and Kolkata Arthroscopy Society for this invitation. So, I would be speaking on meniscus to repair or to resect, and I'm going to highlight the dilemma, decision, and the conclusion. So once we encounter with the meniscus tear, you got a various option. You can resect it, you can repair it, you can leave it alone. You can resect minimum and repair maximum, or even you can use the meniscus substitutes. So the question arises, if you repair, why to repair, when to repair, and how to repair. How to repair is going to be covered by subsequent speakers. So I will be focusing on why to repair a meniscus or resect a meniscus and when to do this. So why to save the meniscus? Because even the 15% meniscus resection leads to increase in contact pressure by 350%. And at 8 years and 20 years following the meniscectomy, there are chances of 1500% increase in the risk of osteoarthritis. So how to make the decision? ASCA 2019 consensus clearly gives certain criteria, out of which the most important is Cooper's zone. But equally important is the type of tear, chronicity of tear, age and alignment, and BMI. The previous classification of red-white zones should be avoided, and a more objective and measurable classification of Cooper's zone 1, 2, 3 should be used. So once we talk about zone 0 or a meniscocapsular tear, which is a ramp tear, excellent result are seen. I am looking from the high posteromedial portal, and the instrument is coming from the low posteromedial portal. This is a classical ramp. I use an antegrade scorpion device and take the bite from the meniscus as well as from the capsule, and you can just take the simple half inches. So you can see whole of the tear and you are able to do the repair till the maximum extent by using a simple technique. Once you talk about the zone 1, this is 0 to 3 millimeter. There is also got excellent result with healing rate of 85 to 90%. And my personal preference in this case is a all inside suture device. So whatever technique you use, all inside or inside out, the one thing that is sure that you need to, because triangular structure of meniscus, you should do a superior repair as well as you should pass the device on the inferior side as well. So once you tension it, you can see the meniscus is reducing very well onto the tibial surface. Zone 2, that is 3 to 5 millimeter, has got good result with healing rate of more than 80 to 85%. And in such cases of zone 2, my preference is usually an inside-out technique, so that you can pass the suture superiorly. You can go up to any extent posteriorly as well as anteriorly. And it gives me the freedom of going inferior to the meniscus as well. Zone 3, which is more than 5 millimeter, has got a poor result with a healing rate of 70 to 75%. You can see in such case I use a scissor to do a partial meniscectomy. But after doing a balancing with the shaver, still there is a horizontal tear, which you can do repair very well using circumferential stitches. So ASCA concluded that tear in this zone should not be considered as a contraindication for repair, and in young patient like this, you can use the different suture technique. So I use a orthocord on the top of the meniscus, which is pink in color, and on the bottom of the meniscus I use a fiber wire which is blue in color. So that gives me advantage once I am doing the outside tying, that all my pink suture are superior and the blue suture are inferior. Location, whether anterior or posterior, doesn't affect the outcome of the repair, and the length of tear should not be a contraindication for the repair. Age studies are available that you got a good result with age of 9 to 58, and this patient age 53 himself is an ophthalmologist, and this was a horizontal cleavage tear. So we done a repair throughout the meniscus using the same fish mouth closure and the circumferential stitches. Patient with high BMI should not appear to be a high risk failure and should not be a contraindication for a meniscus repair. Acute repair achieves a very good result as compared to chronic, and 100% success rate has been seen in 2 series. Chronic tear achieves a success rate of 70 to 80% and should be repaired whenever feasible rather than going for a resection. So type of tear do matter whether you should go for a repair or a resection, but as we know, the ramp tear and the root tear require a repair. Bucket handle tear, radial tear and longitudinal unstable tear, again you have to go for a repair rather than for a resection. So radial tear is equivalent to a total meniscectomy, and even the partial preservation will help the load transmission and distribution. In such case, I use the rebar suture configuration, which is a combination of horizontal and mattress. Same horizontal mattress I use on the superior surface as well as on the inferior surface, because the radial tear require a good, strong, stable repair. Bucket handle medial meniscus tear, particularly associated with the ACL. If patient is presenting to you within 60 hours, you can do ACL and meniscus repair in the same setting. If patient is in a subacute, you can divide into two stages. First do the meniscus and then do the ACL. But in the chronic, you can do both ACL as well as meniscus repair in the same setting. Inside out repair being the golden standard is my preference in almost all cases of BHMMT. Horizontal cleavage tear increases the peak pressure, but it leads to the progressive meniscus extrusion, and you need to do a good repair using the fish mouth closure and the circumferential stitches throughout the meniscus. Root tear definitely require a surgery and should be repaired to avoid OA and extrusion of the meniscus. I use a suture anchor, that is a root fix anchor, for doing my root repair. You can see that this anchor is lodging onto the bone, and you can take the horizontal mattress suture and the vertical mattress suture, and once you tie it up, you can see the root is very well getting reduced onto the tibial surface. This is very useful, particularly if you are doing a high tibial osteotomy along with the root repair, because there is no tunnel on the tibial side, and with the anchor you can repair the root very well. Longitudinal unstable tear, resection should be considered only when the option of repair and leaving it alone is not there. And I personally prefer to use again the same inside out technique, and on the inferior surface I will put the suture. You can see once you tension the superior suture, there would be opening of the meniscus onto the inferior side, so that the inferior suture are very important. So you can see in this particular demonstration, I am going down as well on this thing, and once I am compressing the superior, there is a opening of the meniscus, and once I am pulling both the suture, there is a reduction of the meniscus. So both superior and inferior suture are very important. A stable tear which is less than 10 millimeter, and particularly if is in the lateral meniscus, you can leave it alone, because leaving it alone gives a better result rather than going for a resection, and you can use or combine a trephination in such case. So what are the indications for resection? A case like this in which there is a flat tear, you can do a partial meniscectomy. Complex tear like this, a tear with a high degree of degeneration and a non-reducible bucket handle tear require a resection. But even after doing resection, if you can preserve the circumferential collagen fiber, like in this case, that would be always more beneficial. And if required, you can now add on the all inside sutures onto it. You have to enhance the biology using a rasping. You have to use a notch microfracture. For root repair, you have to do a cartilage exposure to expose the underlying bone for a better healing. You can do the trephination for vascular channel. I use sometimes the fibrin clot, and the fibrin clot is then combined with the meniscus repair. So to conclude, the preservation of healthy meniscus as much as possible, you can always combine resection and repair rather than going for exclusively resection. All radial root and ramp tear needs repair. Unstable longitudinal tear more than 10 mm, including the bucket handle tear, should always be repaired. And the consensus conclude that the chronicity of tear, older tear, tear in the obese patient, and long tear are no more a contraindication for resection. Thank you.
Thank you, Dr. Sheetal. Any questions? Dr. Sheetal, is there an age limit for the root repair?
So it's
cut a point.
Depending on the degree of osteoarthritis which is associated on the long-standing scanogram, root repair we can have two types basically. One with the chronic root tear, and there is a malalignment, you will go for high tibial osteotomy. But my preference will always to go do arthroscopy and do root repair, particularly if it's a reducible. If it's irreducible, definitely there is no point on going and doing that root repair. Only just deloading the joint with the STO would be sufficient in such case. So root repair, there is no age criteria. Even if the patient age is 65 And if alignment is normal, cartilage is normal, I will go ahead and do isolated root repair.
Thank you.
Horizontal tear of late from last around 3-4 years, I am doing repair almost in all horizontal cleavage tear. I don't leave any of the horizontal cleavage tear alone.
So what's your take in doing the pike resting on the medial side in case of tight knees? While doing the repair?
Even the knee is not tight, I will do pike resting because my visualization is always better. So I'm not doing any of the meniscus repair without pike resting. So tight or no tight, I will always do pike resting.
All cases?
All cases, yeah.
It was a very good presentation, Dr. Sheetal. Regarding the age factor, as you were talking about, that you would want to do root repair for all ages, and there's very good literature on that, that age is not a contraindication for a root repair.
Yeah.
A root repair is probably a biomechanical issue more than anything else, so you would want to restore that as much as possible. So I have a question. It's as you were talking about that you try to divide the sutures, like having a blue suture and a pink suture for a bucket handle repair, and that helps you balance it out. So what is the order in which you tie, and how do you make sure which suture corresponds to which? Do you have a arthroscope inside while you're doing the tying, or you do it all together?
It's always posterior to anterior and superior first, followed by inferior. So this is the first criteria. And what I do basically once, because to cut the cost, I use the same suture, I cut it, and I just tie a simple knot and keep it there, so that I can identify, and I cut it at the different lengths. So first is cut at the 8 centimeter, then 10, then 12, so I can realize that this is the most posterior one. So this order I can follow.
Yeah, that's a good idea, because I think if you are into the habit, I've been using inside out for a very long time now, and that's how I've been saving my costs.
Yeah, because sometimes there are already 13-14 mosquito fossae which are lying there while you're doing the repair. So
exactly.
This
so
is
it's
one
a very
criteria.
good idea to have different length sutures, so that you know this is the posterior most.
Yeah.
Because many a times it's difficult assessing it if you're seeing it all from the back. It's possible that one of the less anterior sutures might come out posterior.
Yeah.
So trying to figure that out arthroscopically is also difficult. But it was an excellent presentation. Do we have any more questions for Dr. Sheetal?
Thank you.
Okay. So we'd like to call upon IPS sir for his presentation, a root repair technique.
I think root is an important injury which should not be missed. Breakage of the meniscus root leads to increased hoop pressures and stresses and increases the contact forces, and the knee becomes more arthritic. I think it's important that we need to find ways to heal these root tears. There are two methods to repair this. One is called as a tunnel method, where we take a bite into the meniscal root and do a pull through sutures and stitch it on a button, and then there is an anchor technique where we can put an anchor and repair it. I think conventionally we have always been doing a root repair with the help of normal zigs, like an ACL zig. We used to use cannulated reamers to pass in the threads, and we used lassos to pass in sutures, and finally buttons to fix it when we used to do a conventional way of root repair. We do of making a big tunnel, make a small socket which actually does not take away large bone. So just you make a small socket in the root rather than making a full tunnel of 4.5 millimeter which you used to make conventionally. Taking sutures into the root was always a problem. We had shoulder instruments which were something like lasso devices, which were quite cumbersome to take a bite in the back of the knee. Now do we have a small integrate suture passing devices like Scorpion devices, where we can go in, take a bite and create a snare, and I think a snare is a better way to actually heal the meniscus root, and then all of these sutures are finally taken away into the tibial tunnel, and then instead of fixing it over a button which can become loose over a period of time, we try to create a post to fix these sutures onto the tibia, which actually gives more stable fixation on the tibial side. So at the end of the day, when we are going to use a Scorpion device to take a bite, a flip cutter to essentially make a small socket, and a zig, a root zig, it actually increases and enhances our chances of healing. That's a small video presentation how exactly it is done. An arthroscope is in the medial portal, and on the lateral side we are putting a root repair zig. These zigs have markings, so depending upon the medial root or the lateral root and the size of the footprint, you can actually identify how much from the posterior part can the zig write. These zigs are going to be more stable than the ACL zigs, which are pointed zigs which move medial or lateral. These zigs have got a handle which is going right onto the root, but when you are going to hold the zig from outside, you can actually wobble the handle of the zig medial or laterally. So if you are going to add on an ACL reconstruction where there would be a tunnel for the ACL, you can actually make your tunnel on the other side when you're using a root repair devices. So these zigs are much more better than conventional ACL zigs, which we used to do for a root repair as well. So and you can set it for the medial root as well as for the lateral root. You do have a bullet which actually sits well. Instead of moving it, it actually sits well onto the bone. And then you can use, instead of a 4 millimeter cannulated reamer, you can actually use a flip cutter. Instead of making a large tunnel from down to tibial cortex to above, you can have a small socket and a raw bone at the mouth of the tunnel. So that's a flip cutter which is going in, and it sits right here. And you can actually remove the zig like this, and you can actually see where the flip cutter is exiting out. So again, that's the beauty of this kind of devices, which help us in seeing where exactly the flip cutter is going to come out. And then once you think that your footprint is quite okay, you can remove the zig and being flip cutter in the normal place, and then make a small socket. So with a small socket, once you've made, that's a raw area where the root is going to heal nicely. Instead of taking a suture, which you conventionally take it with the lasso devices, as I told you, we do have now knee Scorpions. These are smaller devices where you can actually create a snare. It is something like a suture in a suture loop, and this creates like a snare. So instead of a single bite which cuts out through degenerative roots, most of the time whenever you are creating a snare, it actually holds well even in a degenerate tissue. One bite is usually not enough. You usually can add on 2 or sometimes even 3 snares. It increases the surface area on which the root is going to finally fix onto the, so that's another tip. So instead of a single suture, you can have 2-3 snares which can actually go in, and these Scorpion integrate suture passing devices are an excellent device to actually pass in the sutures to hold nicely these snares. And then you can shuttle these sutures back into the tibial tunnel and take it out onto the tibial cortex. So, so these steps of simple modifications of surgery are actually helping us in improving the outcomes of root repair whenever it is possible. And on the cortical side, instead of putting a button, you can actually add in a post, which gives much more stability. The other technique is an anchor root repair device. Again, this is good. It is usually good for young patients where you have an epiphyseal plate and you don't want to damage the epiphyseal plate, and also in patients where you are adding an high tibial osteotomy. When you want to do a high tibial osteotomy, it's better to use an anchor to repair the root. So that's a small video showing how anchor root repair is done. You make a posterior medial portal. It's a high posterior medial portal, and create directly tangent towards the root. So you can use a burr to make a small fresh bone in the root. And then the normal shoulder anchors you can actually pass in posteriorly, superiorly, going directly into the root. So when the anchor is sitting here, from the anterior part you can take sutures one out of other and then start taking bite into the root. So this is anchor technique of doing a repair. All it needs is that you need to be comfortable using anchors of the shoulder arthroscopy, and your anchor angle should be such that it actually sits well onto the root where you want the insertion to happen. Again, antegrade suture passing devices are used to shuttle in these sutures, and then all of these knots can be tied here, and then you can have a nice well sitting root in place. So you can have 4, which is a double loaded suture and mattress suture configuration. Both of these sutures can be taken out, a knot can be tied, and knot can be slided down, and which actually helps us in sitting and making this root sit nicely. So this is an epiphyseal sparing kind of technique where you are going to use an anchor, especially useful for younger patients and in patients where you want to do a high tibial osteotomy. So these neuro devices definitely have helped us ease of doing a root repair surgery. Our suture passage has become much more comfortable. The fixation on the cortex has become good, and the outcome overall has become much more predictable. Thank you very much.
Excellent presentation, sir. Do we have any questions for IPS, sir? I had a couple of questions, sir. So, is there any literature to suggest which modality of fixation, whether it's the what you call the post or the endo button, which is better for root repairs?
No, I think conventionally we have always been doing a tunnel fixation, which always is sitting well in time. The advantage of tunnel fixation is the amount of force you put. The root has to sit nicely onto the raw bone, and the tunnel fixation ensures that the sutures are actually pulled down and held well. Anchor fixation depends upon the knot security and the loop security. So even if your anchor, you're putting an anchor and your knot is not so very tight, the healing becomes a problem. So most of the cases where we are not doing a HTO, we are actually going ahead and doing a root repair with a pull-through suture, and that is a conventional and sitting well.
No, so my question was for the pull-through sutures, whether using an endo button over that,
perfect.
or aperture device. Or
yeah. So if you're going to put a small root button or probably an endo button or a suture disc, there are chances of these discs to become loose over a period of time. So post fixation has much more superior longevity of holding the sutures well. So instead of putting a knot which can become a loose over a post or an endo button, it's better to put a knot, a post like a civil device.
Okay. Typically, how big a socket size would you create with a flip cutter?
So it's essentially a 4 millimeter or 4.5 millimeter socket. It's a small socket. The length is around 1.5 centimeters.
So is I think the flip cutter rod is around
4.
3.75, and then when you flip it,
so you come to 5. The smallest flip cutter is around 5.
So would you make a 5 millimeter?
Very 4.5 millimeter, very small socket, not instead of tunnel.
I think this new device which you showed, the Arthroscopic, the root device, it's a wonderful device, because I think, like, for all the people who have been trying to repair roots, this is the most, the part where we all struggle a lot, because if you have a tight knee, getting in an ACL jig is virtually impossible.
Absolutely.
So in fact, I had a modification where I had like virtually filed off that hook of the ACL, and understanding that my pin will come out around 3 millimeters beyond that tip was how I did it. But I think this is
Roots device is better.
Device.
Yeah. IPS sir, when we take a bite at the meniscal root and put those snares, what happens is when we pull those threads outwards to the tibia, anterior tibia, because of the direction of the thread, they tend to pull anteriorly. So what is it take? Can we make those suture direction along the direction of the meniscus so that direction of pull will be better?
Yeah, exactly. And that is the reason single snare doesn't work. Single snare actually lifts the meniscus root like up. So you have to put multiple snares in different directions. So scorpion usually goes first like this, second like this, and third more obliquely like this. And it creates like a parachute, and it creates the sutures which actually bring it down. So you have got a right point, and that is why more than one snare is usually needed.
Okay, thank you, sir.
Okay, so thank you, sir.
Thank you very much.
We'll move on with our talks. So we have Dr. Amit Joshi, who will talk about meniscus repair outside in and inside out.
नहीं आएगा तो डायरेक्ट करो ओके चलो किसी भी जोड़ दो
लैपटॉप पे लगाओ लैपटॉप तक गुजर दाओ सर चालू আছে ওইদিকে পিছনে
विवेक thank you very much. I'm going to talk on one technique which is usually discarded by saying that this is limited to only anterior horn or the anterior part of the meniscus. At the very outset, if you think my presentation on considering these facts, why I do these techniques more often than other people, is because many of the meniscal tear are diagnosed intraoperatively. So you don't know what has happened. MRI is not that much sensitive, and then you diagnose them intraoperatively, and you have not counseled the patient about the cost, about so many things. And 95% of our patients, they do not have insurance. So they have to pay for all the devices that we put inside from their pocket. And cost is a major factor for differing from ACL injury in our context. So if you add a lot of cost of your meniscal repair, most of these patients are not going to get your surgery. So my patients' demands are best possible treatment. They want best possible treatment and least possible cost. That is the basic demand of most of my patients. If you talk about all these various techniques that we have been talking about, all inside is costly. Inside out, it requires an extra incision, and it is costly also. If you compare with all inside, it is cheap, but if you compare with the outside in, it is costly. That is the reason why inside outside in is my favorite technique. So coming to the biomechanics of all this repair, the ABC of meniscal repair is very, very essential for healing of the meniscus. We have to reduce anatomically. There has to be a biological augmentation, and one of the most important thing is the circumferential compression. And that was the reason why Sheetal and everyone is commenting about if you put from superior, then you have to give from inferior as well. So this concept of circumferential compression was brought by Mr. Sullivan in 2013. If you look at how your all inside works once you put, this is inside out, once you put from superior surface and tighten it, it opens on the inferior side. So that is the reason why you have to supplement from the inferior as well. This is the reason why you need more suture material into the meniscus, more piercing from the meniscus. Same thing happens with the all inside technique as well. If you talk about circumferential compression on outside in technique, this is how it is done. So you come from outside, pierce the meniscus from one surface, in this case from superior to inferior. In next piercing, you just shuttle the suture, and then in next piercing, what you do, you don't purchase the meniscus substance, you just come from the inferior to the meniscus and take out your suture outside. And if you tighten it, then it shows that this gives a circumferential compression on the tear site, which is very, very essential. And if you apply this kind of circumferential compression, probably the number of sutures that is required to be applied should be the less. So that is the whole principle of outside-in technique, which is a suture shuttle technique, which is published in Arthroscopy technique in 2020. So this is a small video how I do this technique. This is the position of the patient, the normal extension of the knee and the valgus. So this is an example of a relatively old bucket handle tear. So this is reducible, which is important one. Then in all the cases I do pie crusting. I'm very liberal to do a pie crusting because repairing with the outside-in technique requires a wide opening of the joint. So augmentation by various methods, I use a low suction saver. This is the diamond rasp. I believe that the inferior surface is very, very important. And my key equipment is an epidural needle. You remember that this Towie epidural needle has a gentle curve which can attack your meniscus in the different direction. So here I am coming from up, piercing the meniscus from up and coming down. Then I pass up number 1 proline through the cannula of the epidural, then take it out. This is a very important of the outside technique, that you make a stab incision through which the needle has gone and make a soft tissue tunnel. This is a very important process. The one suture has to go from the same soft tissue tunnel so that it doesn't have any fat into the suture, so that it goes right, sits into the capsule. Then the simple suttling process, this is the upper one. This is important one, you are going from the same soft tissue tunnel, but this time you are coming inferior. So that is how you are going to give the circumferential compression. You take this out, again out. Earlier I used to use a cannula, but nowadays because putting up cannula is a little cumbersome, I do a virtual cannula technique. So both the sutures are from the same soft tissue tunnel, and then shuttle the second limb. By the same, apply a simple knot on the loop of the 2-0 orthocord and pull it out. So this first suture has to be the reduction suture. If you see this, it's circumferentially pulled out. This beautifully sits into the place and it reduces your meniscus as it has to reduce. So once your first suture has to be the reduction suture. Once you apply the reduction suture, then the other sutures become very easy. This is the third one, and you can see you can go right up to the posterior root of the meniscus. So this is the third suture on the posterior side. So this is from the superior. Putting on the posterior is little hard, but it is not difficult one. So you see that I'm coming from the inferior one, and the same process of making a virtual cannula, take it out, and then apply your third suture. So this is the posterior part. So this suture was just placed here to show that you can go right up to the posterior. So this is the important one. As you come anteriorly, having an acute attack to the meniscus is difficult, so you can hold with your ice tong or something so that you can hold the meniscus and just get pierced into from superior to inferior. So you can have a good bite of your meniscus. And the rest of the process are almost the same. I'll again show a very important step of this procedure is give a stab incision outside next to your needle. Use a small mosquito forceps, go inside right up to the capsule so that you make a soft tissue tunnel. Then you shuttle the suture. Then you shuttle the suture. Here it goes. And then you come from inferior. And what is important is you go from the same soft tissue tunnel so that there is no catching of soft tissue between the two limbs of the suture. So now, coming from inferior side, take the proline out, take from both the suture from the same soft tissue tunnel, making a virtual cannula, and then this, completes the pulling, shuttling of the second limb. So you shuttle the limb of the suture one by one. That is why the technique is named as a suture shuttle technique. So you see that again we would like to show you the circumferential compression of this one. One is right coming from up, the second one is going from down. So it is giving a good compression at the tear side. So this is the circumferential compression. It doesn't require a suture that is to be put from up and put from down. It doesn't require so many sutures. So you 6 suture, almost all from posterior to anterior, all the meniscus has been repaired. Another important thing is each of them, they come out from the separate soft tissue tunnel of a small stab incision. So while tying, there is no entanglement of the suture. You can tie them one by one. So this is, I am just demonstrating one suture which has been tied. The posterior one is not visible, so I showed you one of the anterior one. So I apply a SMC knot outside, and then you gradually go deliver your SMC knot right up to the capsule. So it has to be sustained pull. I always roll a artery forceps so that your pull is sustained and your knot goes and sits right at the capsule. An important thing is push your cord cutter right inside the incision that you have made and cut your suture inside, not on the superficial. And this is the final picture of the repair, where you can see that it is beautifully compressed. There are various advantages and disadvantages. One of the disadvantages is pie crusting of superficial MCL is almost always required. Usually when there is a tight knee, orientation of the suture, which is right posterior in the posterior root, may not be vertical, but if your other sutures are making stable, probably the posterior one suture may not need to be that much vertical. And relatively larger knot, in a very thin people, I use a sliding knot. Sometimes this can be palpable. Thank you very much and have a great day.
Excellent presentation, Dr. Amit. Do we have any questions for Dr. Amit?
Because it's possible once you are doing it anteriorly. So any tips on that?
First tip is you pass your epidural needle. What I feel, may not be right, but what I feel is by passing from or doing all inside, you have no control over where the needle is coming. Either you have to give a safety incision, put a retractor on the back side. Otherwise, you have no control over where your needle is exiting. But you know the anatomy for the medial meniscus. Your neurovascular bundles are on the lateral to the midline. So you can just get in, just avoid the adductor tendon. You just get in, make once you are inside the joint, make a stab incision, use your mosquito forceps to release the soft tissue and go right up to the capsule. Yes, you go right up to the capsule, then it becomes mobile and then you can use your needle. The second pass should be right from the same soft tissue tunnel. That is what is trick. But believe me, once you start doing it, it's not that difficult. When you, yeah, thank you. Yes, sir. No. I put my needle first, I identify which location I want, then I decide where to give the stab first. Yeah.
I think, Dr. Wright.
So I've been using inside-out techniques, and you said that the inferior part of the meniscus doesn't sit when we suture it back. But I feel that if we take it inferiorly and the bite is a little inferior, I don't have any problem in making the meniscus sit entirely over the capsule. What's your take?
I always find that when you apply in the superior surface and start tying it, it just, while tying, it just opens up inferiorly. So there has to be supplemented. If you want a good compression, if you can get without inferior, then well and good, but most of the time,
but
inferior.
Your technique was very good, and it is really very useful in places where I work. I'm practicing in Jharkhand, where patients are not so much paying. So I really like your technique. Thank you.
Very, very nice. Is there any incidence of saphenous nerve entrapment, and how do you avoid?
Entrapment of?
Saphenous nerve.
Saphenous nerve.
Yeah, that is what I say. Making a soft tissue tunnel is a key step of this outside-in technique. Earlier, we never used to consider to making a soft tissue tunnel. So give a stab incision on the skin only. You just do not go inside. Stab incision to the skin, use a mosquito to open it up and make a soft tissue tunnel from skin to the capsule. So you are just bluntly dissecting. Most of the time saphenous is spared. But you are right. Sometimes we have cases of saphenous nerve entrapment because of this outside in technique.
What do you do when you have that?
Usually they recover. I remember one case in which the saphenous nerve entrapment as well as the knot was palpable. He was a very thin guy. So I had to remove the suture knot and he became fine after some time.
And many times it might not be the full nerve but a branch coming from it and it causes equal pain. I've faced that. It bothers the patient for almost like 2.5 months.
But the same thing can occur with inside-out technique as well. Yeah.
I agree.
Thank you.
Excellent presentation, Dr. Amit. I think we'll move on.
Meniscal repair, even though recently we have a non-implant based circumferential suture systems, but in the hands of most surgeons it will be a needle based implant repair, and it is perhaps best suited for posterior horn because it gives the additional advantage of not having to make an external incision. And so you have various kinds of devices available with you these days. So these pictures and these measurements are from a very recent biomechanical study done by Dr. Alan Barber. And when you are analyzing what kind of repair or what kind of device you want to use, if you have a look at these device characteristics, some of them have devices with 2 different sizes, for example. Most of them have a sliding locking knot. There are some other devices in which both the implants are roughly of the same size, and these are the 3 most common devices available to us in our hands. Now, biomechanical studies may tell you that one device is superior over the other. Generally, it has been found that PEEK-based orthocord device is a superior device in terms of strength, but just having a device with high initial fixation strength is not good enough for these devices. So if you look at the conclusions, you might find that some devices perform better than the other, but it is important to remember that these are biomechanical data. And generally, if you look at practical clinical concerns, you find that they don't make too much of a difference. It is a trade-off between construct stiffness and the construct flexibility. When it comes to the technique, the previous speakers have already elaborated on the key points that you need to do for any meniscal repair. You need to make generous size portals so that you are easily able to pass in these large devices, and you need to do an MCL microperforation if you are dealing with the medial side. If you are dealing with the lateral side repair, I often have my OT assistant remove the side support so that I can do a very good figure of 4, and I sometimes even request my intraoperative assistant to lift the leg up in the air to improve the access on the lateral side. I prefer to use these half pipes. They are made by Karl Stoss, but even these days all inside devices come with their half pipes, and these are very useful, especially if you have the needle pointing towards the metallic end. You can very easily pass the device without the needle getting caught in the fat pad or in the soft tissue. The most important is to have a properly directed portal, and this is particularly so for lateral and the medial sides, because the lateral side, the tibial spine has a slightly higher peak and the lateral tibial plateau is convex. You might want a slightly higher video. So I'll just play a short video, and again, these devices may have differences in the deployment mechanism. So I prefer a device which I can squeeze from my hands, a gun-based device, but a lot of colleagues prefer devices in which you can throw it like a dart and you can deploy the implant. But all said and done, whichever device works best in your hands, the steps that you follow essentially are the same. I like to use a diamond rasp to ensure that, first of all, you'd like to ensure that the tear is actually repairable. And once you have decided to repair the tear, you use a diamond rasp to freshen off the edges and to see if you can improve the vascularity. At this particular stage, MCL microperforation has just been done. My initial stitch is almost always a horizontal mattress. It's a debatable whether you want to do all vertical mattress or all horizontal mattress or a mixture of both. But my initial stitch always remains a horizontal mattress because I find that it sets the tone for the rest of the procedure, and it is a relatively easy stitch to put initially, and you can tighten the meniscus very nicely with a horizontal mattress stitch. Even with a horizontal mattress stitch, you can alter the point where you pierce the meniscus and create an oblique mattress kind of a configuration. So as you see that once this knot tightens up, the meniscus almost always gets a little uplifted, and that permits you to put your vertical mattress sutures with ease. So one important consideration with this particular device, and again you must have a chat with your device manufacturer, is that there is a little bit of mild recoil associated with this. So if you are not prepared for that recoil, it's almost like firing an actual gun. So if you're not prepared for that recoil, sometimes you might deploy the implant a little inaccurately. So be conversant with the device that you want to use and have a consistent technique with these devices. You need to set a depth stop to these devices. I generally keep my depth stop between 16 to 18 mm, and as you see, as the meniscal edge has rolled up, there is space for one more device, and that device will be put in a vertical mattress kind of a configuration. So as you can clearly see, I have done an MCL microperforation. I use a half pipe, a flexible half pipe which is supplied with this particular all-inside device. I set a depth stop. Thankfully this gun allows you to do all that with a single hand. And it is important to introduce this device with the needle facing down so that it does not get caught. Sometimes these needles are not stitch configuration, and generally for this particular tear pattern type, 2 stitches will do the job. The technique choice depends on your personal preference. I would rather not give a medial incision for a tear of this kind, but if the same meniscus was a bucket handle tear, my present preference would be to do an inside out repair, because to use so many implants for a large bucket handle tear generally makes this procedure economically unviable for the patient, regardless of whether he is insured or not. So these devices are unfortunately a little expensive, and for small tears like this, they are very good. The other tip that I would like to point out is I don't give a very solid yank at this thread. So I like to roll this thread in my index finger, and I then come up to the tibia and I then pull from the tibia, a bit similar to what Dr. Amit Joshi also showed you. Roll up the artery forceps so that you give a right amount of tension rather than just pulling at it with one go. Few pitfalls, especially on the lateral side. If you do the same technique on the lateral side, you'd be surprised how close the neurovascular furniture is from the lateral portal. So from the anterolateral portal, the popliteal artery is merely 5 millimeters away from the tip of your device. So therefore, it is no longer recommended to do a posterior horn lateral meniscus repair from the anterolateral portal unless you can be very sure of your distances. If you look at the medial side, the distances are very generous, but on the lateral side, one needs to be very careful. And when it comes to what kind of device you choose, it's a balance between the stiffness of the construct and the flexibility of the construct. So please remember that regardless of what biomechanical data tell you, a strong implant is generally not the best implant. Implant which is not very strong on biomechanical test will probably fail by suture pullout or by suture slippage. Whereas if your rep tells you that we have the best performing implant, very stiff implant, very strong on biomechanical testing, these implants also can fail by cheese wiring, which is an equally serious problem. So sometimes it is a balance between what kind of an implant you want to choose. And biomechanical data has found this value, which is an optimal value of around 26.5 newtons per millimeter. But then it remains to be seen how stiff is stiff. Thank you very much indeed for your kind attention.
Do we have any questions for Raja sir?
How much would be your spacing between the two implants? So that is about 1.2 or 2 centimeter. Then how
I generally am not able to tell that in measurements. It is an intraoperative feel. It should not be very close. It should. What I just generally do is after I deploy the first implant, however much my hand moves, a very slight movement of hand, that is where I put my second needle. So it is very difficult or impossible to be mathematically precise as to how far apart you need to place your sutures. It's a feel, I guess, which one develops with time.
Is there anything you don't like about all inside repairs?
I don't like the cost. I don't like the thickness of the needle. It creates a very, very thick bite. And I especially don't like implant which fail to deploy and still the patient is charged for it. But then this is part and parcel. So these are the three top things which I don't like. I still prefer to do an inside-out suture for a bucket handle because the needle bite is very
Exactly.
thin.
I totally
So
agree with
it's
you.
only for these small posterior horn kind of tears where you feel that why to give an additional incision and do all the dissection.
Right. As you began your talk, sir, you were hinting at a newer device. I guess that was the Cetrix system
That's
that
right.
has come in.
That's right.
Do you have any experience with that?
It's too expensive for my patients to afford at this point in time. So I have no experience with it.
Okay. Okay. Thank you, sir.
Thank you.
With this session closes. Yeah. Thank you very much.
I would like to take this opportunity to thank Calcutta Arthroscopy and Sports Surgery Society for being associated with the Indian Arthroscopy Society to organize this Saarc meeting associated with the Indian Arthroscopy Society. So I thank all the office bearers and members of Calcutta Arthroscopy and Sports Surgery Society. So this, after knowing all these technical parts for the last four talks, we can go to some case scenarios. I would like to invite Professor Armugam, Dr. Chirag Tanse, Dr. Sheetal Gupta. Sorry? Change the name. Dr. Sarthak Patnaik, Dr. Ishwar Pradhan, you finished everything. Yes. So I'll go on with the case scenarios. This is a 68 years old female because we had learned all the new techniques now. It's a 68-year-old female. Patient presented with a severe pain in her right knee for 3 months duration. She had on and off pain for the 2 years on the same knee, but she was walking, carrying on her all day-to-day activities. No history of trauma. She had a severe medial joint line tenderness. McMurray's tests were positive. Movements were 10 to 90 degrees movements. And this is her X-ray. You can see that I had put AP. Sorry, there is no lateral view, but this problem is on the right side knee, this knee. And we know that in the age group, always we take an alignment X-ray, and that is her alignment X-ray. She has got a mild RS. So I would ask the panel, so how will you proceed when you see a case like this? We'll start with the Chirag.
Sir, 68-year-old. First of all, assess her daily activity living.
She's a female housewife.
Looks moderately built.
Yeah. She's a bit.
Yeah, I would.
She's not a bedridden or something. She's an active lady, but not 68
years old. If it is the first visit, I would definitely conserve her with some analgesics and probably put her on rehab.
Okay.
And probably give her a hinge brace.
Okay.
Or a medial offloading brace. She got a little bit of varus.
Yes.
So
Sheetal, okay. If she doesn't respond with medical treatment, for the second visit now.
I would like to get an MRI done to see few things like status of the meniscus root that may change my plan of treatment. At the same time, I would like to see whether there are any bone contusions, particularly in the medial femoral condyle or on the tibial side. To check whether what exactly is causing the pain, because in this age there is a lot of contusion which leads to the same pain.
So we do MRI?
Yeah.
Okay. Saarc, so in this age group, 68 years old, we don't do an MRI very often. So what are your indications in old age patients presenting with the knee pain to do an MRI scan?
So I will also like for an MRI, sir, as Dr. Seetal said, for the bone contusion one. Second, depending, you have history says pain, restricted movement, and even sir unable to, stand for a prolonged time. So I am thinking of differential diagnosis of sometimes a bulky ACL, or like a mucoid degeneration cyst of the ACL, one. It can be a torn meniscus, two. So, and also the bone condition. These three things are necessary before we plan something, sir.
And Dr. Ishan? So do you consider any total knee replacement before you do consider for MRI scan, because he's 68 years old, 2 years pain, now 3 years acute pain?
Yeah, I would advise an MRI because she seems to be having a lot of mechanical problem. It's not going beyond 90 degree, and it's been for 3 years. And as my colleagues have already pointed out that we have done along with all the conservative treatment, I think it's better to have an MRI and to see what might be there.
So I think all of us agree that this patient has got a 68 years old, 3 months acute pain. Restricted movements for knee movements is beyond 90 degrees restricted because of the pain. And you want to say something?
You didn't put the lateral one. So how is the patellofemoral?
Patellofemoral joint is okay.
Okay. Yeah. Then you have more case for MRI.
Yeah.
If there is also already pointed out the middle joints.
Yeah. X-ray wise, there is another point is restriction of the movements, severe pain over the last 3 months. X-ray wise recently maintained the joint space. So this is an indications which we do on a MRI in this age group. Even
one
though
more point is, even if you're planning a uni knee in such case, basically, if so still you want to rule out whether there is a lateral meniscus, radial tear is there, so that you can want to go for a total knee or a uni or a high tibial osteotomy. And status of ACL also would be
very
of help with
very important. Yes. Chirag, you want to add anything?
Also, since flexion is restricted, to rule out any sort of a ganglion cyst, because there's no much of an osteophyte seen there. So
Saarc sold that point. That is another different, could be a mucoid degeneration of the ACL. That is MRI. That is the coronal view. Also, I put some important pictures there, because if you are shall I move on to the next slide? So I'll put a sagittal view also. That is the sagittal MRI. Don't worry about that picture. The problem is on the only medial side. I think this picture is more on the lateral side. So what will you do now? So you can see that, Saarc, how will you proceed this patient receiving the MRI? Your opinion?
Sir, as per the MRI, there is no bony contusion. The cartilage are well maintained. What I can see in the image on the right hand side, sir, of both the condyles of the femur and tibia. There is a big radial tear of the medial meniscus, and also, sir, the ACL looked quite bulky on the sagittal side, sir. So I would go for an diagnostic arthroscopy with debulking of the ACL, go for mild arthroscopic debridement with, if the meniscus is, I found it a tear, I will repair it, sir.
Sheetal, for public
she's already got a varus knee, so I think nothing, arthroscopy is not going to help her unless you combine it with the HTO. At the age of 68, I would be not very much keen to do a HTO, because at the age of 68, even you go for a joint replacement, is going to give a very good result and good function, particularly her activity level is low.
Sorry, before I go to the treatment option, the differential diagnosis which we discussed, I think this age group, which is very, very important, is other two important diagnoses. One is the SPONG, another is the medial tibial stress syndrome. So it's very, very important before you do an MRI scan, you should palpate the medial side of the tibia. So make sure that pain is in the medial joint line tenderness or below the joint line tenderness. If the patient present with mild varus with tenderness 2 to 3 centimeter below the joint line, 90% of the time it is a medial tibial stress syndrome. Just you treat with a medial unloading brace, that patients will be completely all right. Even you don't need to go for an MRI scan. You are reasonably joint space, you can MRI, you can have a spunk also, which that is another differential diagnosis always for the youngsters to keep it in mind. So now the treatment option, Sheetal, conserve. You said that you conserve.
And yeah, because at the age of 68, there is no point with the varus knee. Either go for a replacement or just wait and watch till the.
Yeah, Professor Armugam, any different opinion?
Again, depends on how active she is. Just a housewife, I'm even try considering the PRP injections to get rid of the pain. Of course, that will give more kind of bargaining to go for surgery.
Ishan, any different opinion? You do a conservative or a surgery? That's only two questions.
I'll go for a surgery. The reason why is that she's having a mechanical obstruction. That's there. She can flex up to 90 degree. But looking at the MRI, she has a radial tear in the middle meniscus. That could be the reason for the limitation in the range of motion. I would do a arthroscopy, maybe do a debridement, but provided that telling the patient that this is going to reduce her mechanical problem, but she might still have some pain. Okay, and if she continues to have some pain, after 65, 68, I would advise her a TKA.
Okay, 2 for surgery, 2 for conservative, 1 for PRP. Chirag?
Definitely there is no middle path for this. Osteophytes on both the sides, middle and lateral. Both the meniscus regenerative tears. I'll wait for a while, wait for her to ask for a TKR.
Okay, so you'll conserve.
Yeah, 68.
Okay, so this patient, I went for arthroscopy because she had a complex with the radial tear, which he talked about. Of course, she had a degenerative changes, even though X-ray was normal, like Professor Aramam asked, she has got some patellofemoral joint pain. But this is her picture as soon as you go inside. You see the cartilage, so even though the X-ray is light, whereas you can see the cartilage is reasonably very good. So this is a complex tear which you see in the posteromedial joint space, which gives a mechanical pain and symptoms. That is the reason for the restriction of the movements beyond 90 degrees. As you see here, this is the typical tear which was flipped and complex tear, which gets caught between your condyle and the. Sometimes you see even in young patients. So these patients will have a mechanical pain. So this is one of the tear which needs an arthroscopy. These patients do excellently well, and you can see we are doing the partial meniscectomy. You can see there is some degenerative tear in the entire meniscus. Okay, so you done a partial meniscectomy. Are you happy with this? It's okay. Of course, myocard decompression was done. Sarthak, once you done this meniscectomy, we think that is the problem. So we just a meniscectomy. Will you stop with that?
No, sir. I would like to look for the other structures, sir, like the other condyle cartilage. What is the resilience and how much of cartilage defect is there? One. Second, I would like to see the ACL, sir, predominantly, sir.
ACL mycoid was decompressed.
Yes.
Decompressed.
So, and then to end up, I'll get to see the patellofemoral, the trochlea and the patella, if there is any site of any patella.
Yeah, there is OA changes which we cannot do much about it. See, 68 years old.
Then it's fine. Then I will wait for
it. Anything add, Sheetal, to no.
It's quite good, but the only thing is basically because of the virus, she may have continuous pain. Mechanical symptom can go, but pain is one factor because our patient doesn't understand what is a 70% pain relief or a 10%.
She's 68 years old. She had on and off mild pain, but she was not. That was not bothering her day-to-day activities, which I told. The why I told about it, we should not stop with that. You see that I'm probing. I'm getting another flap which was flipped back. You see that? That is another flipped fragment which is again getting caught between this femur. After excising that fragment which was caught, so it is important that you should probe it. All this degenerative tear, the important point which I want to make for all the youngsters, if you learn this point in this meniscus panel discussion, that is good. Because any meniscal tear, of course, you have to probe it. There is no doubt about it. So when you have this kind of complex tear,
There will be a hidden part which can be flipped. Sometimes MRI also cannot, even we cannot pick it up, even the musculoskeletal radiologist cannot pick it up. You can see such a big fragment, you can see that which I put back inside the joint now. So that fragment was in the back, again that can cause a lot of pain. So this patient underwent, I removed that fragment also. You can see that. So such a big fragment which we had to remove it. So it's very, very important to look for the flipped portion of the tear whenever you do a partial meniscectomy. That is very important. And that story doesn't stop here. Again, you can see then another flipped fragment in the body also.
I would like to add a pipe crusting there,
Yeah, if you feel it is very tight, you can do a pipe crusting. Absolutely, absolutely. Nothing wrong in that. So always you can do a controlled pipe crusting to open up the joint space. We can see that another fragment which was flipped in the body level also. So that is the main issue. That is also can be a cause for the mechanical symptom. So this patient had a two flipped fragment, one in the posterior horn, the another fragment which is in the body, but flipped in the body level. So these patients, you can see that that is the final after removing that. So there is a role for a partial meniscectomy in an osteoarthritic patient, but you have to be very careful whenever they had mechanical symptoms, restriction of the movements, reasonable joint space, then this patient definitely MRI and role of meniscectomy will help them. This patient was completely all right after the partial meniscectomy. We go to the second case. It's a 38 years old female, reasonably younger patient than the previous patient. She had a pain in the knee for 6 months, but she had a slip and fall at home 6 months before the pain started. Before that, she was completely all right, but no locking or instability. Mpfn test was positive. She also had a restriction of the movements, the last 20 to 30 degrees of restriction of the movement, and that is her X-ray. Of course, the differential diagnosis, you think about the mycoid degeneration, which with ganglion cyst, in the previous case we discussed, that was normal. There is no mycoid degeneration, and that is her MRI finding. Dr. Ishan, you can start. Sorry, that are the pictures. I only the findings picture I had put it. Yeah.
There's a middle meniscus tear, and it's not just only the tear, but the meniscus is extruded outside. So I would like to have a look at the lateral, the sagittal.
Yeah, sorry, these are the pictures only I have.
Okay. So we should be careful about the root tear there.
There is no root tear for this patient.
Okay, but why is
you can see the coronal axial view.
Yeah,
you can see the root here, both the sides. Can you visualize?
Why is the middle meniscus extruded so far out?
Now you can see here, there is a tear.
Yeah, just a tear.
Okay, Saarc, you want to add something?
Yeah, when the root is intact, usually you expect a complex tear.
Yes.
Horizontal cleavage with the radial component.
So yeah, that's the point. So it's agree that because without wasting time. So it's a complex tear. Complex tear. Anybody concerned, or will anybody, all of you will operate?
It would be surgery, just scanogram and then followed by surgery.
Yeah, alignment is normal. She's a 38 years old female, only 6 months post-traumatic. I didn't add any alignment X-ray here. Clinically also she is had alignment. I didn't take alignment X-ray, of course, because she is absolutely normal. So when you have these kind of cases, how will you counsel? So this is a complex tear from Shatak. Sardak? What do you, you agreed, all of us agreed that we will go for arthroscopy. So what will you do in arthroscopy? You have to tell the patient, no, because it's a complex tear.
So 38-year-old female, a young lady. So I would just take it like you are losing the cushion of your knee. So once it is torn, it is like completely shattered. So if you don't do slowly, your knees are going to, your cartilage are going to rub against each other, and you will end up with a bigger problem. So if you go ahead now, there might be two types. When we go inside, the picture might be different inside the knee joint when you scope it. So if there is something which is which we can preserve, it will be repaired, and the remnant, just like a nail, you have to clip it out, and followed by a proper rehab for around 2 months, and you will be back in action.
You'll do a meniscectomy or a meniscus repair How will you counsel? Because whenever you see it's just a complex tear, degenerative, 38 years old.
We had to counsel both the possibilities. Meniscectomy, the first question they will ask, what will happen in the young losing meniscus? I would tell her, meniscus is already gone. There is a chance we may repair it, but that's the reason why you have pain. So there is a little more counseling needed, because they said, we are young, leaving the meniscus, I am going to arthritis very soon. So those question has to be answered.
Okay, any other different opinion? So
We'll go for resection, and we will try to preserve as much as we can.
as much as possible. So this is a SIG. You can see that same like a previous case. You can see the complex tear. You can see that flipped fragment in the posteromedial joint space between the femoral condyle and the tibial side. So typically that is the one which gives the mechanical symptom more than the horizontal component, which we know. You can see, just will go through fast. This is the next slide. So naturally you tend to excise that fragment which was flipped in the posteromedial joint space. It is not possible because it's a
you don't do pike cresting on these patients? I don't hesitate, even meniscectomy, do a pike cresting because
yeah.
it will save the cartilage.
You can do pike cresting, of course.
For the younger colleague.
Yeah, absolutely.
The MCL always heals.
Agree.
The cartilage never heals, so don't hesitate.
So this is the meniscectomy. You can see that another flat fragment on the body side. So you change your portal, you come from the opposite side. Now you see through the lateral side and go through the anteromedial portal, remove that another degenerative portion over here. So this is very important when you do a partial meniscectomy. Changing the portal is the key if you want to do a proper partial meniscectomy. So to complete the meniscectomy on the both the posterior side and the body level, and that is how you end up with. You can see there is a horizontal component which you could see over there. So what is your take from Ishan? Will you leave it like that because we know that it's a degenerative component? You can see that horizontal component there which we discussed, complex with horizontal tear. Yes,
I'd put a probe inside and find out which is the more looser one, you know.
Yeah.
The inferior or the superior. I would remove the looser one because that is going to tear very soon in the future. I would not repair it.
Your opinion?
So I would like to check the knee mobilization intra-op and try to see which fragment is going more mobilization as such, so which is the looser fragment.
Yeah.
If I see the connectivity is not much longer, the tear is not much longer, I'll go for clipping the looser fragment.
Looser fragment.
But if both are maintaining a similar tensile strength and both are parallel to each other, I might go for vertical repair of the posterior fragment.
So, and Chirag or Seetal?
Sir, it looks chronic. So definitely I would like to repair this and augment it with something, either a blood clot or else microfracture inside for a healing, because once you clean it up...
Chronic means what? Why you are saying chronic?
Once you clean it up, you see that horizontal flaps, both of them, they look...
Yeah, you are able to see the mycard material between.
Yeah.
It's a degenerative, naturally. Even though he's 36 years old, in our Indian scenario, we tend to see many patients with a lot of degeneration. That's why they go for a mycard ACL also. So all these patients will have a mycard meniscus also. Yes, Seetal.
This is a classical horizontal cleavage tear with equal flaps both superiorly and inferiorly. So I would like to do a circumferential stitch closer with the fibrin clot preferably. You can very well put the clot inside and then you can just stitch.
So you can see the gap between the both the flaps. Once you do the debridement of your all the material, it's a big horizontal component. Of course, that's a question which we discussed, whether to leave it like that or to do a repair, or if you do a repair, I think Seetal told you will go all around and do the tie it well. And Chirag, what is your technique?
Similar to what Dr. Seetal said, I would do inside out. I would close off both the flap and probably augment it with the fibrin clot inside.
Yeah, sometimes if it is a big gap, it's very difficult to go all around and take a bite. So sometimes you can take a separate bites from the inferior flap and the superior flap.
There have been studies which suggest that the horizontal cleavage tear finally convert into a root tear. Because that horizontal cleavage, once it proceeds towards the root, it's going to cause the root tear.
Root tear.
So that's why kind of a root extrusion kind of a thing was visible in the MRI. So it's always better to do a circumferential compression stitches in all horizontal cleavage.
So the panel agree that these cases has to be repaired, both the flap, because they are young patients, 38 years old, but we know the cause is a degenerative tear. But still, by removing that whole flap is going to be a huge, because almost extending from posterior to the body, almost come to the anterior and middle horn junction. So you make multiple stitches like this. What happens, this is another video which I don't have it now. So because you have done excessive debridement, as you said, it's highly unstable in the posterior horn, this level. Even though you make a multiple stitches like this, the posterior horn level already you debrided, the meniscus has debrided, you completely divide out the capsule. So when you put a probe, it can come in easily. So the one other adding the all inside, which helps you to help stabilize this horizontal component along with your posterior horn, makes it as a very, very stable tear. So you can see that inside component was added, and that is the final picture. We can see that's completely closed. Both the horizontal component is completely stable, and up to the posterior horn, you can see that is the probe which you can pull it up and see the flaps are. Otherwise, you have to excise the whole flap. So now we have these techniques to add on your armamentarium. So make sure that when you have see a complex tear with the horizontal component, you counsel the patients for suturing, because there is a cost also involved in these cases. So it's very important that you have to, I can expect that these patients may need a tear also apart from partial meniscectomy. There is no role here like before, only meniscectomy, only repair. So these are the cases where you do a meniscectomy and also add a repair too. So I'll go to the third case. Yes, Mukesh. Sorry? Absolutely, you can add on that. No, I don't do it.
No?
I don't do. I just do a triffening and clearing, which I agree, which I always with the Trapedo, always I clear that surrounding area to increase the circulation, but I don't add the fibroid clot.
Any long term, as the meniscus still looked, the posterior medial tibia was still exposed. So the meniscus is still like little extruded. So what have you ever seen in long term, the meniscus getting reduced, or only the pain goes?
No, because I don't have, because these are all the earlier cases we started doing only the last 2 years. So I don't have any long-term follow-up of these patients at the MRI studies. I don't have any MRI studies available, I don't know, any for the horizontal tears.
And a closer note to that, even for the meniscal root repairs, we are classically present with these meniscal extrusion. After even repair, Chung has done a very good meta-analysis on that. In about 70% of cases, the extrusion does not get corrected.
Yes, sir. That is a totally different scenario. We are talking about root tear with extrusion. This is.
So what I sometimes what I do post-op, I try to give intra-articular hyaluronic acid, and I have around 4 patients whom I have done like that, and that content is like 3 of them have come back in the 3rd year, symptomatically free, only for the injections. So
okay. So just we'll go to the 3rd case, because they're telling already time is over. Probably we are talking too much. So just I will finish with this case. 37 years old female, pain and instability, 3 weeks old twisting injury. It's an acute case, so I don't want to elaborate it. This patient with the ACL, I think with the MRI shows that you have a typical, this is a common scenario of your lateral meniscal tear, which you see in the ACL. So that is a video which you all of us see. This is not just a radial tear. We know this is a complex tear. And you can see that is a popliteus. That is not the meniscus. You can see that is the popliteus. You can see the another fragment is so far ahead from your original posterior horn. You can see that. That is the posterior component. This is the anterior component. This patient also has got an incomplete discoid meniscus with the tear. Yeah, more of discoid meniscus with the tear. So, of course, options of repair, yes, I'm not going to discuss here. So you have not many options here to discuss at all, because we have only one option where you can do a side-to-side repair. Luckily, with the help of this new armamentarium in our kit, this kind of knee scorpions help us to do the side-to-side repair. The only part in the lateral meniscus, always you should take a risk and do a repair, because we know that lateral meniscus has got a good potential for healing than the medial meniscus. Then you take a bite from that on both the sides because it's completely displaced. Almost you have a 1.5 to 2 centimeter gap. So you take a bites on the both the side, securing the sutures. Make sure that you don't tight too much because it can overlap. So just approximate and do the tight. Do the reassess. Add multiple 2 or 3 side to side stitch. This is the second side to side stitch was added for this case. And the inner edges, the discoid material can be debrided, can be removed because they are discoid material. That was the stable meniscus at the end. So you can see that it's completely almost 1.5 centimeter displaced meniscus can be approximated very well with the side to side repair in the complex lateral meniscal tear. With that, I thank all the panel because I wanted to finish. And before I go away, I want to talk about the IASCon. So please do join for IASCon 19th annual meetings going to happen in Hotel Lee Meridian, Coimbatore. It is September 15th to 17th. We are planning for 25 to 30 live surgeries. We have 12 international faculty, confirmed faculties. We have all the symposia, panel discussions. More than that, we have all the stalwarts of Indian faculty, around 100 people coming and showing their skills. And also we have 3 best paper awards for the knee and shoulder with rewards, not cash prizes. We are planning for something else also. Registrations are open. Please go to the www.iascon2022.com to do a registration. Thank you very much. Thank you.
The presenter is Dr. Tirtha Vyas, and the panelists are Dr. Mohammad Fazil, Dr. Ravi Kumar, Dr. Devasi Chatterjee sir, Dr. Swarnendu Samanto, and Dr. Roshan.
Good noon, everyone. Thank you for inviting me, first of all. So let us start with let me run through the few slides. Meniscus was considered vestigial, but today we are looking at Save the Meniscus campaign. We all know all these functions, the tear patterns that we commonly encounter in our clinical practice. The dilemma today we have is, should we repair all the meniscus tears? And the answer is no. So what are the criteria that we should be looking at before we contemplate repairing the meniscus? The duration, all acute tears and few chronic tears that we can repair, we should repair. Vascularity in red zone and red-white zone, we should be contemplating repair. Type of tears, most of the time longitudinal, bucket handle tears and the radial tears. These tears are commonly being repaired. Age less than 40 years, stable knee profile, patient with normal limb alignment, we should be repairing the meniscus. Then ACL and associated injuries. In this patient cohort, there are chances that it will heal better than isolated meniscus repair. The tear length, higher the tear length, there are less chances that it will not heal. So all these factors we should be considering. What are the essentials? We should treat all the meniscus repair like a non-union. Always think about the biology, debride, abrade, trephinate, put the clot, microfracture and rasping. This is very important. Whenever needed, use hybrid techniques, combination of techniques. For example, in bucket handle tears, we can use inside out and outside in, or all inside, all three techniques. Never hesitate to take accessory portals. Whenever needed to visualize it, plan the surgeries. If you fail to plan, you plan to fail. Biomechanics, the vertical sutures are always better than horizontal, and horizontal is always better than the mulberry knot. Suture placement, 2:1 or 3:1, we can put perpendicular placement of the suture is important. General meniscus repair protocols that I follow, visualize the meniscus well, spinal needle vectors is extremely important, thorough tear site preparation, that is improving the biology, assess the geometry of the tear, provisionally reduce first, then dissect the accessory incision, place the proper retractors if needed for inside out, then select repair device method because it has its own learning curve, then individualize the rehab protocols. The repair techniques, this is the general norms that is there, but with the advent of the technique, there is quite a good amount of overlap between the zone in which we can use all these techniques. Case 1. So he is a 27-year male without any comorbidity. He is an office goer, and his activity level was, he had a recreational sports activity level, history of bike accident 3 months back. He was complaining of pain and locking. On examination, he was having neutral alignment. Medial joint line tenderness was present. His range of motion was from 10 to 130 degree. McMurray's was positive for medial side. Pain on passive extension. His stable knee. He was advised X-ray and MRI. X-ray was normal and MRI picture was showing this. So in the you can see that the bucket of the bucket handle tear, that arrow is showing, and the double PCL sign. So with this MRI image, I planned for arthroscopic meniscus repair using hybrid technique, SOS meniscectomy. These are the zone-specific cannulas that we use for the inside-out technique, and this is for the outside-in repair, 18 gauge spinal needle and 20 PDS. One slide on safety incision. We should be always putting our retractors to see increase the safety of the entire procedure. Now coming on to the scoping the joint. So I have reduced the joint with the probe. You can see that it is nicely reduced. Then going into the diagnostic round, ACL is quite good, and the lateral meniscus is also very good. So once that has been done, on the other side of on the other video, I am just shaving the tear site. So it is about improving the biology. Tear the site. Sorry.
Dr. Tirtha, is there anything, suppose this was supposed to be a case sort of discussion. Do you have any question to the panels or any interaction with the delegates that you can go ahead? Because we don't, you are not taking this as a sort of presentation, okay?
Okay.
If there is any query in your case, then you can ask the learned faculty.
Okay. So, sir, I will finish this case and then, yeah. Yeah. So, cursor. Okay. So I'm excising the non-union, and then later on synovial abrasion. So yeah, once that has been done, you go on the posterior side, place your retractors properly, and then put your reduction stitch. Yeah. So after placing 3 to 4 stitches, there is a possibility, so it will evert the meniscus, and we have to put the inferior stitch. And then finally coming on to the anterior horn. This is the inside out technique, or sorry, outside in technique. And finally, I am putting a stitch on the posterior horn, and one can see that it is nicely reduced. For the post-op rehabilitation, for 0 to 4 weeks, I keep them non-weight bearing, range of motion, active and passive.
Hello. Can I just stop you there?
Yeah.
This is not a case presentation. You are showing us how you have dealt a particular case. This was supposed to be a case discussion where you have some questions about certain problems in managing a case, and you take the opinion of people, how other people would like to handle that, and you also tell your opinion. So instead of talking all the way about one case, the problems or the questions or the decision makings in certain steps of a particular case would be welcome.
Yes, sir. So, sir, for rehab, like in bucket handle tear, after rehabilitation, how would you rehab in an isolated bucket handle tear repair?
So you have done a lateral meniscal repair.
Medial meniscus.
Medial meniscal,
Yes, sir.
medial meniscal repair with inside out technique and then outside in technique. So in rehab, initially I would like to start passive an active range of movement up to 90 degree. Then I'll make him weight bear a little bit delay of about 4 weeks.
Okay. Any other opinion?
Yes, I mean for bucket handle tears which are otherwise stable, well repaired, these days people start weight bearing pretty early, partial weight bearing to full weight bearing pretty early. The problem was with 3 things. Number 1 is weight bearing, number 2 is knee brace or not, number 3 is knee range of movement. If it is a good and stable repair, then I don't think any brace or anything would be necessary. I think you can allow early knee bending and movements, and weight bearing should also be done early rather than late. Any other thought?
No. It is like that because I think previously when people were telling that big repair that you move up to 30 degree non-weight bearing for 6 weeks, it is not been nowadays it is there. It is a patellar mobilization, hardly non-weight bearing or partial whatever is for 3 weeks. Mobilize up to 90 because the hoop stress, and now the theory has been changed. More you walk, the hoop and everything, it basically helps in the union. Okay. So this is the way this has changed now.
Yes,
and
sir.
I think one comment on your repair technique, what you
Yeah.
have shown, I will request don't use this Prolene sort of suture for your repairs nowadays, okay?
Okay.
Because these are not very strong suture material to hold the meniscus, and during your surgery also you get tears, mostly at the mouth of your needle, what you are showing at the 4th one. When you put the needle outside in, and when you pull the suture, it basically abrades the suture, ultimately the holding power, and you have to repeat the same stage many a times, okay? So I think this Prolene is out of the way of meniscal repair. It has not been done. It is only for the relay.
Yes, sir. So coming on to the case 2, 23-year female. She was complaining of pain and occasional locking, deep squatting pain, difficulty in getting up from squatting position, range of motion 0 to 130 degree. There was no instability. McMurray's was positive. He was having deep squatting pain. This was the radiographic picture and this was the MRI image which was showing signal changes at the meniscocapsular junction. So from this I would like to ask the panelists, like, how would you manage this case?
Since this is posterior and it is at the red zone, so we'll go for repair this one, okay? So if we have, this is in posterior part, so all inside technique will be better for this.
Okay. Any other opinion, sir? Samantha, sir?
Yes, definitely. This is a posterior peripheral tear, red, okay. But thing is that you have to have more MRI cuts to decide, because you cannot have the decision how you go ahead with this thing. Probably you are definitely going ahead with your scopy, then you decide. Because at the age, the tear timing and all this goes with the repair technique. So you have to do the repair whatever feels best. If it is dead posterior, you just do the all inside, or else you do the inside out technique. Because posterior third, this is the two methods that is left with.
Okay. And sir, there are some incomplete tears also for the ramp, as far as the ramp lesion is concerned. So would you straight away plan for the repair, or you would like to go in, see and probe it and then decide?
No, you have to have all the MRI cards, your naked eye vision, then you decide. I think ramp is a oversold thing. Okay. Ramp is a oversold thing. Take it that. So if you see your all MRI pictures, then you do the repair, because this will need repair.
Yeah.
Actually, we should see the MRI picture, but we should be prepared to go for any type of repair intraoperatively, because sometimes we may see something different from what we see in MRI.
Exactly. So I had planned the same thing, but before that there was a literature support that MRI is a bit inconclusive, and so it should be an intraoperative decision, but definitely if it is a complete ramp tear, it requires surgical repair. So I had planned for diagnostic arthroscopy and ramp repair using fiber wire and suture lasso. So this was the armamentarium that we need while doing a repair, and starting with the scopy. So this was the initial look. And while doing the posterior scopy, one can see that there is a meniscocapsular separation. After diagnosing, I took the posteromedial portal and tried to improve the biology with the diamond rasp. Because it was a complete tear, I finally planned for the repair. So I would like to ask the panelist here that if we are doing a repair, so what would be the order of the stitch, like from medial to lateral or lateral to medial?
Before that, may I ask you one question?
Yes, sir.
What was the symptom of this patient? You said deep posterior pain, and you also mentioned locking.
Yeah.
How can patient have locking with this lesion?
Sir, the patient, if you intricately see the picture, this is not only the ramp lesion. This has got the ramp component, also the peripheral tear is there.
Yes, sir.
Because your meniscus is already been displaced midline. So this is, you have to concentrate more on your peripheral repair rather than the ramp. Because it has detached from the periphery. If you probe it, it will come into the midline.
Okay. You mean to say that longitudinal tear plus ramp?
No. This is definitely a longitudinal tear. If you go back to your 3 slides back, you will see that it is not in anatomical position. It has to be repaired at the periphery first, then concentrate on the ramp. This is not the classic ramp. This is combination of two.
We have to go and probe and pull out and see whether it's getting away from the periphery, just not by visualizing. I think we have to go and see into the periphery.
Okay. So I had planned for the ramp repair, and this is the Benkat lasso, suture lasso, and first the capsular bite. So yes, here also I would like to ask one another question, like first you will take the meniscal bite or the capsular bite?
I think there is no confusion on that. This is classically how you repair your Benkat. It has to be from the capsule to the meniscus.
Capsule to the meniscus.
How can you get it? The alphabet starts from the Z. It should be from the A.
Once the PDS is passed, we will railroad the suture, and 0 number fiber wire has been passed. and the knot has been tied. So anything difference in the rehab protocol for this lesion?
Whatever you do for the ramp and whatever you do for the periphery, all are same. Only
All
thing
are
the
same.
deep flexion
Yes,
is
sir.
not there for the ramp. Okay.
Yes, sir.
So I think you have to stop because we have to share with the other people. Mani Mainak, you are going to present,
Yeah.
na? Okay.
Okay. Thank you, sir.
Thank you, Tirtho.
Thank you, sir.
Particularly for this,
Yes, sir,
because
I
you
will
try
just-
to interact.
yes,
Okay.
yes, definitely, sir. Because, sir, the video is only 2 minutes. The interaction is the main thing.
Okay. Video 2 minutes, interaction 8 minutes. Okay. চলবে তো ভিডিওটা?
So, sir,
দেখো না ভাই ওখান থেকে।
কি ব্যাপার ভিডিওটা এখানে চলছে ওখানে চলছে না কেন?
ঠিক আছে মইনাক বল না কিছু একটা জিজ্ঞেস তো কর, কিছু না হলেও
So the main thing, actually video is running here but it is not running there. কি ব্যাপার এখানে তো চলছে ওখানে তো চলছে।
মইনাক
স্টিল হয়ে গেছে এটা।
মইনাক
So the main issue which I actually all of the things about meniscus has already been discussed. So one of the things I would like to ask the panelists is about this root avulsion injury, the repair, whether any of you have shifted from the 1 tunnel to the 2 tunnel repair that is now being propagated by Dr. Robert Laprade. According to him, the 2 tunnel is more of an anatomical fixation with the equal pressure over the footprint. So that is my question from Dr. Roshan.
No, I have just done single tunnel, so I don't have idea of double tunnel. Sorry, you.
Any of you?
No, you can do a single tunnel or double tunnel. It doesn't matter. You have to have a proper stitch. Go with the single, double, whatever you do. Single tunnel, double tunnel, everything goes fine. If your stitch and everything is fine. I think you don't need the 2 tunnels.
Okay, Devashit sir, you are the same view. Okay, so the next question would be about the tensioning. How much of the tensioning and the position of the tunnel with respect to the root? Because sometimes it so happens that when the injury is old enough, it gets retracted a bit and it is very difficult to pull it back to the initial footprint area. So what is your picture on this and what is your take on this?
Well, that depends on the degree of injury. You don't have to put it back right back there. Wherever it can come comfortably.
Yes, sir, that is the
tension that is, you have to accept.
Means you will just pull on the meniscus and see where the proper tensioning is there and then, okay, so the next question would be how much of the tension that you are pulling on the tunnel, that is the question. Like, you know, Dr. Fazil, have I made my question clear?
Yeah, I would go in for something in between. If it's very long chronic injury, you may have some difficulty in bringing it, but I wouldn't apply too much tension because wherever I get how much reduction I keep it, I just place it there and I don't apply too much tension.
No, basically when you repair the root, you don't give too much of tension. Otherwise, you will tear apart the root. It is a dangerous situation then. Okay. So basically, before that, you have to see where it is sitting to. then sometimes you need the peripheral release. So these are the techniques all been described by Laprad. Okay. So they have.
You want to do?
What do you mean, at the repair side?
Yes, sir. Yes, sir.
Well, I mean, you have to scoop it out to expose the raw bone to so that make it heal well. Of course, you have to do it unless you are using one of those flip cutter things where it is done automatically.
Okay. So the consensus is that still all of you are doing a single tunnel technique because you feel that the hype about anatomical fixation is just maybe hype. Okay. And the tension is just where it ought to be. Okay. Okay. So this is what we did. We also did a single tunnel. We used a self-retrieving suture passing device. And we pulled it to the tibial tunnel. So since all of the points are covered, this is one of the main points which I wanted to highlight, whether one tunnel or two tunnel. Okay, thank you. Thank you.
Good afternoon. So at first I think my topic is predominantly cases. Can you, Dr. Sarthak Patnaik? हाँ sir. So हम लोग actually there was this mild confusion which me and Tirth had. Like we thought it is a case presentation, so the PowerPoint was not done accordingly. So I'll just try to make it slowly. I'll go slowly into it. Yeah. कहाँ है? ना सार्थक पटनायक वहाँ दिया था ना, नहीं कि मैं अपना लेके आऊँ, इधर तो नहीं है, उधर दीजिए, वहाँ से कैसे मैं इसको मैनेज कैसे करूँगा? दे देगा इसमें सब। मैं अपने ले आऊँ? नहीं नहीं सर भेज रहा है। नहीं दीदी कैंडल दीदी क्या
রাজীব কি করব তাহলে এখন?
कैसे एसडीएम है तो कैसा ऐसा रहेगा ना, बहुत बड़ा। हाँ जल्दी खत्म। So I'll start first. So mine is a 35-year-old male who was a music composer, presented with came with a history of RTA. On clinical examination, the Lachman was negative, but he had a posterior drawer. A posterior sag was present, and around drawer was around grade 2 with tenderness in the medial joint line. RM was around 0 to 60 degree, which can be a painful due to the painful knee joint. So the MRI showed a complete longitudinal, as you can see, sir, the complete longitudinal radial tear involving the posterior root of meniscus with a partial tear of the PCL, sir. So X-ray was normal. I'll just let go fast. The patient turned out that he was COVID positive, so the treatment was delayed for a month. I had to wait. During this meantime, patient was managed with a knee brace and partial toe touching weight bearing. So after 1 month when I examined, the swelling has reduced, but the posterior drawer was around grade 1 to grade 2. Sag was absent, and patient complains of instability, and there was a pain on knee bending. So now, what do you think, sir? What we should do? Like with two components here I'm looking for, that is a PCL injury and a meniscus tear. What should be the best thing? Should we leave it? Or do you think surgery? If surgery, what should be the treatment? Is it PCL or PCL with meniscus?
Actually, what is his complaints now?
Complaint is pain in knee bending is the most important complaint. No
having full range of movement.
No range of movement. Yeah, only till 90 degree was the pain. No instability, but
no instability.
No instability.
I think with the PCL and the tear pattern, probably for one MRI it is very hard to comment on. But still, with this laxity grade 1 PCL with the root tears, it doesn't necessarily mean that every time you have to go ahead with surgery. You can conserve, you can see at 3 months' time what his symptoms are. Go ahead with the physio and everything. Probably some of the root tears, even with the grade 1 PCL, they go ahead with your normal activities. Sital?
No, do we need to operate a grade 1 PCL with meniscus root tear? So do you have any time interval that you need to wait for a month or 2 months? No. No, not.
Until unless it's an avulsion like the previous case, that was a lateral meniscus avulsion, bony avulsion. In such case, it's a different scenario, but otherwise.
Right. So the cost was also a question here. I'll explain why. So, yes, sir.
I just wanted to ask, but we have all decided from looking only at the MRI and this that it is a root tear.
Yeah.
Just from that MRI picture, we could decide that it is a root tear.
MRI is clearly showing it's more of a radial tear which is very close to root. So
Root,
it's within
yeah.
within 9
Yeah, I will show the
10
arthroscopic.
millimeter,
Yes. So I thought of, sir, operating. So I did an diagnostic arthroscopy, and after, so to reach the knee joints, mostly to the posterior part, do you have any tips? Can anyone give any tips to reach to the posterior part of to the horn, like to the root of the meniscus? There are two things. Any small tips? The pie crusting is one. We need to open the medial side. Anything else?
Do pie crusting, 3 things. One is pie crusting, second is 30-degree knee flexion in the valgus.
Yes,
this
sir.
will suffice your purpose. 3 things.
Yes, sir. Anything else, sir?
Anything you can
Yeah.
do the reverse nosplasty. Probably
Yes,
you
sir.
are,
Sir,
you
in
are
case-
pointing towards me that question.
Yes, sir.
क्या खबर बोल?
You can have additional portal also.
Okay, sir.
Yes.
Okay, and suppose it is a case of root of the lateral meniscus. There we have this PCL pad of fat. So do we need to remove the PCL pad of fat, or we have to?
No, I think this confusion has already been written by the great boss Laprade, that if you have difficulty in reaching the root, you have to take out your fat and do the reverse nosplasty. It is a consensus now.
Right. So, since this is the medial meniscus root repair, sir, so I went ahead, got 2 bites. After doing the cartilage resurfacing, so this is the first bite which was taken, and then I go ahead with the second bite. So here the question is, sir, suppose sometimes it gets difficult to get 2 bites. So can we compromise anytime by just taking one single bite of the root? And if yes, what type of stitch are we thinking of?
Root repair should not be done with one bite. There is a single answer. you have to somehow take 2 bites, one medial, one lateral, or else one front and back. If their tear patterns go, sometimes people are now recommending that you can go ahead with the, even with the root with the mesanelal sort of stitch. That has already been in the literature. So anyhow, we have to have the proper bite and grip on the root. It cannot be single suture.
And so how far or distance?
No, it's like the meniscal repair. You go ahead with 3 to 5 millimeter distance if you are going from medial to lateral.
So this is what 2 bites were taken, and then I prefer to do the trans-tibial technique. So I had this flip cutter, sir, with the flip cutter, and I didn't have the meniscus, this diamond rasper. So what I do, to the blade of the flip cutter, I try to open it and try to surface the tibial blade, and then with the help of the curate and the shaver, then pass the suture. So as Dr. Seetal said, you can make a separate portal which can be through the transpatellar tendon, or if you are good enough, you can use only with the M and the AL portal, you can do it. So while doing this, we need to take out both the sutures through you have to change your portals to the portal and it's passed on. So what is the suture fixation? Like what all do you prefer, sir? Do you use sometimes the swivel lock or ABS button or the such a suture wheel, sir?
I think IPS has already been told how to fix the meniscal roots.
Sir.
Okay, it can be your bone bridge, it can be bone bridge, it can be endo button, it can be the, your pillar post, it can be a punching anchor. Okay,
anything.
Whatever, the biomechanical, the punching is the best.
Right. This is a post-op X-ray, and this is the mobilization in 2 months. Thank you, sir.
Thank you, Sarthak. Devas is the final comments from you.
So we have seen 3 different cases of meniscal repair. One is a simple bucket handle tear, one is a root repair, one is a third variety. But yes, ramp lesion, the opinion is slightly divided about the so-called ramp lesion though. But the thing is, the meniscus is a thing to preserve in these days, and you have to look at them with that idea. Thank you.
This newsletter is basically will be catering all aspects of sports medicine, sports psychology, sports nutrition, and sports rehabilitation. So the first issue will be inaugurated this coming 1st April by our Padma Shri and hockey field India captain Mr. Dilip Tirke and Commonwealth gold medalist Ravi Kumar. And once the issue is printed, I will be sending my personal email to all of you. Thank you very much.
Thank you. So with this, we conclude. The next session is knee instability session, and for that I would like to call upon Dr. Aminul Haq Pathan and Dr. Naveen Karn to chair the session. Please.
Good afternoon. This will be the knee instability, and this is master talks. We have 7 masters. To begin with, I would like to request Professor Arugumam to talk on IAS ACL registry, why and how. Arumugam sir.
To all of you. At the outset, I'd like to thank the organizers,
especially Dr. Rajiv Raman for inviting me for this unique meeting. IAS and Saarc conference for the first time. It was the idea mooted by our President IPS Oberoi long ago to bring all these Saarc countries close together. And I'm so happy with the pandemic couldn't happen earlier. Now we got all of them in one umbrella. And in the future, we're going to have this Saarc IAS collaboration more. And upcoming conference in Coimbatore, we're going to have a dedicated time slot for Saarc meeting also. So my talk is Indian Ligament Registry. Why and how? Why, in a world ruled by data, we shouldn't be asking this question anymore? Thank you. This is an example of Australian Joint Replacement Registry. Look, what all the information can be get in one slide. I think you need to get close connection. Sorry. Yeah, like number of surgeries and also how many conferences been held with this data and yeah, I think Sachin's. Yeah. Yeah. So not only that, the patient-related outcome measures. So data is the key. We all know that, and we always like statistics, but do we put any effort creating it? We always say yes to innovations, but no to change. How can you create data? It's very easy to conceptualize, but difficult to really bring it on board. Registering data is what we need to do. And if you want to know what is ACL surgery in India, if you just Google it, this is what you get. We get about 50,000 surgeries. There is no authentication, no validation. And medical tourism says so many ACL surgeries in India. But that's not the way how we should project our country in this time and day of the year. Whereas if you put Danish knee ligament registry, they come under the authentic data, how many surgeries being done, the specific numbers. That's what we should be aiming for. So what is ligament registry? There are 7 C's of data magic: data collection, data compilation, comprehension, comparison, capitalization, contribution, and continuation of collection. Okay. Why we need it? It is the prospective surveillance of well-defined patient populations, risk affecting short-term clinical outcomes, example, infection and so forth can be, or thromboembolism, all can be studied. Long-term outcomes representing failure are evaluated. There's a continuous feedback to surgeons and the healthcare centers for patient safety and quality improvement. And various ligament registries are around the world. National ACL registries like Denmark, Scandinavian countries are leading the way. Also United Kingdom and regional based in USA, and India is a new entrant. We look at the Norwegian registry, is first one to be started since 2004, and includes only crucial ligament registry, ACL and PCL. Here the reporting is voluntary. Where the Danish registry came a year after, here the submission is mandatory, and not only ACL, also PCL, and also I have patient outcome measures like TEGDER and KOOS. Swedish one from 2005, again it's identical to the Scandinavian country. So comparison of this all started about 15 years ago, and when they started initially they have only 14,000 cases. Now each country has about 1 million cases, and they have exact data. How many of them is BTB, how many of them hamstring, how many associated with the meniscus, and so on and so forth. And the UK registry, here it is by the National Health System, the NHS, not by individual society. And here also it's not only the surgeon, patient also puts in the data. So with all this, the Indian Arthroscopy Society's Indian Ligament Registry was always a dream. And during my tenure as secretary in 2018, we started with as an app-based. And I must thank Dr. Sanjay Desai, who was donated a fund from the Mumbai conference. And we have the caution deposit, which can be utilized for developing registry. But it started with the app-based. It was not much of the cost. In fact, we didn't have any cost incurred. And it was launched in 2018. What we learned was there was good AL reception, slowly fading interest, and change of office bearers, lack of continuity in the society. So the app-based can't be very comprehensive solution yet. That's what we learned. And thanks to IPS Oberoi, you called me during pandemic. I said, he asked me to restart the registry because that's the way we should go. And I thank him for giving me this opportunity and extend a full support and a free hand, and so that we can create the robust ligament registry. So first and foremost, what we wanted to do was dedicate a long-term committee to foresee and established exclusive registry company, which is already running international registry. We wanted to collaborate with. The registry committee was formed so that irrespective of people come and go, the president, secretary, and the vice president all form the committee. So once we start that, it becomes mandatory for the office bearers to take it forward. It is not dependent upon one single person anymore. Even though to start with, we have a chairman as a ligament registry, but now it can be all the elected office bearer become the part of the committee, so that there is a stability and continuity of this process. So we chose the NECSWS registry form because they have supported and developed national joint registry of UK and Eurospine, and we need to develop a platform which has specific requirements of Indian Arthroscopy Society registry. And mind you, our society registry is different because it's the only one which is by the society, whereas other registry are from the government and proxy government. So we need to have a lot of model approach, adaptation to suit our need, especially how to do the ID. We don't have centralized hospital ID number as other countries. So we need to use Aadhaar. At that time, Aadhaar card was on a debate whether we can use it or not. So it involved a lot of discussions, and we used the good part of the pandemic to have multiple discussions with our European company, and in fact also the cost also involved. The main discussion was about the data security, data entry, and then how to suitable for our conditions. Finally, we were able to strike a deal, and we were able to compile our own registry. And we got about 40 eminent surgeons and started the form validation. And then after that, we have about 95 people tested it, the soft launch. Then finally, we were able to launch the registry in December. I think the video is not. So Indian Ligament Registry is since December 2021, only very shortly bit. After that, we couldn't do much because election of the IAS came. So it's individually designed by the Registry Committee of NEC. Collect not only prospective, also retrospective data. The members can also go back and put their 2 years, 3-year-old data. Entry of patients is voluntary for surgeons, and fully online web-based data collection system, and all government and private patients can be entered, and surgeons enter follow-up based on Degner license score. The challenges what we have is lack of documentation habit among us, and lack of motivation, and apprehension to participation, privacy factor of the identity. So the total case so far, we have only 683, active participants only 34. When we have about 3,000 members, of which about 1,500 are very active members, and now we started to talking to them and encourage them to enter the data, and very soon we will have a very robust system, and our vision is to have a registries based on as many countries, so that we can tie up with ESCON, ESCOS, so the international registry can be formed, and the software could be the same, but it has to be separate data for the legal purposes, and international comparison could be made easily. So the most important thing is to I urge all the members to take it forward and use them in a daily practice. It's like only you can see your data, nobody else can do that. And anybody who wants to do the paper or anything, they have to write to the registry committee. Upon their approval only, that can be shared. In other words, basically it's your own logbook. Now somebody else is maintaining your logbook. You look at that way. And so hopefully within 6 months we have enough data to present the initial data in the forthcoming IASCON conference in September, and I request all the members to participate. We have about 12 international faculties, and after the pandemic we are all eager to see on each one face to face. Is an ideal opportunity, and about 25 plus live surgery, not only knee and shoulder, also wrist, elbow, hip and ankle. So it will be really an academic feast. And thank you all for your kind attention.
Thank you, Professor Agrawal, sir. First of all, I would like to congratulate for this such an innovative Indian registry. Already we were depending on the Western registry. Now we have something from Indian side also. Any question pertaining to this talk? Sir, one thing I want to say that whenever we are filling this registry form, there is a patient Aadhaar card is mandatory. So patient from Nepal will not have that, or our patient will not have that. So feeling that might, so if you can make a simple any identity proof, that will be okay.
See, the ID proof is the main thing, which has to be, as far as India is concerned, Aadhaar card has become routine. Everybody is happy to share the ID and the Aadhaar card. When we started initially 2 years ago, a lot of apprehension, a lot of cases was going on in the Supreme Court. Now it is kind of standardized. As far as the India concerned, patient's ID, the Aadhaar card is mandatory everywhere, wherever you go. So not an issue. But Nepal, I don't know if you have some similar system, or you have to do a driving license or some authenticated government ID is important, or ration card. Otherwise, it will be difficult to have the authenticity of your data.
Okay. And some surgeon is posting something. What is the privacy of that document, sir?
100%. Nobody else can see, including us. And only I can see yours, other surgeon cannot see, even though the registry committee, they cannot see this documents, okay. So individual.
Okay, thank you, sir. Now another talk is the post-ACL in reconstruction, instability and inflammation, assessment and planning by M.N. Basu Malik, sir.
Run fast enough, or there is a group of people who will come to you and say, see boss, my knee is still subluxating. So they are voluntary subluxators. They will come and demonstrate that the knee is subluxating. Okay, what are the reasons behind it? Okay, there's a whole lot of reasons. The first thing that comes to mind is a failed ACLR, and we are not looking at that in this talk. So that is something which will be tackled by somebody else. So that group is there, but we are trying to look at a group who has got an intact ACL but are still unstable. So there are a whole lot of reasons that I have found or that I have been able to sort out. I'll go into some of them slightly deeply, and some of them we can discuss. The first is an ACLR failure. We are not looking at ACL rupture per se. We are looking at this kind of a patient, a 24-year-old male footballer who has had an ACLR in the left knee 36 months back, which is doing perfectly well, and the other knee 18 months back, which is not doing as well. So he has got a feeling of instability in the right knee. If you look at the X-rays, look good enough 18 months down the line. If you look at the MRIs that have been done, it shows that the ACL fibers are intact but loose, lax, and there is a sort of impingement. Now, because both the surgeries were done by the same person, it is difficult to say that the operation was not done well. It was probably done well enough. So what could have happened? One, my thinking is probably there's an osteophyte there which caused the impingement, caused the ACL to become loose, and now the knee is not stable enough for him to perform well. So it's this kind of a partial ACL failure. It's not a complete ACL failure. It's a sort of partial ACL failure which can give rise to instability. The second thing is a residual instability coming from a different ligament. So if you see this patient walk, he is complaining of instability post ACLR. You can see that there is a lateral thrust. So this patient definitely had a LCL and a PLC injury, which probably went unnoticed during the primary surgery, resulting in his having a persistent sense of instability, poor proprioception, unable to stand on that limb, unable to gain that strength from that limb. So this is another case, another pattern of cases where there is some residual or missed ligament injury here. The third pattern is a residual fixed flexion deformity. If the patient has a fixed flexion deformity which the patient has not been able to completely address, the quads are always going to be weak. And because he is walking with slightly flexed posture, his quads will get fatigued out. So in a period of time, he'll start complaining of pain and also slight buckling of the knee. So it's nothing to do with the ACL per se, it's something to do with the range of movement. These patients can also be stiff in flexion, but the problem comes with loss of extension more than the loss of flexion. The fourth pattern is this one. This is called an active pivot shift test. The patient will come and show you that the knee is subluxating. Okay. There is some mention of literature of these kind of patients. All patients who have been operated end up with the same symptom post ACLR. So these are bad candidates for surgery. There's probably some kind of functional issue involved, some psychological issue involved. So they'll come to your clinic with this. Pre-surgery, then you operate, 6 months later he'll still come and show you, see boss, my knee is still subluxating. So these are voluntary subluxators, not good candidates for surgery. They'll never be stable. The other causes that we'll slightly look is weak quads, which is from poor rehab or from pre-operative wasting or post-operative wasting. Wrong ligament surgery. So somebody has a PCL injury, it was not picked up in MRI. It was not picked up in arthroscopy. So somebody goes in and does an ACL by a wrong diagnosis will still have some sort of an instability. A significant anterolateral capsule or a ALL injury. So if that goes unaddressed, because we don't often do ALL primarily, we would usually do it only in a very profound pivot shift or in a failed ACL scenario. So a residual ALL laxity can give you a sense of instability. If the patient has had a complete meniscectomy, meniscus has this door stopper effect. It adds to the stability of the knee. So ACL with a meniscus will perform much better than an ACL with a meniscectomy. With a meniscectomy, the knee is going to be slightly unstable because of, especially the posterior horn has gone, because the door stopper effect has gone. The other issues are, of course, poor rehab and functional issues, means if they are not rehabbed well, if they don't have good proprioception, they are still going to feel unstable. Now looking at the second part of the problem, which is pain and inflammation. Patient might present with a persistent pain and swelling, or a intermittent episodes of effusion, or a chronic pain, warmth and stiffness. These are the three situations that I have faced in my life. The first thing that comes to your mind and that you must rule out is infection, but we are not looking at that issue. The other issues would be having a ACL done in an arthritic knee. So if the knee is arthritic, the patient has had an ACL injury probably 5 years back, then there is a Shastro Shati card and suddenly he has got money to get operated, and he comes and joins you, and you are dying to operate post-COVID, and you get an operation done. These patients are never going to be pain-free because the arthritis has already set in. These are painful knees. He comes to you thinking that the instability will go, the pain will go and everything, and you probably give him slightly optimistic picture, yes it will go, yes it will go, but it will not go. The Shastrasati money will go, the pain and swelling or some sort of a problem will keep on happening. So beware of operating in an arthritic knee. You should operate. I am not saying you should not. You should operate, but you should warn the patient that the pain will probably not go post surgery. It's only the instability that's going to go. Second is leaving behind bone and cartilage debris. An ACL surgery, especially with an ACL and a meniscus surgery, will generate some amount of debris. So it's very important that we wash it out. If you leave behind cartilage debris or a bony debris, they are going to cause synovitis, they are going to cause joint effusion, they are going to cause pain and locking. So it's not going to come up on MRI, it's not going to come up on X-ray, and you'll be thinking that why this problem is happening, where it's probably related to some kind of a residual debris or a bone thing. The third thing is retained sutures. So now we have two kinds of sutures, one which are absorbable, orthocord, made out of polydioxanone. So even if you leave them back in the joint, they are going to dissolve in probably 300 days. But if you end up leaving behind a non-absorbable suture like Ethibond, so if this kind of a suture remains in the joint at the end of surgery, so there is a possibility that there is going to be some amount of reactive effusion. So this is not a good idea to leave non-absorbable sutures inside a joint. The other thing is, of course, synovial plica. Synovial plica is physiological, lots of people have it, but once you have an ACL surgery and a hemarthrosis, this plica can swell up, and then it starts giving clicking and pain and swelling and intermittent. The last thing that I must mention, and you must note it down somewhere, that CRPS. Anxious people post-surgery will end up with a reflex dystrophy, which we know as complex regional pain syndrome. And they'll keep on coming back to you with stiffness, pain, the area will be warm, you get an X-ray, there will be osteopenia, and you are thinking so many things, maybe stiffness, maybe this, maybe that, maybe infection, but also keep in mind a possibility of CRPS. Thank you.
Thank you very much, sir. If any question pertaining to this talk?
To deal with those patients, so any...
Refer
to your good friend. Yeah.
No, refer to your seniors. Kanchanda is there, Devashish Chatterjee is there, why worry, man? Yeah.
Yeah, you brought about a good point about you should not have permanent sutures inside the joint.
Especially Ethibond. I think the culprit is Ethibond, not the modern ones. Ethibond
so
is
what do you take about fiber tape inside the joint?
Fiber tape, orthocord, these things I have not seen any problems, but I have seen problems with Ethibond.
Orthocord will slowly start getting absorbed.
Yeah.
But this fiber tape thing will stay permanently inside. So what is your take on this?
I think these new materials that are coming up is probably less reactive or less allergenic than Ethibond that we have. Ethibond, whatever reactions I have seen is seen with Ethibond. I have not seen with the newer ones.
IPS, you want to make a comment?
I think I strongly recommend not to use any kind of synthetic material inside the joint, and they are good enough for extra articular ligaments. So that's my stay, and I have removed so many of them, including fiber tape, so I am not very happy.
I think the fiber tape is more notorious than your Ethibonds.
Could be. No, I am just saying, I am just mentioning this is because this patient will come to you and you have not operated. You don't know what happened during surgery. And then you are left scratching your mind, why this is not settling. So that is a problem. If you are a primary surgeon, you should take care that this should not happen and this patient should not have problems. The problem comes when you are not the primary surgeon. You don't know what's the issue. As I said, it's very difficult to pinpoint what is causing the instability, but what I have tried to outline here is what I have thought could be the reasons, what I could find in literature. Every time I have this kind of a case, in my case of mine, I go back to the literature, try to find a solution. And it could be any of these. It could be poor rehab, it could be some kind of a meniscectomy done, it could be a lax ACL, the graft was probably not tightened, it's probably stretched out something, it can be a residual baton, it can be some functional issue. I am not saying it's easy to pinpoint, but I'm just giving you an outline of how to think along these lines. There are no single answer to these problems.
So in these patients, does your rehab plan changes? Because these patients, sometimes those are very painful knee.
Yeah, sometimes they are painful knee. Sometimes they are painful knee. I love if some rehab guy takes the patient over and takes my problem away, but unfortunately we don't get them. They keep coming back to you.
And there are some cases on clinical examination after about a year maybe. If you do Lachman test, you get some laxity and you do not get that sensation of good heart endpoint. But patient is asymptomatic. But some patients, you have good heart point, but this patient is still...
I know the answer to this, but I will not answer. I will request Kanchanda or Devchat or to answer it. Devchat, this is an issue. There are some patients, a lot of patients who come back to you 1 year down the line, patient is asymptomatic, but the latchman is 1+ firm, not 1+ hard. So, that's his question. Yeah, he is going to talk about.
Yes, it does happen for so many things. Number one, your fixation, which was there on day 0, may not be exactly the same on day 1. Number 2, some grafts, all grafts, they do stretch, but may not be in the span of 1 year. Number 3, your rehab may not have been proper. So many things might contribute. But if the endpoint is firm, just about 1+, then it is unlikely to be grossly symptomatic.
Yeah. There's one addition to what you pointed out.
Yeah.
Patient has no symptom. If he's come to me after 1 year, an ACL, he has symptoms. Or he would not be here.
Thank you, sir. If there is
how to deal with the aseptic effusions? So out of 150 or 200, one patient comes. Whatever you do, whatever investigation you do, nothing will come out.
So I'll tell you what I do. I usually aspirate twice. Every time I send it for culture, even if this problem comes back a third time and I aspirate and I find there's a clear fluid, I don't know whether it's sterile or not. The third time I give a steroid injection intra-articular. So but I try to give steroid only after first 3-4 months, not within the 4 months, because I know the tissue, there's a dead tissue inside. So try to hold on for 4-5 months.
Seniors, Kanchan sir, anything from your side? Aseptic effusions.
It sometimes happens, yeah.
Very hard to handle. For these, I consider if it keeps coming, for me it's infection unless proven otherwise. I really do not think they're aseptic. In my case, I go ahead and debride them. I'm not a steroid person.
I think there should be a clear consensus of giving the steroid in post-ACLR. I think this should not be recommended that at any point of time, within a span of 1 year, you go ahead with any steroid shot.
I agree. It's not a good thing.
It's not the answer to it. It's not
no,
the answer.
I didn't say the answer. That's what I said is what I do. I'm not saying this is the answer.
That's why I'm asking, because probably Kanchanda, Devasisda, they have got the maximum experience of doing ACL in this part of the country. So I think Kanchanda, Devchat, they has never put steroid inside the knee post-ACLR.
Thank you, sir. Thank you. May I request Dr. Devasis Chatterjee, sir, to talk on failed ACL assessment and planning.
Right. Hello. Yeah. So I'm talking on failed ACLs, the assessment and planning. First of all, what is a failure? ACL failure basically means one of the 3 things. Either there would be recurrent instability, both subjective and objective are important, but subjective in my mind is more important. If the patient is complaining, take care. Usually they say more than 6 mm of difference. Then other causes of instability can also come. We'll talk about that. Also, stiffness, if it is there, both lack of flexion beyond 90 or even an FFD of more than 10 degree is also considered as a failure following an ACL reconstruction, or if there is a pain persistent or intermittent, and other causes just we discussed like effusion, aseptic or otherwise, infection. These are all considered as a failed or failure of ACL. Let us take them one by one. First of all, the instability. We know that instability is commonest con is a non-anatomical tunnel placement. There are different types of examples. You have seen the femoral tunnel, too anterior is the commonest and usual from the beginner, or a vertical or a posterior thing. The tibial tunnel, anterior or posterior, medial or lateral, they all can cause instability following an reconstruction. As also is a missed associated injury, associated MCL or PCL or posterolateral corner, which was not addressed properly. And also the graft failure. Graft failure can be either due to poor fixation or poor tensioning or poor isometry, or due to failure of graft incorporation, that is a biological thing, or that could be due to a repeat trauma or undue physiotherapy. Stiffness, we said, because of poor rehab or poor technique or infection, rarely something like CRPS, and pain usually from the patellofemoral joint, commoner from using the patellar tendon graft, or if there was a pre-existing femorotibial osteoarthritis, the donor site pain, etc. However, if you combine them all, the common causes of failed ACL is either a non-anatomical femoral tunnel, or a poor fixation, or a poor post-op management. Also there is the wrong diagnosis or missed diagnosis and repeat injury and non-compliance. So how do you assess them? The main thing is to see what is the main problem at this point of time, whether it is the instability or pain or stiffness or a combo. And beware of the weakness and pain combination. Very often, especially middle-aged patients who are rather housewives and that sort of had done an ACL, quads weak, persistent pain, beware of them. And if it is instability, then what is the cause? The non-anatomical tunnel, or missed associated injury, or graft failure, or what? So how do you handle them? Document the primary procedure, the injury, surgery, the post-op details, your return to sports whenever times, and your recurrence, the date, type of injury, and symptoms. Examine, look for the scar, the swelling, the muscle atrophy, the gait, and the limb alignment. Feel the temperature or effusion or trigger points or tenderness in case of CRPS, for example. Range of movement, especially if there is any FFD. I would not mind my patient having slightly less full flexion, but FFD is absolutely unacceptable. And then also do the special test for cruciates and collaterals, especially the pivot shift and Lachman. Imaging, plain X-rays, both the AP lateral and the standing to see the alignment and the joint degeneration. The MRI to see the graft position, the tunnels, the meniscus and the articular cartilage damage. 3D CT to assess the tunnel and widening and positioning, and rare cases technetium scan for infection or CRPS. How do you plan from here? After you have identified that this was the main cause possibly, plan from there. As I said, identify the problems in your subsequent surgery. Think of whatever grafts are available, whatever hard issues are there. If there is any interfering or wide tunnel, if there is any associated injuries, whether you do it in 1 stage or 2 stage. 2 stage is especially helpful in case of stiffness or infection or severe synovitis or synovial fistula. And please, please have a realistic goal and expectation, both you and your patient, because it has been established that the overall patient satisfaction after revision surgery is less than the primary one. Choice of graft depends on the grafts available and the existing tunnel and patient's functional demand. Usually in our country, ipsilateral grafts are preferred. The patellar tendon, quadriceps, peroneus longus, semitian gracilis. If necessary, the opposite side can be used, but our patients generally do not like that. Allografts were available, not with us. Use the strongest, thickest available graft because it is stronger and it can fill up a wider tunnel, eliminating the need of a bone graft marginally. Hardwares are removed only when they interfere with proposed tunnel. It requires extra operating time and struggle, so plan for that. And oftentimes they will cause loss of bone stock. Arrange for appropriate instrumentation, screwdrivers, staple removers, etc. Use appropriate knee flexion and appropriate portal. If there are bias screws there, they can jolly well be over-drilled. The tunnel problems are, of course, at times significant. And in my book, the femoral tunnel can be of 3 types. Both femoral and tibial. It can be a well-positioned tunnel, which is perfect, so I can reuse it, no problem. Or if it is a grossly mal-positioned tunnel, no problem, make a new one in the correct place. The problem is, if it is a partially correct tunnel like this, in those cases, you have got only 2 options. You can use a bigger tunnel in the correct place, incorporating the previous one. If that is not possible, then you have to go for a 2-stage surgery. You have to bone graft the tunnel first and do a reconstruction after 2nd stage. There is another dreaded thing, that is femoral tunnel blowout. When the posterior wall of the femoral tunnel is gone, there are different ways to take care of that. You can use a over-the-top fixation using a lateral post like good old days. Or you can use a bigger button as a fixation suspensory device known as mega button and different names. Or very commonly people change the angle of the femoral tunnel so that they can come in different places. Suppose if this is the previous tunnel, this is the previous tunnel, you actually make a different angle so that it is coming out anatomically at the right place internally, but externally it comes out in a different place. These are all different ways suggested to handle a femoral tunnel blowout. 2-stage surgery, usually 4 to 6 months gap is used. It is used when there is a stiff knee with a poor graft. You do an arthrolysis first and revision later. Or if it is a gross wide tunnel, then you have to bone graft first, as we had just said. Or if it is an active infection or severe synovitis or with a synovial fistula, then you have to remove the remnants of previous ACL graft and hardware and synovectomy and do a revision later. So in conclusion, the reasons for the failure of the primary ACL must always be identified whenever possible to ensure optimal management. The choice of new graft, removal of hardware and treatment of associated injuries and defects must be taken into account. Establish a realistic goal and expectation. Ensure good vision during surgery, add notchplasty if needed. Make sure that current tunnels are made because that is half the job. Take the thickest available graft. You don't want to come back here 3rd time. Plan the fixation accordingly. Plan and execute the rehab accordingly. That is very important. And always have a plan B. As they say, plan well, counsel well, and prepare well. Thank you.
Thank you very much. It's open for question now.
primarily BTB was done, and after 1 year due to again re-injury BTB failed. So, and he want to continue with the sport. So what would be the option?
Well, I mean, if it is established that this is, I missed one slide, that what they call is an early failure or late failure, meaning that after the operation, the patient was well, went back to his normal function, and then had the problem, which usually means it's a trauma, post-traumatic thing. In such cases, you do a revision surgery with whichever graft. If it is, I mean, it's a elite professional player, you can talk to him, think about using a peroneus longus, which gives you a very thick graft, or you can use semity and gracilis together. That is also established practice.
Primarily, the BTB was put in the mind that he is a high-end sports person, so we'll prefer to do semity with the revision of BTB or using,
Personally, I don't have a problem. About 3 years ago, in they did a this thing survey of the American sports surgeons. Yes, a bigger number they use BTB graft for body contact games, almost 70%, but still 30% use semity and gracilis there. Nothing wrong with that.
Sir, in revision cases, when do you add lateral extra-articular tenodesis?
Never.
Any other question? If there is no any other question, thank you very much, sir. Now
Thank
we'll
you.
proceed with the next talk, that is ACL avulsion by Dr. Amrish Jha.
Open means I also managed to get this picture, maybe it's in open scenario, and then came SS wires. So I am not going into that. So there are numerous techniques like screw fixation, staples, SS wires, probably K wires, anchors, and the latest one being suture pull-out techniques, where number of tunnels and number of sutures are important. So what are the challenges in ACL avulsion fixation? We have to get a good hold on ACL stem as well as on bony fragments. We should avoid fascial damage as much as possible in pediatric age group. And the prevention of complications should also be our concern, like FFD, arthropibrosis and other complications. Although there is nothing called ideal, but for me it's a strong fixation, the method which gives me a strong fixation and allow me to do early ROM, and the method which I know hardware prominence in the joint with the minimal damage to the growth plate, and it should be surgeon friendly and require minimum instrumentation in average setup. To start with, a child came with this, so relatively it's a normal X-ray, but when we see it minutely, there is ACL avulsion, undisplaced avulsion, and probably this is the thing we should not miss. Otherwise, it may go to this in the later stages, then someone tried for this, and it remained ununited, and finally it has to be reconstructed. So, in pediatric age group, it's very common. ACL avulsion, it's a major part of the knee injury, and we should look into it. This screw fixation, there are advantages, and in some scenario, if the bone chunk is larger, so it's a good option. But the problems being, it's a decreased screw purchase in some cases, especially if the fragments are comminuted. And definitely it causes some fascial damage, and maybe later on it require hardware removal in case of impingement or some other problem. So there are issues with the directions, length, and the fascial injury, and sometimes comminution and back out of screw. Then came ACL staples, which our seniors used. So even if it was reduced and fixed very well, we have seen these complications, back out of staples, flaring of staples and other complications. And in few times I have seen it required removal of staples as well. So currently we are towards suture pull-out techniques. It's supposed to be the ideal technique till now. It gives us a strong fixation, minimum damage to physis, early ROM, but there are a lot of controversies regarding this suture pull-out techniques. There are numerous numbers of techniques as well, but the final consensus is we should use 2 smooth, low diameter tunnels, and the tunnels should be as peripheral as possible, especially in pediatric age group, to minimize the damage of physis. Use of too heavy non-absorbable sutures are recommended, and the compression over the broad area should be there. So one of them is suture bridge technique. So this is a ACL avulsion on arthroscopy. After reduction with the probe, we pass a guide wire through the medial side, then through the lateral side, and through the suture shuttle device we pass the suture one from the and retrieve it, one from the medial and then from the lateral. So this is how it looks, and then we have come up with these two threads with the 4 ends. Now what we do, we just tie the knot in the lateral thread and pull it through the portal. So what it causes, it causes sitting of the left out part, anterior part of the bony stem, and after that I just retrieve it and tie it with the, you can use suture anchor or disc or some any other device. So this is our final picture. In such cases, the post-op protocol remains. If it's a screw fixation, we provide early weight bearing with the brace for 1 month and then off brace 2 to 3 months. And if it's suture bridge technique, brace immobilization for 15 days, knee mobilization out of brace at 15 days, and then full weight bearing with the brace on for 1 month and then off brace by 2 months. So this is a case, this is somewhat rare case of ACL. It's a 14 years male patient. His body weight was 112 kg. He fell down from the bike, and routine MRI and pre-op was suggestive of ACL avulsion. Unfortunately, I don't have his MRI pictures, and I could not retrieve the video of intra of video also. But what here, it's a comminuted ACL avulsion with peeling of ACL substance from the bone. So there are bone pieces as well as ACL substance injury along with a big osteochondral fracture. And in this case I had to open it. I fixed it through the suture, and the big osteochondral fragment was fixed by the screw. It's a 5 years follow-up, having full ROM, and there is no instability. This was a somewhat rare scenario. So this was the pre-op picture. On scopy, what I found, there were loose chondral pieces between the ACL attachment of the tibia and PCL attachment of the tibia. That means it was neither the ACL avulsion nor the PCL avulsion, although few fibers of posterolateral ACL was involved, but major chunk of the ACL was intact. So I removed the chondral fragments, and after removal of the fragments, I found it stable. And the post-operative, I did not reconstruct it and left it as it was. And post-operatively, patient is doing well. no signs of instability after 3 years of follow-up. And this is a simple ACL avulsion fixed by pull-out suture and suture. Patient is doing well. This is a simple, normal pull-out double tunnel technique. Thank you.
Thank you very much. Any questions? Dr. Jha, for I am here. Hello. Just ACL avulsion. No, after what duration you want to go ahead and do the suture bridge technique, or you go ahead with the reconstruction?
No, if it's a avulsion.
Duration I am asking, right?
Avulsion, as soon as possible.
No. Patient has come to you. Up to what level after injury you will go ahead and do the fixation rather than going to the ACL reconstruction? Any duration? Maybe patient has come 6 months, 9 months. So any duration?
No, if in X-ray and MRI there are no sclerosing of bony margins, and if there are chances of healing, maybe up to 3 months.
Okay. Any case of physical injury you have encountered in pediatric age group with that drilling?
No, I have done, as I have shown here, I have done 2 cases with screw fixation in pediatric age group. Because I have started suture bridge technique just.
No, with suture bridge technique we drill in tibia.
Yeah.
So in pediatric age group, you might damage the physis, no?
But it's a 2.5 mm.
So you have not encountered any problem by now. Okay, thank you.
It's a smooth pin, and the diameter is 2.4 to 2.5 mm.
Okay, thank you. Thank you very much. Now may I invite Dr. Ritik Kangoli for his talk on revision ACL.
Good afternoon. So my talk and the thing has been very much covered by Dr. Debashish Chatterjee sir, and there is lots of controversy regarding the failed ACL and revision ACL reconstruction. There are various literature in controversy. So I am just give an example of this is a case. This is a patient with 30 years with recreational sports activity, having that instability 2 years after injury, or 2 years after reconstruction. So this ACL is not going to help, not going to give the stability at all. So the plan was to remove the ACL, the stump, the ACL remnants, and revise. So basically for that the proper evaluation is required. The previous implants was removed. It was fixed by interference screw in the femoral side and in the same in the tibial side. Then we have to take care of the femoral tunnel. The femoral tunnel measured, but it was very difficult through the portals, the anteromedial portals. So we have done by outside in femoral drilling technique here, and we have taken the peroneus longus graft for reconstruction and the fixation with the screws, interference screws. So basically there are 3 things in ACL failure when there is in combination or in isolated. There is instability, pain and stiffness. It may be only pain or only stiffness in a post ACLR situation. So we have to address each and everything. So always restore range of motion, strength and normal gait prior to previous ACL surgeries. Sometimes patient may present with stiffness and the quadriceps power is weak, and proper physiotherapy and exercise will do the job. So revision ACL reconstruction may not be required in that in some scenarios. So there are technical errors. Most important error is tunnel malposition. The failure to diagnose the other problems like other ligament injury, PCL, PLC injuries, the root and lamp lesion. The malalignment issues is very common. So we have to take the orthoscanogram in revision cases to take care of if there is revision, there is ACL tear, sometimes slope correction osteotomy. The slope correction of the posterior tibial slope correction osteotomy may do the job. Sometimes generalized ligamentous laxity may present with this failed ACL after reconstruction. The inadequate graft or the premature amputation of the graft, improper graft tension during fixation at the tibial site, inadequate fixation is the cause of the failure. For revision, the history is most important. This includes the patient surgical history. Previous surgical note is very important, including the graft, which graft has been used, which fixation has been used, whether there any other intraoperative mishap, whether has occurred or not. The gait of the patient is very important in examination. Sometimes the old PLC injuries may present with this lateral thrust gait, and in that scenario sometimes we may get this genuverum. So always this correction of the alignment should be done before any ligament surgery. And the radiological studies in revision cases, the CT is more important than the MR, because in CT we have to check for the tunnel, that the enlargement of the tunnel is very important, and the proper positioning of the tunnel. If the tunnel is enlarged or it is not in the proper place, then we may require the two-stage procedure. So these are the technical aspects. The graft selection is very important. If it is the semitendinosus graft is used, then we may take the BPTB graft or the robust peroneus longus graft, because allograft is not our in hand in our scenario. The hardware removal is very much crucial, because sometimes there may be broken screw. So proper armamentarium should be there for broken screw removal from femoral side. The bone tunnel management is important. The graft fixation and the associated ligament injury management is very important. So bony tunnel should be anatomically positioned in both the femoral and tibial side, and the new tunnel position must not be compromised by the previous tunnel or hardware. Now there are three situations. If it is the perfectly alright tunnel, then we can use that femoral and tibial tunnel, and we remove the implant, take out the new graft and fix it. If it is perfectly incorrect, then it is easy. Then we may drill the new tunnels and may or may not fill the previous graft. And if it is partially correct, then there is a matter of this tunnel enlargement and tunnel overlap. It may require the two-stage procedure. So in CT scan, if the tunnel is more than 12 mm, then it is recommended to go for a two-stage procedure. So for two-stage procedure, we have to enlarge the tunnel and take the graft, and through this guide wire, this graft is placed over the femoral tunnel. And for the tibial side, we can use a syringe. We cut the syringe, we put the graft, make a proper shape, and that tibial side, the void is filled with the graft. And we have to wait for 4 months to 6 months for the graft to unite for revision ACL reconstruction if at all required. AL reconstruction is sometimes required when there is a grade 3 pivot shift positive and there is active participant, the players, the elite athletes, and after the revision ACL, there is still the latchman is positive or the pivot shift is positive. Then ALL reconstruction is recommended. Now this is our case, another case. This is a 28 years male, history of recreational activity, history of ACL surgery 6 years before, but for last 4 years, patient presents with history of buckling and instability. But there was no history of significant trauma. And we examined the patient, there is everything was normal, there is no posterolateral laxity, the drawer, the anterior drawer is grade 3, the pivot shift was positive, and the other tests are negative, and the patient having fairly good range of motion. This is the X-ray preoperative. This is done elsewhere. We have done the orthoscanogram. It shows there is no genuvarum deformity. And this is the MR, and it shows the tibial tunnel is anterior, and the anterior and medial, and femoral tunnel is too anterior. This is the intraoperative pictures. The ACL graft is loose and lax. We have taken out all the implants and graft, and we have created the new tunnels in the femur, and the peroneus longus, the same peroneus longus graft has been taken and is fixed. This is the post-operative picture, and the patient having good functional range of motion. So ACL revision is a technically demanding technique. The preoperative planning is very important, and proper counseling is important, as the most of the athletes are the only earning member, and the emotional trauma has to be dealt with, and anatomic reconstruction is mandatory. Thank you.
Thank you, Ritik. Any question we have?
Yes, sir.
You only do ALL, no LET, and let's say what percentage of your revision ACLs get an ALL?
Sir, if the patient after this ACL reconstruction having this latchman or drawer positive, then we, and he is a elite athlete, then we may add on this procedure, ALL reconstruction. It is recommended to add on this after the procedure if it is lax.
Sir is asking whether you are, for the revision scenario, whether you are going to go with the ALL or the LET?
ALL.
ALL. I think the recommendation probably Devashish sir and all the senior people, they will, he is not doing, but for the pivotship and everything, it is better to do the LET.
Okay, sir.
Not the ALL.
Devashish sir completely disagreed. He said no,
LET. He told that he is not doing any lateral procedure.
Okay.
But I think recommendation and everything is that Kanchan sir will agree that it is better to do the LET rather than the ALL, because the ALL graft is very thin.
Yes, the ITB. Okay.
Any other question? Okay. Thank you. Thank you, Ritik. May I invite Dr. Ishwar Pradhan for his talk on ACL blues.
I think everybody is getting hungry, so I better finish this on time so that we can have our lunch. Where is it? Is my slide? Why is it not coming there? Anyway, I think it's always, it's been a pleasure to come to Calcutta, to take part in this first IAS Saarc Sportsmedcon. It is an honor for us. And I would like to thank the Kolkata Arthroscopic Society for inviting us and giving us the hospitality, very nice hospitality. History of the fraternity of Saarc arthroscopic surgeon. Well, I come from Nepal. I bring greetings from Nepal to all of you here. So this is the place where I work. This is the BNB hospital at Kathmandu. And this is a general hospital, and it's a pretty busy hospital. And the hospital was started long time back, and the founder and the owner of the hospital are these two gentlemen. My boss on the left is Dr. Banskota. Maybe some of you might know him. And the one on the left is his colleague, neurosurgeon colleague, who started this hospital. We have a big orthopedic department, and we are the most busiest department here, and we have a lot of specialties, sub-specialties there, starting from all the spine, arthroplasty, and everything there. But the arthroscopy unit there, we call ourselves the AKB Center for Arthroscopic Sports Injury and Regenerative Medicine, and we are the #1 department there doing a lot of arthroscopic work since our establishment in 2018. So coming back to the topic of my talk, you know, ACLR blues and bailout. So we all know that ACL reconstruction is one of the most commonly performed arthroscopic procedure, and in the US alone, more than 400,000 ACL reconstruction are done annually. But we don't have any data of this in our subcontinent. Maybe the Indian Ligament Registry is going to give us some guideline on how much ACL reconstruction we are doing in our continent. ACLR is an exacting procedure, and if executed efficiently, it gives good result. Problems and complications do arise and reduce the success of the procedure. So we know that the basic 3 steps of the ACL reconstruction, the graft harvesting step, the tunnel placement, and the graft fixation, you can land up with problems at each of these steps. So going to the first stage in which we harvest the graft, most of our graft in our part of the world we use autograft, and we all know the most common ones used are the BPTB and the hamstring. Initially all the ACLR started with the use of BPTB, but now more and more people are using the hamstring graft, probably because it's very easy to harvest it, and of course because of the low morbidity at the donor site. Even then you can have problem with the graft harvesting of the hamstring graft harvesting. When you make the incision there to harvest the graft, you can injure the infrapatellar bands of the saphenous nerve. You can see that the saphenous nerve comes in the anteromedial aspect of the knee, and people say that if you boot your incision more obliquely and in a flex position, you have lesser chances of injuring the infrapatellar bands of the saphenous nerve. The other complication as can happen is you can injure the medial collateral ligament. This is very rare unless you are a very careless surgeon, but if you know the anatomy, you have a very big potential space between the MCL and the pes anserenus. So if you reflect the pes anserenus like that and take the graft from inside, you are less likely to damage the MCL middle collateral ligament. The other complication is that you might cause a premature amputation of the hamstring graft. For this, you must understand that there are a lot of these fascial strips going from the calf to the tendon. All these fascial strips called vinculas, which you must identify. And properly release all the vinculas and make sure that the graft crosses over the tibial crest and it is free to for you to pass your tendon stripper. The most fair complication, I would say, in a harvesting of hamstring graft is that you can land up with inadequate graft size. the surgeon has no control on the size of the grafts, no matter a skillful surgeon, because the graft size is dependent upon the patient's anthropometry, you know. Patients who are tall, male patient, muscular athlete have good diameter graft. The problem is in our part of the world, in Nepal, we are coming across all these young female workers who ride scooters and they accidentally turn over and injured their knee. And for this, we are now using more alternate grafts like the peroneus longus and the quadriceps tendon. We all know that we harvest the semity first and triplicate it, and to make it to a better size, you can quadruple or pentapole the hamstring along with the gracilis. We don't use that much of BPTB, but there are reports that you can land up problem like the patellar fracture, and you can land up with a small thin bone plug. The solution is that you should be using a specialized saw and cut the cortex at 90 degree and 45 degree to a depth of 6 to 7 cm. Avoid making deep cuts and gently lift the graft with your osteotome. This is a funny thing, but it does happen, you know. If you drop a graft, it's going to be a problem. So to prevent that, you should keep it wrapped with a gauze or a mop and clip it. Always pass the graft with a tray underneath. If you do drop the graft, the solution is cleanse the graft with a 4% chlorhexidine solution for about 30 minutes, and followed by dripping the graft into a triple antibiotic solution for 30 minutes. The other thing is you can use an alternate graft, but after you use an alternate graft, we have to do a lot of counseling post-operatively to the patient. The most feared complication in the femoral tunnel placement is the posterior blowout. Dr. Laprat came out with a review article about 4 years back, and he recommended that he identified that you can have a posterior blowout at the aperture of the tunnel near the middle aspect of the lateral femoral condyle, or within the tunnel throughout its length, or you can just over-rim even up to the lateral cortex and cause a lateral cortical bridge. He recommended that to prevent this complication, you should have a good exposure of the posterior wall by removing all the surrounding soft tissues and adequately visualize the posterior lateral notch. He also recommended that it's better to use a femoral offset guide to make your tunnel. This will leave at least 1.5 to 2 millimeter distance from the posterior wall beyond the planned tunnel radius. The other thing he recommended was to do the drilling in a stepwise manner. First at 90 degree of the knee flexion, ream and score the footprint, then back up to directly visualize the confirmation of adequate posterior wall, and then hyperflex it to 120 degree to make the tunnel at a depth of 2 millimeter, then to the fold depth. After you make your tunnel, you should carefully inspect the tunnel to make sure that there are no breaches through the anteromedial portal. How do you manage the posterior blowout? If the blowout is within the 5 millimeter of aperture, you can continue with your aperture fixation or with a suspensory fixation. But if you have a whole posterior wall blowout, interference screws cannot be possible to be used, so you have to use a suspensory fixation, either endo buttons and supplement it with, or use a post with staple. If you breach the lateral cortex, it was mentioned here, you can use what is called an extended endo button or a mega button, or you have to go with the use of post and staples. The other solution is you need to make another portal from the outside in technique, making the tunnel more anteriorly and laterally. You can have problem with the graft passage complication, like a tight tunnel causing graft laceration. This is just because of the mismatch between the graft and the tunnel. So what you have to do is you have to re-drill the tunnel with one size bigger reamer. You can have a loose graft in the tunnel. This especially happens in the tibial side. You can reinforce with additional cortical fixation using post or staple. Graft fixation can occur whether you use an interference screw or an endo button. With an interference screw, your graft might rotate around the screw. So to prevent this, you should pull tightly both the ends of the graft and keep it in tension while putting in the screw. You can cause laceration of the graft when you put on the screw. This is because there is a screw and tunnel mismatch. The bias screw or the interference screw can also break during insertion. This is also because there is a screw tunnel mismatch. The guideline is in femoral tunnel, you use a screw size that is equal to the graft diameter, and in the tibia, you use a one size larger. The other solution is you can notch the aperture when you put your screw in. Graft fixation problems with endo button, you can have the button flip outside the quadriceps, and you can have the button flip inside the tunnel. The cause of this is your calculation to measure and use your endo button may be improper, and you might fail to mark the graft to see what you are getting into. So it's proper to mark the graft. So if you land up with the button flipping outside, what you can do is, this can be also done by your enthusiastic pull of your assistant, if you can't control him. So the solution, if you have a button flipping outside the quadriceps, you have to open it from the femoral side, split the quadriceps, and push the button down. The other thing is button flipping inside. I think this is a little bit, theoretical thing, very difficult to diagnose. What you can do to prevent that is pull the lead thread to the reverse, then flip and pull the graft down. So to conclude, ACLR is a very exacting surgical procedure. You have to have a meticulous pre-op planning. You must know your anatomy, and you have to execute the procedure very efficiently. And it is better to prevent problem than to deal with it. Thank you. Thank you for your attention.
Thank you, Iswarda. If there is any question to him? If no, then thank you very much. Now this session is closed for lunch, I think. There is a lunch symposium. Okay. Thank you very much.
Thank you.
Good afternoon. I'm going to talk on this all inside ACL reconstruction with the live surgery, relive. I think most of the people now are aware about that. What is the usefulness of our all inside ACL reconstruction, especially when we are dealing with a short graft and females and pediatric patients. Yeah. You have to keep pressing it. So the harvesting of the graft is very important. So I will usually I harvest the hamstring, which includes the both the gracilis as well as the semity, just to make sure self that I need always a thickness. You know that the thickness of the graft is very important if you want the graft to survive a long period, and even if the stress, it should not re-tear. So I always believe in, that the thick is always better than when your surgery should be really good enough. And this is a harvested one, the graft. You can see that the minimum, the length of the graft which I always need is around 26. That is 260 mm. And beyond that, if you have got, you got to really have facing in a trouble. So 260 mm is almost sufficient for me to take it. If you find a little bit smaller than that, shorter than that, still you can do it, but how much shorter you can do it? You can go up to around 240. That's a limit you can have it up. And the good thing is what you have to do when you get the harvest, getting the both the sides, that is the femoral side and the tibial side of the graft, which we are going to make it as a suturing it. That has to be in the same size. So I am going to make it the size of the both length, the gracilis as well as the semity to the same length. And to maintain the size, both the femoral side as well as the tibial side, I'll ensure that there should not be any thick enough there in both the sides. And once I made it the extra things to be removed, I'm going to place 2 tight ropes, 2 pro cinch. These pro cinches are the one which is placed over that and looped it. One which I want the tibia side, I make it deliberately a little longer. So we have got something, there in the, we have something there here. You can see that the loop, once if you pull that, there will be 2 strands. Once if you pull that, it's going to lengthen it. This is to make sure that I can have an enough long lever arm to make it to the tibia side. I'm not going to have an extra implant on the tibia side. Whatever we have got in the pro cinch, the same thing I'm going to use it for both the sides. You can see that you can lengthen it. The same thing, if you want to shorten it, you can just cinch it. It gets shortened. So you can lengthen and you can shorten it. And this is what I'm just lengthening it now here. Normally it comes to around 40 to 50, and I'll make it around some 60 mm. And once I have done that, you can see that 2, I'm going to place it over there, and the other graft end of the side, I'm going to take it to the other side of the loop, and I'm going to suture it both the ends of the graft using number 0 fiber wire. I repeat, number 0 fiber wire, not the 2 fiber wire, because the thickness should not be big enough. If you have a bigger thick one, your socket preparation at the femoral side or the tibia side will be a bigger one. So you're not achieving it a proper one which you needed. So once I made it at the topper, this is called a graft link technique. So I've linked both the edges of the graft and suture it. And here you should make sure that the gracilis which have taken should be properly taken into your suture. If you lose that, and when you are tightening it, there will be a little bit of loosening can happen. So you have to incorporate your gracilis in your semity one. And this is a simple suturing, and I repeat, it's a 0 fiber wire, it's not a bigger one. And simple suturing to the end to end. And once if I have done the end to end suture, I will going to trim the edges to avoid widening of it again at the side, at one end. So that is how it's done. You can see that, and I'll stretch it, and I'll keep it in both the sides in a little tension, and the one which I have taken the edge to edge, that is linked one, I am going to put it inside. That is, it is a stress riser. If you are pulling it towards the socket, I call this a socket and not a tunnel. So when I am pulling it over the socket, it should not get abraded. So since it is the weakest link of your graft preparation, it has to be very much buried inside. You can see that I am going to put it well within this side and ensure my suture taking it around through that. It should not be to the edge. It should be a little bit away from the procinge. And you are going to repair it. Repair it is very simple. You can start from your inside, then from inside take it outside, and from out you have to come to the inside one and finish the knot. And after finishing the knot here, you are not supposed to cut it. You are supposed to continue it through the other side. You can see that. You have made it. That is the knot placement over there. And once if it is done, not supposed to cut it. You retain that and take the bite from the opposite side. So this is very important. And taking all the strands of the graft is important to keep it in tight. You're not supposed, if you just miss it, it can become a little bit bulky, or when you're pulling it to the graft side, as the femoral socket or tibial socket, you might be able to get bump in that. And unnecessarily you are creating an extra thickness of the graft. So that should be avoided. So if you give a little bit of tight tension over both the ends, it keeps into its size. And wrap it around. You are taking the loop around the graft. So that makes the uniform size at the one end. You can see that. On average around 4 to 5 ton is more than sufficient. And once it is done, again you are getting it from outside to inside. Whatever the extra suture it was there placed inside, then repaired, then stitched it, and taking the suture from inside to outside and cutting it at the edge. So thereby, whatever the suture which you have done will be protected inside, and it will not be giving you as a stress riser, and your suture is very much safe. Yes. Similarly, you are doing it in the other side of the. I am not going to repeat this. So normally when I do that, the thickness of the graft what I achieve in all my cases is usually around 10. 10 mm is the size. Sometimes I will go for 11. In order to maintain both the femoral side as well as tibia side, what I said earlier, you need to trim it properly at both the edges. And you can see that there is no suture not seen in my graft preparation. And the length, as I showed, you can see here, it's around 60 mm. So this 60 mm is the ideal length which I always wanted, and it used to be safe. And once if I had done, so you can see that size, it is 10. So that is the size which I always try to expect when I am doing an all inside. And then once I am done with the graft preparation, then a routine anteromedial and anterolateral portals, I will go for the knee, and I will keep the knee in supine position and 90-degree placement of the foot stopper. So here you can see when we are doing it all inside, the jig is the places in such a way that when you done it, you have to take out the other part of your instrument, and only the bullet should be placed. So you have got vertical and horizontal things. The horizontal has got a serrations which it locks it, and once if you make it as a vertical, it allows your the jig, the tibial jig, to slide out. Same thing principle holds in the femoral jig. So now I've done with the they're a little bit too much forward. Yeah. Yes, get David. As I said, I'm not going to do an hyperflexion here. It's the same 90-degree flexion, I'm going to keep it. You can see this femoral jig which I have placed it is placed not in an anatomical. I repeat, it's not an anatomical, because anatomical reconstruction we are not doing it. We are going a little bit of now an eccentric or isometric points. And isometric points is the one which we need it. That is isometric tunnel preparation, where we are giving the direct fibers of an ACL. We know that when we are doing a direct fibers of an ACL, the length of the graft which is going to stretch out is very minimal. If you are going for a direct, that is anatomical, the length variation when you do inflection and extension, it is going to elongation around 8 mm. So if we are going for a direct fibers, that is an isometric points, the stretch out of the fibers is very less. Approximately say around 2 mm is the one which has been given in literature which gives it. So I go usually for an isometric points. You can see that the horizontal thing has to be there in the exactly just above the cartilage level of your femoral condyle. And when you do that, it comes to the place where you wanted it. And the good thing about this retro-reamer, we call it as a retro-reamer. His thing is, once it should be driven in the forward, and when you want to take a socket, create a socket, it has to go in the reverse mode. When you go in the reverse mode, it opens up. And this is the femoral, you can see that it is a 90-degree flexion. I'm not going for hyperflexion. And one good point about this is, it creates a very good round tunnel what we wanted. It doesn't create an oval socket, sorry. And this is the blue is the point 1, which shows that how much of the length of the socket which we are going to prepare in the femoral side. And once if we ensure that our femoral socket in ideal position, start reaming reverse. You can see that that is a point which I am going to say in intra-articular point is going to side. And when I start reverse, the flange is going to open up. And when the flange opens up, the ideal size of the what I wanted to create a socket gets in. And there is a marker on the other side, on outer side of it, that shows that how much the length of the socket which I want to create. I always needs around 25 mm of the socket of the femoral side and 25 mm at the tibia side, and keep 15 to 20 mm intra-articularly. If your socket, you are preparing it very same, say if you have got about 60 mm of your graft, and if you are preparing it thinking that I need 25 and 25 and or 20 and 20, 40, 40 plus 20, if you are keeping it, you are stuck up. Because what happens is, you have to pull extra pull has to be done in order to avoid the buttonholing of the graft. So for that, you always tend to have a little bit of 5 mm extra socket preparation is needed either side. And again, similarly, the same thing repeated for the tibia side. You can see that this is a femoral socket and well posterior, and it is, I said, not in the indirect fibers, it is in the direct fibers. The direct fibers are one which saves us. And similarly, similar technique has been done in the tibia side. You can see that the placement where I wanted it, and the retroreamer has passed antegrade. From here, whatever the length I wanted, just measured over there the blue thing which measures the length of the socket which I wanted, and start reaming in reverse mode. The reverse mode, it opens up, and whatever the length of the socket which I want, I'm going to stop it. And we have created two sockets, and the tibia and the femur side. And once if I immediately the socket is been done, I'm going to place, there is a small, you can see that nitinol wire is there. That wire allows the passage of the suture shuttle. You can pass either the fiber wire or you can pass ethibond, whatever the material you wanted. You can pass it, and that will be used as a railroad technique for the passing of the graft from the socket, tibia socket as well as femoral socket. So once MMA ensure that a socket is prepared and the ethibond is placed both at the tibia side and femur side, both the sides I will try to pass it in a one portal, that is either anterolateral portal or anterior medial portal. I keep it in a anterolateral medial portal. Anterior portal is little bit of wider. That's it which we have kept. Okay, so okay. Once if it is done, let us be sure. Once if it is done, we are going to tighten it both at the tibia side as well as the femoral side, ensuring it you are going to cinch it and give the good proper things. And this is the retro reamer what we have got it. I think you can see in the stall how this retro reamer is going to work when you are drilling it anti-grade, and when we are going for a retrograde, that is in the reverse mode, how the flange is going to open. Thank you. Anything? Thank you so much.
On the knee instability session, may I call upon Dr. Parvez Ahsan and Dr. Mukesh Ladna to chair the session, please?
किसी को बुलाना वहाँ से?
Excuse me. We are now starting knee instability session, and to chair the session, may I call upon Dr. Parvez Ahsan and Dr. Mukesh Ladna, please?
Thank you, Kolkata. Thank you, Kolkata Arthroscopy Society, for giving me opportunity to talk about posterolateral corner injury, the current concepts. So it is considered the dark side of the knee. 1/6 of all the ligament injuries are posterolateral corner injury, mostly presenting as a combined injury pattern. So most commonly it is associated with anterior cruciate ligament tears. So hardly 2% of the total posterolateral corner injuries are isolated injuries. So why posterolateral corner draws so much of attention and debate? A study by Laprade has shown that this part of the knee is inherently unstable, with two convex opposing surfaces of tibia and femur are contacting each other. So the bony static stability to this corner is missing as against the medial corner of the knee, where femoral cortex surface opposes each other. One is convex, the other is concave. This leads to precarious soft tissue healing in this part of the knee. Structures in this part of the knee are popliteus tendon, popliteofibular ligament, and lateral collateral ligament. And these structures are providing restraint to varus and posteromedial rotatory forces around the knee.
varus being primarily taken care by lateral collateral ligament and secondarily by popliteus tendon and popliteofibular ligament. The external rotation being primarily taken care by lateral collateral ligament, popliteus tendon and popliteofibular ligament, and secondarily by PCL. 1 of 6 posterolateral coronary injuries will have peroneal nerve injury, so one has to be very wary about it and check for it. Certain tests have been defined to check integrity of these structures based on function that they provide. A varus test is done at 30 degree of knee flexion and at 0 degree. Positive varus at 30 degree suggests definite injury to lateral collateral ligament and possible injury to popliteus tendon and popliteofibular ligament. Now at 0 degrees, if varus stress becomes negative, suggests injury to lateral collateral ligament, but if varus stress is positive at 0 degrees, it suggests injuries to lateral collateral ligament, popliteofibular ligament and popliteus tendon. Dial test is probably the most commonly done test for posterolateral coronary injuries. Positive at 0 degrees suggests injury to PLC and PCL both. Reverse pivot shift test is done by giving valgus at knee with external rotation of tibia and extending the knee. It has 90% positive and negative predictive value and 70% positive predictive value. Now, Laprat has described heel height test. Side to side difference of more than 3 centimeters hints at ACL plus FCL tear. Now, based on these tests, one needs to classify a posterolateral coronary injury into grades. Two most popular classification systems are Fanelli and modified Houston. This is the Fanelli classification. This classification system is characterized by 3 types, all having more than 10 degrees of external rotation. When there is no injury to LCL, it's type A. Additional injury to lateral collateral ligament signifies type B, whereas additional injury to lateral collateral ligament, capsule avulsion and anterocruciate ligament tear characteristic type 3. Modified Houston classification system takes into account varus opening. MRI is helpful directly by identifying the individual structures or indirectly by few telltale signs. Anterior medial bone bruise is seen in more than 50% of posterolateral coronary injuries. 1/3 will have posteromedial bone bruise and signifies injuries to ACL and PLC injury pattern. Now, identifying individual structure can be difficult sometimes in acute scenario, but empty popliteal groove or lax lateral structures can sometimes be visualized, highlighting these injury pattern. Now, based on grading system, we plan the treatment. Conservative treatment is advised for grade 1 injury and isolated grade 2 injury, which is rarely rare. Now, avulsions should be fixed always, whether it is grade 1, grade 2 or grade 3, avulsion injuries need to be fixed always. A combined grade 2 injury pattern and grade 3 injury pattern need to be managed surgically. There is no role of conservative management, and surgical management can be in form of repair or reconstruction. If we take up a case managed with repair, this is a case of 30-year male, road traffic accident, PLC sleeve kind of injury pattern was there, plus ACL injury was there. So, if one can see, there's a whole sleeve of posterolateral structures which have come after the fibula. It's like a sleeve kind of avulsion. So, for this case, in mass repair was done using suture anchors, and these are the intraoperative pictures. You fix up anchors there on the fibula and the Gerdy's tubercle and fix up everything en masse. This is the post-op X-ray showing nicely reduced tibia on the femur, and that's yesterday only the patient sent me this video of doing all kind of day-to-day activities. He is from Bihar and living in a village. This technique has been described by Shelbourne, highlighting good results of repair when done within 4 weeks of injury. So once you do wait for more time, this repair doesn't work. Now, initial few studies reported good results of repair, especially in 80s and 90s. Study by Baker and Krukog reported very good results of repair. But recent studies recommended reconstruction to be better, like study by Stannard and Bruce Levy. Stannard strongly recommended that reconstruction rather than the direct repair of an immediate motion rehabilitation protocol is employed. Based on their results, they recommended repair only for avulsions and rest everything to be managed by reconstruction. Similar kind of conclusion was drawn by Bruce Levy. A study by Laprat further enforced their view repair was reserved for avulsion type of injury pattern. Gradually, reconstruction techniques have become famous for managing posterolateral coronary injuries. Initial reconstruction method where fibula-based sling type of reconstruction was done. Single tunnel technique was described by Larson in 2001, and then double femoral technique was described by Arcero in 2005. Now, is a case of office going young male with posterolateral corner, medial collateral ligament and anterocruciate ligament injury following RTA. The examination, this is the intra-op picture. Examination of these knee must be very gentle and preoperative angiography is must in these cases because they are self-reducing dislocated cases. MRI image highlight the lax lateral structures. This side, that's LCL is lax. That is a torn LCL. And in this fibula-based reconstruction was done along with medial collateral ligament reconstruction. Now this patient did not come back for anterocruciate ligament reconstruction. These patients do stabilize themselves once we stabilize the corners, and sometimes central pillar is not that important and they don't come back. This is 9-month follow-up of the patient. So reconstruction has the advantage of not immobilizing the patient for long, so you will get usually good range of motion with reconstruction. There had been quite a few publications on fibula-based techniques. Camarda reported good results with single tunnel fibula-based technique. Nikki reported that differential tension between LCL and FCL PFL is critical for good results and recommended double femoral technique along with putting interference screw in the fibular tunnel. So they stressed the importance of differential tension between the lateral collateral ligament and the patellofemoral ligament. This cadaveric study compared between a single femoral technique and dual femoral technique and concluded that double femoral technique in PLC reconstruction showed better rotational stability and resistance to posterior translation. So all in all, double femoral technique have taken over the single femoral classical Larsen type technique. In 2004, Laprat came up with anatomical reconstruction recreating popliteus tendon, PFL and the LCL. Now this is a case of 20-year male with PCL and the PLC injury following a RTA. And one can see here the empty popliteal space and the lateral structure damaged. So in this case, anatomical reconstruction was done because he was an young active male using a Laprat technique. A Laprat technique basically has 5 steps. First one is to find the peroneal nerve and then find the fibular insertion of LCL and then through there reach the femoral insertion of lateral collateral ligament and the popliteus tendon, and then from there create all the tunnels and secure with threads and then the final construct. So here one is try to find out the LCL on the fibular side, tie it with a suture and then pull it and try to find out the femoral insertion of LCL. There you will find both. 18 millimeter anterior to the LCL insertion of the femur is the popliteus tendon insertion. To create tunnels on the femoral side and then create tunnel on the fibular side and on the tibial side. Once all the tunnels are being created, one can pass in the graft and complete the construct. This is a post-op X-ray of the patient and that's his 1-year follow-up. He is a village boy playing cricket just for recreation, and this is yesterday's video which he has sent me. So you can do back foot shots, front foot shots. So Kim compared few posterolateral corner reconstruction techniques and concluded that the anatomical and non-anatomical techniques provide similar results, but original strength of knee could not be achieved in either method. But Laprat highlighted that there was in fact a difference in anatomical PCL reconstruction procedure between reconstructing and not reconstructing the popliteofibular ligament through a tibial tunnel. Furthermore, they also said that there was no abnormal restriction of knee motion following this reconstruction of popliteofibular ligament through the tibial tunnel. So this study stressed upon the need for reconstruction of 3 individual structures: lateral ligament, popliteofibular ligament and the popliteus tendon. This is the algorithm which I follow. Grade 1 injury should be managed conservatively, and grade 2 injury, if it is an avulsion pattern, one has to fix it, otherwise it can be managed non-surgically. For grade 2 combined injury pattern and grade 3 injury pattern, if it is acute, one can go depending on which structure has been damaged, either rotational, varus or both. One can reconstruct. If it is a chronic injury pattern, then one has to do an osteotomy as well as reconstruction of the structures. Sometimes you do an osteotomy and get away without reconstructing the structures as well. So take home is look for PLC injury always. It is an inherently unstable part of the knee, so you might not get a good healing. And then stress X-ray are important as a starting reference point, because then you have to compare your final end point with the starting reference point in terms of getting an X-ray done. Repairs work well in avulsion scenario only. Modified Larsen technique has given good results classically, traditionally. High demand patients need anatomical reconstruction. Thank you so much.
Thank you, Dr. Binay Pandey. I will request to ask question if there is any question to him relating with this subject matter. Time is complete. Okay. No question?
In a nice talk, sometime in a revision scenario, when already you have first time revision of ACL, do you prefer putting two tunnels, the classical Laprade or single modified type, single tunnel in between the attachment of the popliteus and LCL?
But usually the ACL tunnel is far posterior, so there is not too much of struggle. Then the trajectory is, if you make a trajectory is 40 degrees up, proximal, and 40 degrees superior. So you usually avoid that LCL. It is more of a problem on the medial side than on the lateral side. So you can get away using a normal tunnel.
In those cases also you prefer two tunnels?
Yes, correct.
Thank you very much, Dr. Binay Pandey. I would like to request Dr. Kanchan Bhattacharya will speak on ACL plus grade through MCL. Dr. Kanchan Bhattacharya.
Thank you, sir, for asking me to be a part of this wonderful meeting, and thank you for remembering to call me even though I was late. One ligament would go and nothing else would happen. It does not. And so during this pandemic period, Andy Williams and Willingford looked back at some 100 of their cases and found out retrospectively how many of them had additional MCL injuries. And you'd be surprised that they had about 67% in all at some amount of radiologically demonstrable MCL injuries. A larger number of them were superficial, some of them were deep, and a very small number were posterior oblique ligament. So it's very important for us to remember that these things do happen, and a number of times we miss them completely. We know that MCL primarily functions as prevents the valgus deformity. It also helps a little bit in rotational, and it does act in tandem with ACL. And a very important part in this part here is something that was that we've known forever, and that's the grading of the MCL, which is strain, which is type 1, type 2, and type 3 is complete separation. Now, there's something else about MCL which is important. We should not club them together. Grading is just the tear, and once it's completely torn, then you have the laxity, type 1, 2, and 3. To diagnose a patient who comes to your clinic for ACL and MCL injury, you've got to look at both. They're usually pretty serious injuries. The knee will be swollen, and you'll have to look for the MCL deficiency by trying the valgus in both the straight and in the 30 degrees flexion. If it happens in both straight and 30 degrees flexion, then obviously the injury is a little more serious. And then you look for the ACL injuries also. You look for gentle lockments in the early stages. Drawer probably is not very well demonstrable, but do not forget the PCL step-up, because you do not want to miss a PCL injury if it's already hidden there. X-rays normally do not have a huge role to play, but I think you should still get it done because it will tell us something which you might miss otherwise. And just for completion, routine X-ray is probably a good idea, and they all come with it. MRI is the image of choice, and they tell us about the MCL, the ACL, the bone bruises, and if there are other associated injuries involved in the same token. Historically, we have known that when you have an ACL and MCL injury, the ACL probably would have to be reconstructed, and MCL can very well be treated conservatively. And that has been the hallmark of treatment. We've had Houston and Jokel demonstrate very good results, with about 70% of the players going back to pre-injury level in the 80s by conserving both the MCL and the ACL. But that is a thing of the past. We probably wouldn't go that far today. But you have to remember, because if you do not remember history, you are bound to make the same mistakes all over again. The diagnosis and the treatment of ACL and MCL has always been controversial. We do not have a single consensus on exactly what we should be doing and when we should be doing them. But however, most agree that in grade 1 and grade 2 MCL injuries, it's a reasonable approach to treat the ACL as needed, which means reconstruction when needed, and treat the MCL conservatively. There is usually a little bit of difference in your post-operative regimen when you have an associated MCL. You would guard it, brace it for some time, probably give it some weight, partial weight bearing for some time. But the moment you have the grade 3 ACL, the water gets a little murky. You wonder what you should be doing. And in today's context, as we have all noticed, that we tend to go incline more towards surgery as days are going by. But the moment you look back at literature, what do you find? You find that this is a compilation of subjects where one group had plain ACL, simple ACL injury or isolated. The other had ACL injuries grade 2 valgus. Grade 2 valgus means it's if there's a valgus laxity, it would be grade 2 or grade 3, and the laxity would be different in today's context. And what did they find out? At the end of 2 years, there was no difference in clinical outcome between the two of them, which means that if you treat the ACL surgically and the MCL conservatively, you still would have very good results. Now, what does this literature say about MCL and ACL? Again, done quite a few years ago. And this was a prospective randomized trial of about 30 odd patients of grade 3 MCL and ACL. And they were all those that were operated pretty early within the first 2 or 3 weeks. And those that weren't had only their ACL done and the MCL was conserved. And what were the results? Equally good clinical results in both of them. So it all depends on how you look at things. And these are the controversies. Adding to them, and this is very recent, Smith in 2015 presented a very important paper which was based on all the available literature that he found from Cochrane and PubMed, and then he came to a conclusion and proposed a theory. And his proposal was that all MCL and ACL injuries, especially grade 3 injuries, should be conserved. And then at the end of 6 weeks, when the knee gets quiet, you go ahead and do with the ACL. And if you still find that there is valgus laxity, or if you find that there are more than 2 ligaments involved, then you reconstruct the MCL as well. And when the MCL is reconstructed, he found out that the best result is when you reconstruct both the superficial MCL and the POL, posterior oblique ligament. On the other hand, Gallo and Hestroni in 2015 and 16 have shown their work of primarily fixing both the ACL and the MCL. Gallo described his technique of using a single strand of Achilles tendon allograft and fixing the ACL and continuing it with the same allograft upwards into the medial side to contract the MCL as well, and has shown very good results. Blanc has done about the same thing, but 2 different autografts. But the similarity is they have chosen to operate on each one of MCL grade 3 and ACL and have good results too. Now, as it stands now, we do not have a large enough study, and we cannot really convincingly say that this is a reliable form of treatment that we should go ahead with. And this is an average kind of MCL reconstruction that we normally do. The pictures were provided to me by Dr. Manavendra Basumalle quite a few years ago. Now, in terms of deciding what we want to do, I think a little bit of progress has been made in helping our way forward. The German Knee Society surgeons, during this pandemic again, got together and pooled in their knowledge and resources in some kind of a questionnaire format to come up with some kind of consensus on how to deal with MCL and ACL injury. And this is what I take from them and pass it on and for you to decide. acute MCL grade 3 tears can be operated. Large number of surgeons tend to believe that they can be operated. And if you do not operate them, then see them back in 6 weeks and then take a call. If you find them deficient, go ahead and reconstruct. If MCL needs to be reconstructed, you address both the superficial MCL and the posterior oblique ligament. And the posterior oblique ligament. What about the graft? You carry out a standard ACL, whichever way you want to do it, whichever graft you normally choose. Their suggestion, however, is in case of MCL and ACL, they are most of the surgeons are hesitant to use hamstring for ACL. They would suggest a patellar tendon or quadriceps tendon or a hamstring on the contralateral side and save the hamstring for MCL reconstruction, where the choice would be hamstring or split peroneus graft or an allograft. And again, in Germany, allograft is not as popular as it in the United States. What are the options of MCL surgery when you want to do it? If it's an acute surgery, you want to do it. If it's a bony avulsion, obviously you fix it. If it's an avulsion from the femoral or the tibial end, you fix it with whatever devices you have, staples or anchors, whichever way you want to do it. And when you have a mid-substance tear, you repair it and augment it with an internal brace. That's what most of them want to follow. And when you want to reconstruct it, again, coming back to it, both superficial MCL and posterior oblique ligament. Whenever you treat MCL and ACL, regardless of whether you treat them operatively or non-operatively, most surgeons in that group tend to believe that you brace them and you have your ways of bracing, and whichever way you want, first lock brace and then give them gradual movement, keep them partial weight bearing and gradual knee bending over a period of 6 weeks. And this, the consensus is not exactly great on how many degrees of flexion, but they all believe that this should be a very slow and gradual progress to normalcy. So to summarize, ACL, MCL grade 1 and grade 2, all researchers agree that ACL reconstruction and non-surgical management of MCL would do. But ACL grade 3 and MCL treatment is fraught with controversy, and it is wise to customize the treatment based on acuity of injury and the specific outcome goals of each patient. I leave this food for thought for you with no really clear guidelines, but all of you are just as well versed with ACL and MCL as I am, and you'll make your own decision according to the way you think. Thank you very much.
Thank you very much for excellent presentation. I would like to ask the question, because it is very controversial issue whether grade 3 type of MCL injury is going for conservative or operative treatment. So I think you can ask question. Actually, grade 3 type of injury, what will be the post-operative management? We will go for reconstruction of MCL as well as ACL. And what will be your post-operative management?
All right. If I operate on MCL and an ACL...
No, if you operate ACL, but conservative in MCL.
Okay, so I'll brace them. For the first 2 weeks, it will be a locked brace. For the next 2 weeks, they'll start gradually bending. At the end of 6 weeks, the brace will be off completely. So and the same goes for the weight bearing as well. Start with non-weight bearing initially, and then progressively more weight bearing for the next 6 weeks.
But if the patient complains after 6 weeks that he had some problem with due to grade 3 injury,
then we go back and reconstruct the MCL.
Yes, that's the thing. Okay, thank you very much.
Thank you.
Thank you very much. The next speaker is Dr. Ananda Mondol. His subject is PCL My Technique. PCL My Technique.
Good afternoon, everybody. My talk is on PCL reconstruction. I will present a small video, but before going to the presenting the video, what I will say that what is my indication for the PCL reconstruction. My indication of PCL reconstruction is the grade 3 PCL injury, or where the PCL injury is associated with the posterolateral corner injury, or when PCL injury, symptomatic PCL injury is associated with multi-ligament injury. Now, most of my PCL reconstruction usually I do in the supine position with hanging the knee from the end of the table, and I usually use the peroneus longus graft for my the PCL reconstruction, and also I use also semi-TD graft also. Now, after entering into the joint, in this part of the video we can see that the ACL is lax here, and it becomes tightened when the anterior pull is given to the knee. Then after confirmation of the diagnosis, my first step is to resect the septa between the ACL and the PCL, and also resect the femoral footprint of the PCL. If I remove the femoral footprint, then I can go easily on the posterolateral corner of the knee joint, and by a trajectory through a lumbar puncture needle or the Gelco needle, I can enter into the posteromedial corner, and guiding to its posteromedial capsule is cut by a number 11 blade. And through this opening, we can put a switching stick, and guiding over the switching stick, we usually put a cannula, and through this cannula, later we can use the different kinds of instruments, and also we can put the scope here also. And in this part, we can see that the tibial footprint is saved of the PCL, and also the septa have been resected. Usually, in all of the beginners, the fear is that just behind the stump of the PCL there are great vessels. So everybody are afraid in their beginning. And after clearing the PCL footprint, we usually put the PCL jig just behind the posterior aspect of the tibia, and through the anterolateral portal it is pushed, and the scope is put on the posteromedial portal. Now, here we can see the bead needle is come from the anterior aspect to the posterior aspect, and it is protected by the PCL jig. And to create the tunnel, the reamer is passed on over the bead needle, and everybody have to keep in mind that you have to protect the tip of the bead needle, because just behind the PCL stump there are the great vessels. So chances of the injury of the vessel is very much during the creation of the portal, creation of the tunnel. So here the tunnel is made from the anterior to posterior by protecting the tip of the bead needle. Then the scope is switched from the posteromedial portal to the anterolateral portal, and then a thread is passed from the anterior to the posterior aspect of the knee, and the loop is taken through the posteromedial cannula, which will help for the guiding of the graft from the tibial tunnel into the femoral tunnel later. And after taking the loop into the posteromedial cannula, the femoral guide is placed on the medial condyle of the femur, and the guide pin is passed from the outside to inside. Here the guide is placed at the femoral footprint, and it is usually anterior and the superior aspect, and after putting the bead needle, the tip is protected with a bone scoop, and the tunnel is made from the outer aspect to the inner aspect. protecting the tip of the needle with pin. Then the loop is taken from the tibial side to the femoral tunnel, which will later help to guiding the graft from the tibial tunnel to the intra-articular space and later into the femoral tunnel. In this way, when the graft is pulled to the femoral tunnel, you can help to protect, to pull the graft by putting probe, and it is very difficult to take the graft from the tibia to the femur because the path of the graft is zigzag. It is in the tibial tunnel and anterior to posterior oblique, and it is the femoral tunnel, it is in the coronal plane oblique. Before taking the graft into the femoral tunnel, a guide pin is placed on the anterosuperior aspect of the femoral tunnel. Otherwise, the placing of the guide wire is very, sometimes become difficult. If I try to put the guide wire after taking the graft in the femoral tunnel. So, the guide wire is first placed on the anterior and the superior aspect of the tunnel, then the graft is taken into the femoral tunnel, and it is held by a artery forceps from the anteromedial portal. Then I fixed the graft from outside to in, just only tip of the interference screw can be seen from the from the inside of the joint, or you can palpate the tip of the screw by the probe only. Here we can see that I can just palpate the tip of the screw here, and this is the PCL graft which have been fixed on the femoral side only. The ACL is still lax now because it is not fixed on the tibial side. If I give anterior wire, then the ACL become taut, and after this the tibia is flexed at 70 degree, and through a guide wire the tibial graft is fixed on the tibia with over the guide wire, and this is the PCL graft which can be seen from the posteromedial cannula. And in this way, I usually reconstruct my PCL.
Thank you very much for excellent presentation. There was a lot of new things. I would like to ask the question from the audience, if any questions. No question. Then our next presenter, Dr. Shanandu Shamanto. The topic is failed PCL, assessment and planning. Dr. Shanandu Shamanto.
টাইমার দিয়ে রাখো, আমার 8 মিনিটই হয়ে যাবে। 8 মিনিট মানে 8 মিনিট, বেশি না। So now we have listened to the primary PCL reconstruction. Kanchanda, how many revision PCL you have done, you and Devchat, in your career? Revision PCL? 4 or 5. Debuda? So I have done less than that, okay, and I am talking on that subject. So I am talking on that subject. Believe me, I have done 2. So it is not great number. But Sachin, how many revision PCL you have done? 0, okay. So IPS? 1. So in this whole room, I think if we get all the, Sundar, I was just talking to Sundar, okay. So I think he will be between 0 and 1. So no problem, 1. So I am bit graduated than Sundar, less graduated than Kanchanda and Devchat. I have done too. Okay, so we have taken all the cases and everything. These are all theoretical lectures, but I will try to do something, some justice to this lecture, as because when I was supposed to prepare this talk, I read a bit from the different literatures. I collect some information. Something was new to me even. So I will try my level best to give you some information. So this is, I think, if you want to do at some point of time your revision PCL, you have to read this article, because this is the Frank Noyes article, who is the master of knee arthroscopy, and in his literature of a long career, it was only 52 cases he has done. So imagine the stature of Frank Noyes, he has done 52. So how many we could have done like in our career, okay? So I think when Devchat and everybody was talking about the revision ACL, I was requesting Debuda, we can just change the P in place of A, because all the things in the ACL revision, the criteria for the ACL revision are more or less similar to the PCL. Only the surgical technique is different, as because the orientation of fibers are different, okay? So we planned the same way, like you take the X-ray, you take the history, how the patient is feeling unstable, and what is the demand. It is not the demand of the surgeon. We orthopedic surgeons are very high demanding to make all the fractures, ligaments to be treated surgically, okay? So you do the X-ray, you do the MR pictures, then you have more justification to revise it. But believe me, when you do the PCL revision, it is a great ask for a surgeon, because you have to tell what you are basically going to give at the end of the day to the patient, because you are going to expect 90% of time a very unhappy patient, okay? So this is the picture of the MRI picture. You can see the tunnels. And in ACL, there are 3 common reasons of the ACL failures, okay? 3 most common reasons for ACL failure. One is the wrong tunnel, and second is the wrong tunnel, and third is also the wrong tunnel. And similar is true for your PCL even, because if you see this sort of X-ray pictures with this sort of metal implant, you can see where is the tibial screw, where is the PCL screw. The screw is looking like the ACL screw, okay? So this cannot be the PCL, it is in between the ACL and PCL. So it might be the APCL, okay? So there are many things. When you do the PCL reconstruction, I will request that those who are probably new for the ACL reconstruction, I will request, even when you do the ACL, please never forget to do the dial test and look to the corners. Because this probably we all imprint, and we have been inherited from Kanchanda and Devchat, all very seniors, that if you miss a corner injury, your central injury, whatever best reconstruction is you are doing, it is bound to fail. It is a day 1 failure, believe me. If you miss a corner injury, it is a day 1 failure. So if you do a PCL with the PLC, your PCL is not going to do your purpose. Okay, so this is the way how you do it. And you measure all the tunnels, because I think if your tunnel is more than 12 millimeter and whatever, if it is a wrong tunnel, you are blessed, because you can make a new tunnel. But most of the time, the PCL, if people can't do that, most of the time they are doing a wrong tunnel, okay, because they don't understand what is high and what is low, what is deep and shallow. Because I think many people are doing the double bundle PCL, if you read the Lapral's article, that was one is 11 millimeter and one is 7 millimeter. I don't have the courage of making 18 millimeter tunnel on the medial femoral condyle or somebody's knees, because our knees are very small and my heart is also very small. So I cannot make 18 millimeter tunnel. And you see, if you see this was a reconstructed PCL, and you see, if you take the drawer test, you can see the imprints also in the front, that the PCL will glide posteriorly. I think if you want to do even your primary ACLs, you read the Laplace literature and you take a lateral film in a kneeling position. It is a simple X-ray where you can judge whether you have to do the PCL, yes or no. Forget about the grading system. If it is a kneeling X-ray lateral, more than 10 millimeter, you have to do the PCL, okay? So these are few slides. These have been borrowed, because that time a few slides I have borrowed from the Rajiv also. So you see, if you are doing the PCL, you have to understand how to create the posterior medial portal. A very simple thing. If you see the X-ray, you can see the vein. You should not puncture the vein, you can see, because the nerve is just behind the vein, okay. So you palpate that and you create this portal. You have, whenever you are going to the human specimen lab, you go there, and because we are very meticulous in creating the posterior medial portal, only because nowadays we are all fixing the PCL avulsions. When I started doing the PCL avulsion, I was making the patient prone and doing a big incision and going just kissing the artery, nerve and vein. Nowadays we are doing the modified, that Lobenhofer approach. Nowadays even we have studied that we can do a PCL avulsion, whatever avulsion you give me, I can fix with the PCL, with the scope, because nowadays I am doing 2 posterior medial portals. One superior portal I am having the scope, and the one inferior portal I am handling the instrument, sutures and whatever material. So this is the way I put this scope behind, and I can see on the back side, because I can see your sample drop, whatever the IPS was telling yesterday, okay. So this is the way you can do the transseptal portal. I am not doing the transseptal, what Bancha has told us during the different meetings. I can do the 2 posterior medial portals at the corner. And once you are back there, you can save the whole PCL stump from the back. Because you see, the PCL, when you do, you have to understand where this is the slide you have to print in your brain. Because this is the slide from the Laplace's great article, what is the meaning of your high, low, shallow and deep. Because when you do the single bundle PCL, you do a high and shallow hole for that. And when you do a single bundle PCL, I have never done double bundle PCL in my lifetime. Sundar is doing, because I was talking to him, he told that if I am doing a primary PCL, I am doing a double bundle. But I don't have the courage to make a 16-18 millimeter hole on the medial side, okay. So for the beginners, even if you do the primary or the revision, you must use the CM picture shots, so that you are really deep, you are not at the margin of the tibia, because if you are at the margin of the tibia, this you will fail, okay. So this is the way. Sometimes this is my video when I was doing the primary PCL. I was using the still date I am using the bent wires, because this is the best thing in my hand. Use the crochet hook to retrieve the wires, and you settles the graft very well. So this is another way what Ananda was telling. This is the way, because before putting the graft, you put your Nitilan wire, because this is like you are putting the wire for your MPFL reconstruction, because once you put the graft in, it is very hard to find the hole, okay. Finding the hole is always very important in arthroscopic surgery, in everywhere in your lifetime. So you can do many things. You can do the inlet technique also for this. You can make the double holes over there. And this is the article I will tell you. This I read, and this article is absolutely new to me. This can be done with this type position. You can do the Lobenhofer on the back side with the supine position. You can inlay the graft. You can fix with a screw. Then you can put the 2 bundles from the front. And if I get a revision PCL next time, I will be doing this thing, because this can be done easily, because we are fixing the posterior condylar fractures with the Lobenhofer. So this is very easy at our hand. And once you fix this, you can do, and always remember, when you do the PCL surgery, use the supplementary fixations. Also, this is the picture where you can graft the tunnels, you can go second. And always do check like your ACL, your malalignment, whether it is a varus or valgus, because unless you correct the varus or valgus, you can, whatever ligament like the ACL primary or secondary, this is not going to heal. So varus and valgus, you have to correct the alignments. So why it has failed whenever you deal your ACL or PCL? Probably the tunnel, the graft, the fixation, missed injuries is the most common, re-injury is another one, and also the malalignment at the end. So if you categorize, you feel that instability, stiffness, pain, what is the demand of the patient? Because PCL revision is not equal to the ACL revision. This is a different ball game. Okay. So whenever you do, you have to have the courage, and you take a deep breath, and you plan. Then you address all the possibilities, whatever is associated, whatever you have missed, then plan, address, and then you succeed probably. But you did a really big heart to do the revision PCL, because sometimes you have to also address the corners. Thank you very much for your kind and patient hearing.
Thank you very much for your excellent presentation.
If there is any question or any suggestions, I will take, because my experience with the revision PCL is like half of Kanchonda, Devcheta and all, because Sachin is also there, IPS is there. Any question we all 5 can answer. Pratik, I also forget Pratik, how many you have done RBSL, Pratik? 3. So in the hall we have done probably less than 20. Mukesh, have you done ever revision PCL? 1, okay. So you are not, nobody is, Jaya? Okay, so nobody is in the double figure. Sachin, anything to add on I forgot? Anything I forgot during the revision PCL, anything, any theoretical aspect, anything I forgot?
Yeah, I think majority of PCLs that come for revision will usually have coronal plane malalignment, and they would also have abnormal slope. So I have tackled about close to 20 or 25 failed PCL reconstructions till now, and in almost about 2/3 of them I've gotten away by just doing a
slope correction.
Yeah, I've gotten away by doing a slope correction along with a coronal plane alignment.
Yes. Because this is a very, very good point. Whenever, suppose this is also been recommended for your revision ACLs. If you have high demand, you can change the slope. PCL is more true to change the slope.
Correct.
PCL is more true to change the slope.
And the results are far more rewarding than an ACL.
Yeah. That's so. It is more true for PCL. And whatever corner is there, you have to address that. If you don't have the skill of addressing the corners, you should not touch even the primary PCL. True, Kanchanda?
Thank you very much.
Thank you.
The next topic is PCL avulsion, how I do it. Dr. P.C. Jagdish. Dr. P.C. Jagdish.
And used to fix it with open. Nowadays, we tend to fix the PCL with arthroscopic technique, and there are a lot of techniques are available in the market, right, which to adopt, but it all depends upon the individuals, what you can get into it, how good you are into it, especially when you're approaching the posterior aspect of the knee. And here I'm going to show my technique, how I'm going to do a posterior PCL avulsion fixation. You know that, what it serves, it's mainly it is to restrain your posterior translation, and secondly to the rotational injuries. And deficient knees will always have in our cartilages, especially in the patellofemoral arthritis, lengthening. The studies revealed it. Options are available, as I said, we have got an open approach and arthroscopic approach. And though when we come to the fixation, we need to have it, what type of fixation, and when we have it, we should have an exact armamentarium, what are the type of the avulsion which we are going to fix it. To have it, an X-rays and CT scan is a mandatory. Associated injury should not be missed it. So always have an MRI to have it, what are you going to address along with that avulsions. When it is displaced, that is when you see in an X-ray, if you're able to see it very which has to be pulled back. So I use the spinal needle or any long needle which you have got it, the epidural needle, and place it through that tunnel which I have created at the bed. And using a fiber, using a portal. And then my second needle is coming through the edge, that is where the PCL and the bone interferes. I am not going through the bone, because going through the bone can very well shatter sometime. So it is the junction of the bone and the ligament which I am going it, and the same, either PDS should be passed through that. And once if I am sutured that, that is one is coming through the bed of the bone and another one is coming through the bed, that is the junction of the bone and the ligament. And this I am going to make a single one, railroading it. This will be using as a railroad through negotiate the ACL tightrope from the anterior to the medial side. You can see that that is the picture of two portals which has been done. Now you can see that whatever I have railroaded it, I am going to use this to get the tightrope. Either you can use directly or sometimes you can use accessory, that is ethibond, to get your tightrope posterior medially. Because sometimes when you are pulling it, can get cut. So gentle pulling from that junction will get your tightrope easily. So I said this, I use a tightrope for this. Slowly releasing it and also control your avulse fragment with another instrument so that not to pull up too much. That makes you very clearly. So now I'm happy that I'm almost all pulled the tightrope part, the blue part of the tightrope, but the cinching, the another white part has to be come out. So what if I'm facing a little bit of tight enough, I'll use another instrument, that is our suture retriever, to pull the remaining part of the tightrope through that. Always you should be gentle in pulling this. You should not hurry up. And once I've done, you can see that the avulse fragment, you can see there is one, that's from the bed I'm pulling it. In order to make sure that the too much of pulling should not shatter my bone, I'll use the accessory, that instrument, that is my suture retriever, to pull it furthermore. And once I am done with completely, here it comes my completing my technique. So the button part is in the anteriorly, the free end part is in the medially, that is the posterior medially. The remaining part, that is the remnant part of the tightrope with the loop, is completely in the posterior medially. Here I used the ABS button. The reason for me using the ABS button is, you can see that it goes and sits very well over the avulsed fragment. This is the button which I'm using it. The important point is you should make sure enough it sits over there, and once you are cinching it from the anteriorly, you should have to keep it extra tightness so that in order it should not twist it. But once if you're keeping it, it will not easily slip away. And railroad it through posterior medial portal using grabber. Once if you cinch it from anteriorly, the graft over the avulse fragment, the button goes and sits. So this is the idea of using the button, because the button gives an extra strength and extra area for the bone to sit into it with a well good reduction. And this is the post-op picture with a well-reduced avulsion fracture. There are a lot of advantage of this doing an arthroscopic, especially when you have got associated injuries. And it has a lot of literature has also proved that what is the advantages in getting doing in arthroscopic fixation. The only disadvantage of this technique will be you have to little bit of an extra in learning curve, and there are some studies also showing that if you're not prepared well enough, there will be an unstable fixation, so delayed, you have to do a delayed mobilization. So that's the conclusion which I say. Thank you.
Thank you very much, Dr. P.C. Jagadish, your excellent presentation. I would like to request the audience to ask questions. What I feel is to me is a new case because you used a button. We didn't use the button. So can you show how much case you have done with this?
So till now I have done around 20 cases.
20 cases. All are successful?
All are very good.
Yes, thank you. So if there is no question, can we conclude the session? Okay. Thank you very much. Excellent presentation. I would like to start the next session. Thank you.
The next session is case discussion by Dr. Sagar Kakatkar.
Very good afternoon, everybody. I would like to thank the
and the panelists for this case-based discussion are Dr. S.R. Sundarajan sir, Dr. I.P.S. Oberoi, Dr. P.C. Jagadish, Dr. Biplab Doloi, Dr. Amrish Jha, and Dr. Amit Joshi, please.
So good afternoon, everybody. I'd like to thank the Kolkata Arthroscopy and Sports Medicine Association and the Society for having me here. I've been asked to discuss a case regarding the KD3M injury. Can we have this? It's not visible on the screen, I feel. Oh, now it's there. Sure, according to the Icrs Classification, this is the third injury I'll be discussing about, that is the KD3M injury, which involves the knee dislocation, the cruciate ligaments, both ACL, PCL gone, along with the MCL injury. The points we would like to discuss here is how to time the surgery, whether or not you will stage the surgery, whether to repair, whether to augment the repair or reconstruct, what should be the sequence of repair, what grafts will be used, and how will you immobilize pre-op and post-op as well. Let's start with my case. Had a 24-year-old female police officer, a traffic police, while on duty was hit by a four-wheeler. Her BMI was 28.71, so slightly overweight. She had a knee dislocation, which was reduced elsewhere in the periphery, and she was shifted to our setup. She was in a long knee brace. 2 days post-injury, she was getting her MRI done, and the MRI technician removed the long knee brace, and she again had a knee subluxation with excruciating pain, had a vasovagal symptom, syncope. So the primary surgeon, I was not the primary surgeon, so the primary surgeon shifted her to the OR and called me for further management. So when I checked her, the dorsal pedis and posterior tibial artery pulsations were normal. The CT angio was done on day 0, which had documented no vascular compromise. This was her clinical examination. She had a grade 3 Lockman. She had a classical pathognomic anterior bruising suggestive of significant anteroposterior force. She had a classical posterior sag and grade 3 posterior drawer test. So the valgus stress test in extension showed grade 3 valgus opening in 30 degrees of flexion, again grade 3. The dial test showed that the prominence of anteromedial tibial condyle here suggestive of anteromedial rotatory instability, which we often see. This was the MRI which was done. Unfortunately, only part of the MRI was done. As we can see, she had a lot of bruising on the lateral femoral condyle suggestive of a classical valgus force with a rotational component. Her SMCL attachment on the femoral side seems to be slightly intact probably, but had a bad blowout injury here. The medial meniscus was seen locked in the intercondylar notch. She also had a rim fracture, as you can see by the yellow. The SAG images showed a classical double PCL sign, again suggestive of a locked meniscus in the intercondylar notch. The ACL had gone. On the axial MRI, we can see that the MPFL was torn badly. The SMCL complex and the posterior medial complex of the capsule was badly torn. So my questions to the panelist: will you do any other clinical investigation or clinical test or any other investigation? How will you time the surgery? Unfortunately, I didn't have any option. The patient was already anesthetized by the time I reached. But if you would have gone a chance, how would you time the surgery and will you stage the surgery? I'll start with the first panelist here, sir. Sir.
Yes. First of all, I would like to wait first. That is, without investigation, proper investigation, I won't take the patient inside.
Okay.
Right. And second, because we have to address here it is not a single anterior posterior dislocation. There is a rotational force injuries. That is, the medial retinaculum is torn and the MCL is avulsed. Also, because there is a posterior, the lateral condyle, there is a very much bruising is there. Definitely the posterior capsule should be torn. Okay. Once if this posterior capsule is torn, I do not venture immediately to do an arthroscopy. I will wait for a period of at least a week.
A week at least, yeah.
A week.
For you, sir, Sundar sir?
So this is the second day? This is second day?
Yeah.
Yeah, because I never adventured the second day because very dangerous, because they are all very unstable injuries. So all the KD3 injuries are not same, In that KD3 also you have a slow velocity, high velocity, with the rotational component, without rotational component, without posterior capsule. So in general, we don't operate anything first 2 to 3 weeks, we don't operate at all. We just see a stable or a unstable. If it is stable, I put them on a brace, the knee become quiet, then we start moving the knee, then reassess after 2 to 3 weeks time. Only if it is unstable, then we operate. Because sometimes even the younger patients, very low velocity injuries, that ACL and PCL with the posterior supporting brace can get stabilized. Could be a low violent MCL injury, can heal well by 3 months, 3 weeks, by the time it will become very sticky. So we always reassess after 2 to 3 weeks, then only we decide about the surgery to reassess the instability.
Yes.
And as I said, if it is an unstable, then we put on external fixator, leave it for 3 to 4 weeks, then we take out the external fixator, then move the knee, again reassess. So that is how my protocol goes.
Absolutely. Yes, IPS sir.
I would differ a bit. I would actually open it up from the medial side. The meniscus is dislocated, it's completely transected, dislocated.
This one guy.
So this actually needs a meniscus to come back. Both the meniscofemoral and meniscotibial ligaments are gone.
Yeah.
I think my first priority after opening would be to bring the meniscus back, stitch the meniscus back to the meniscotibial ligaments, and I would try to do a primary repair of whatever MCL is there. I can actually put an internal brace as well as for helping the healing of medial collateral ligament. As far as PCL and ACL are concerned, I definitely agree. We can wait, we don't need to hurry. There are a lot of capsular bruises and injuries. You don't want to push in a lot of water at this moment of time. So the safe bet for this patient would be bringing the meniscus back, repairing the medial and posterior-medial corner, immobilizing this knee into a PTS brace, slowly observing the healing to happen, and then decide at around 6 weeks to 8 weeks what other ligaments you would want to do. So medial and posterior medial corner for me probably are more
and
important.
the meniscus.
With the meniscus repair, coming back to the meniscotibial.
Yes, sir.
All my multi-ligament injury, I usually do not operate before 2 to 3 weeks. But in this particular case, as there is locked meniscus, I will do some open procedure. I will bring back the meniscus, repair the MCL, whatever I can do, and immobilize it. After 6 weeks, again I will reassess whether MCL has united or not, or whether there is any valgus laxity or not. Then I will decide according to that. I will do my cruciate reconstruction. Along with that, if I need any augmentation on the medial side, I will do that.
Yeah, Amit sir.
I think I'm a single stager. I tend to do all those things in single stage, but not in day 2 or day 1. So if your patient is already under anesthesia, I would rather do a quick arthroscopy, maybe reduce the meniscus, put some sutures on the meniscus. They tend to heal very well since it is right on the periphery, capsular rip off. And then take the patient out very quickly, maybe in 1 week time when the knee settles down, there is a little bit of capsular healing. I'll take him for all reconstruction.
So I'll just come to the surgical pictures also, but this patient had a gross medial blowout. So doing an arthroscopy primarily with such a swollen knee and a tense calf compartment, that's the reason I prefer to stay out of it. Sir, what will be your take?
Because attempted reduction failed, so we have no option. We have to go and open it. Sometimes there may be buttonholing of medial condyle of the femur through the capsule, which is sometimes difficult to interpret in MRI. So probably first stage is okay. After that, I will reduce the knee and I will repair the medial structures and then put the limb in brace or slab or X-fix, whatever is comfortable. And second stage after 2 to 3 weeks.
Yeah. So then I went ahead and I always do the stress images. It has been emphasized a lot how to do the valgus and varus stress test in these KD3, M and L injuries. Just to quantify regarding the timing, n number of papers are there. Like these patients, although you will feel the pulsations properly, these patients usually have intimal damages and they will present with delayed vascular injuries or pseudoaneurysms. So ideally we should always document, probably do a CT or MR angio. It's absolutely imperative. Regarding staging and sequence, since we have Sundar Sai here, we have had superb articles which have been published. Few of us will go ahead, and most of us will go ahead and do the collaterals if we have to stage the surgeries. Sundar sir, I would like to know your opinion. You had a wonderful paper present in 2018, published in 2018, when you actually do the cruciates first, then again check the valgus and varus stress test. You probably did almost 20 patients of grade 3, KD3M patients with more than 10 millimeter opening post cruciates. So what is your say if you have such an injury with a medial capsule? Like we all discussed right now, you will repair the capsule, but would you touch the cruciates primarily in such cases?
Yes, that's what I said, because even this particular case, I talked about only about the date because it was done on the second day. So in general, I tend to do it at least 2 to 3 weeks, and the second week to 3 weeks, so that at least the capsular part, posteromedial meniscular part, by the time it will start healing, because we cannot replace everything together. We know that how repair it will be messy, and when you do an MCL, always that's why IPS put the internal brace. So that's why I wait 2 to 3 weeks. This bucket handle tear is not a locked knee. They are all already unstable. The knee is moving. So that's why this can wait for any knee injuries other than vascular injury, other than open fracture with dislocation. They can wait. Or invagination with irreducible dislocation like MCL invagination. These three are, for me, you have to do an immediate open or first day, second day. Otherwise, all other cases can wait for at least 2 to 3 weeks time, so that by the time knee becomes supple, quiet, then we can do, as Amit said, I also do mostly single stage. I always stabilize the cruciate PCL first, so that your knee gets stabilized. Then you assess, then you do a femoral avulsion. If it is opening grade 3, I do a repair. If it is a mid substance, we do an augmentation.
So as soon as I took the incision, I had just incised the subcute, not incised actually completely also, and you can see the patient had a bad blowout injury, the SMCL, the posteromedial capsule, the deep MCL, all the structures were torn. So again, after properly incising the subcute tissue, this is the deep MCL. The SMCL you can see floating around here. It had been ripped off. We had a complete transaction of the deep MCL, the tibial side staying inferiorly and deep MCL femoral side staying separately. The meniscus could be pulled back very easily. The anterior and posterior roots were intact, fortunately, but it was just floating around. What to do with this meniscus? So how will you stitch? Like you will stitch it directly to the bone like a transosseous. You will use a suture anchor or yeah.
The needles would take a good bite onto the peripheral periostem. So it's basically meniscotibial ligament has gone. So the whole meniscus roots are intact. It's actually gone. All you need to bring down, set it down, and then start stitching it with sutures all around.
Yep. So I think we all agree that we have to save this meniscus. Main point is, so the way I did it is I had put 3 suture anchors just at the rim of the proximal tibia. I first stitched the meniscus in the periphery, then used the same sutures to pass it from the capsular side, that is the deep MCL capsular on the tibial side, and again pass the same, as you can see on the third image here, from the femoral side of the capsule. Just to take on, like you could see the yellow arrow denotes a semimembranosus which was intact. I could not see it on the MRI. There are studies now where they recommend advancement of semimembranosus if you have such a bad injury. It's just published in 2019 and 2021. Several papers are there. I personally do not have any experience. Sir, would you go ahead and do any of these in these kind of injuries? Would you go ahead and again detach the semimembranosus, reattach it just to have an anteriorization and deceleration of a dynamic structure?
No, but it is always recommended to add on or augment a primary repair. So as I said, we would either add an internal brace or you have to have a soft tissue graft which is going to help it.
Yeah.
The tissue is weak.
Yeah.
So here, what about for the anterior medial one, that is middle part of a structure, what has been done?
So I'll come to that.
Retinacular?
Yeah, I'll come to that. So I went ahead, did the capsular repair. The superficial MCL was tagged separately. Then I harvested the semitendinosus with an open stripper, keeping the inferior attachment intact. The yellow arrow here denotes the infrapatellar branch of the saphenous, which has to be protected in these patients. So the SMCL was repaired with 2 suture anchors, which were put 6 centimeters below the joint line, and the SMCL was repaired. The semitendinosus, after getting rerouted, just to have the exact axis of pull, was used to augment the SMCL repair. And then I went ahead with the layer 1 repair, that is a sartorial fascia or deep fascia repair, identifying the added tubercle, then medial epicondyle, so the rest of the part remains the same. Augmented it with a semitendinosus. I used a Danish method to create, and also repaired the POL part at the same time with a suture anchor here. So the way I immobilized it was a PTS brace was 6 weeks. Prone passive knee ROM was started after 2 weeks. Non-weight bearing, the patient was non-weighted for 6 weeks. Then I shifted the patients to a knee range of motion brace for another 6 weeks. And then with a good rehab, that is after 13 weeks post the injury, the second surgery, that is I went in with the arthroscopy. You could see a grade 3 chondral defect on the patellar side. The meniscus looked healed well. There was no drive-through sign, so the capsule also had healed pretty nicely. I was quite happy with the way the meniscus was looking. The patient did have a grade 2 chondral defect on the medial femoral condyle. So the ACL PCL reconstructions, I went ahead, did a ACL with symmetry and gracilis 5 stranded graft. I used a peroneus longus, 3 stranded. Microfractures for the medial femoral chondral defect was done and did a patellar chondroplasty. This is a function 3 months post-op. She, as I said, she is a traffic police officer, kept on sending me her images like half marathons and morning rides. Now again, 23 months down the line, again had a road traffic accident, again had the right knee injury, presented with right knee effusion, no complaints of an instability. This time around had a lateral joint line pain, and this is 23 months post-op. There was hardly any medial opening, so I was quite happy with the medial side injury, the way it had healed. But she did have grade 1 posterior sag, although the end point was firm, but she never complained of it. This was a post-op X-ray. So 23 months, she does have some early changes of degeneration in the medial compartment here. The valgus stress test showed that she had no opening on the medial side. So again, to review, we all still have to find a consensus how to stage the surgeries properly. We have to save the meniscus. A good planning for all these structures and repairing all these structures is important. We should try to achieve anatomical or near anatomical repair for these, and a good rehab is the key for all these cases. Thank you. I would like to call upon Dr. Sabyachachi Santra for his case presentation on KD3L.
Hello. So, good afternoon, our panel.
There is there's a dislocation, and there's a fracture which is seen coming from the medial aspect. I can say from this coronal picture, anterior, AP view. So first, in order to avoid the vascular injury, do not keep it for a long time, keeping in the X-ray. Reduce it first. First, reduce it and put the slab, and then take the patient to assess for his vascularity. That is either CT scan, for a to see the vascularity. You can next is you can have it in MRI or not.
Okay, Dr. Sundarajan sir, please.
So this is anteromedial tibial condyle fracture with lateral collateral ligament avulsion, and usually they will be commonly associated with the posterior cruciate ligament injury with the meniscal injuries, because recently we published one arthroscopic technique doing everything in a single stage, but that is, I don't think it is advised for everyone. But I would advise, I think it should be, fractures have to be addressed first, like we have to fix this anteromedial tibial condyle fracture, and the LCL as a first stage, and the later on we can assess and do the secondary stage if PCL if necessary, because sometimes it can get stabilized by doing a fixation, doing all the fixations. If a second stage, if it requires PCL subluxation, then we can do a PCL. Of course, I think so, maybe because we have 3 cases like this in the same series.
Dr. Oberoi sir, please.
Yeah, I think I agree with Sundar. There's a large fragment which needs to be fixed. There is also avulsion from the head of the fibula.
What do you think about the fragment is coming from in which part?
I think we need a good quality CT scan to see, but it probably coming from the tibia. There is also a piece which is avulsed from the head of the fibula. It's an avulsion of the fibula. It's something like an LCL with probably a biceps avulsion which has happened on the fibular side. So there are two pieces which need to be fixed. The lateral side has to also to be fixed. That's a big piece there which has gone posteriorly. That probably involves lateral collateral ligament and probably arcuate ligament and also the biceps head. And then we have also a loose piece there in front. So it needs a CT to assess, but it definitely needs an open surgery in the very first stage.
Dr. Doloi?
I will reduce it immediately, then I will do my neurovascular examination. If there is no vascular injury, then I will go for both CT and MRI, and I will address the bony fragment first. I will fix them.
What do you think the fragment is coming from? That is anterior part, the large fragment?
Fibula styloid is avulsed and another coming from anteromedial tibia most probably.
Anteromedial, okay. Dr. Joshi sir, please.
I think I absolutely agree, and there is no point guessing from where it has come. Get a CT scan done, you'll identify exactly the size, shape and everything, and then you'll identify.
You never know from where it actually
Exactly.
Yeah.
Looking at the fragment, it's difficult to say that from where it has come. So rather than guessing around, get a CT scan.
So just we have to check for the vascularity, the distal pulses is present or not, and we have to check for the nerve injury also, the common peroneal nerve is present or not. So we have tried for the reduction, but the reduction is failed at that time, could not be done, and so after that we have done the MRI and also the CT scan. The pulse was palpable but slightly feeble, and there was no distal neurodeficit. So this is the MRI picture. Asymmetrical. So this is the MRI, the lateral view. Amrish, Dr. Amrish Jha, can you comment on the MRI, the lateral view?
Knee is still dislocated.
Yeah.
There is PCL avulsion of PCL and the fragment is flipped anteriorly. I think the fragment which was seen in the X-ray has come from the posterior tibia.
Yeah,
so
this one.
Yes.
So this is the PCL.
Yes.
So this one is the PCL, and that large fragment is coming to the anterior side. So this is the beauty of the case. And this is the CT scan. You can see this is the CT scan. So there is a large fragment, the posterior defect, that is PCL avulsion, and the fragment is coming to the anterior part.
Moreover, the small fragment.
And also there is a small avulsion at the posterior part of the fibula. That is the, I think that is the biceps, not the LCL, but that is the biceps. So that is not exactly the KD3L type. So after seeing the X-ray in day 2, we have done the open surgery. We have to do the open surgery for the reduction of the fragment. And we fixed that large fragment, that the avulsion part, with 2 screws by over-flexing the knee. So this is the C-arm X-ray, C-arm view, and this is the post-operative view, AP and lateral view. And we also fixed the avulsion part of the biceps femoris with suture. And there are, the LCL was intact, and after the operation the stress view was done, or stress test was done, and it was stable after the operation. So thank you, and the take-home message is, if there is a large fragment, we just have to reduce the fragment and fixation is done, and the result is better as there is the bony avulsion. So thank you, panelists, and thank you. Yes, sir?
No, this MRI, role of MRI,
Yeah.
in this case, maybe like CT scan itself will be more sufficient to
Yeah,
see
yeah,
the
yeah.
fragments, where does it
Yeah,
come
yeah.
from.
We just do the MRI, is there any soft tissue injury was present or not, to see that. Okay, thank you, sir. Thank you.
Yeah, check. So good afternoon, everybody who wants to get up, stretch, have some tea, coffee, come back quickly. Next is going to be alignment issues in sports, and I will call upon Manabendra Basumalik, I'll call upon Kanchanda, I will call upon Vinay Pandey and Saurav Mathur and Chirag Thonse for this next session. I will present only 3 cases. We will get quick answers from everybody and then move on very quickly because we're already running 1 hour late. Okay. Chalo, okay to start. So welcome to the session on alignment where we move further forwards now. Case 1 is a 55-year-old female physician, BMI 28, right ACL reconstruction done 6 years ago elsewhere, not by me. And she has disabling knee pain and she sought me as an opinion for arthroplasty. These are her x-rays. You have the scanogram on your left, you have the lateral view and you have the skyline view. This is her alignment. Okay. Right. Let's start with you, Vinay. What will you do? Arthroplasty or joint preservation? It is not compulsory that you have to say joint preservation just because we are in a non-arthroplasty meeting. You can always say arthroplasty.
So she's 55.
55.
BMI is 28.
Correct.
An active lady.
Very active. She's a physician.
So
she has
we need to
outpatients
do
of
preserving the
150.
joint.
Sorry?
The first option is preserving the
Joint preservation. Any additional views, Manavendra, or you're happy with this? Any more x-rays? You're happy?
Need an MRI.
Need an MR. You'll get an MR. Kanchan, sir? Okay. Let me show you her stress x-rays. Huh? Whenever I see valgus, I always feel that I need to know if the valgus is correctable. So I've got a varus stress view, which shows that yes, the valgus is correctable. And I have a valgus stress view, shows that she has got a deficient MCL, which she had on clinical exam. Saurav, MRI for you. On your MRI, this is the lateral side. Higher you want? Okay. Okay. On her MRI scan, what you can see is on the lateral side, she has deficient cartilage on the femur, on the tibia. She has got extrusion over lateral meniscus. She has a medial meniscus tear and extruded medial meniscus as well. She's got a deficient ACL. The ACL has gone. Now, Saurav, does it change your point of view or are you still happy?
Sir, clinically she has pain on a lateral joint line or a
Lateral side.
Medial joint line, no pain.
No.
Comfortable. I think it's the same. We should try to preserve this.
Okay, Chirag, you're a very good arthroplasty surgeon. So now you have a 55-year-old lady with an ACL, MCL deficient knee with loss of lateral meniscus in a valgus knee with chondral changes in the lateral tibiofibular joint. What will be your plan? Are you still going to do arthroplasty or still do realignment? Because you would agree that if arthroplasty has to be done in an MCL deficient knee, you would require to do something like this with a rotating hinge, correct?
So considering the age, BMI, activity demand, I would do any sort of preserving surgeries right now.
Perfect. What would you do in terms of preservation? Would you do bone alone or bone plus ligament? What will you do to the ACL? What is going to be the way you're going to tackle this?
So it's a tri-compartment OA what I see here.
Predominantly lateral
Yes,
compartment.
Lateral compartment, but there was a patellofemoral component also.
Okay.
There were osteophytes in the patellofemoral
Okay.
compartment. So any kind of ligament reconstruction is out of question. So it's only going to be a bony realignment, nothing else.
She has an unstable knee as well.
Yeah. So
Okay.
slope
How will you tackle the MCL?
So MCL automatically may get corrected to some extent when you do your realignment procedures. Now basically you are seeing a valgus knee which is correctable. Correct the alignment on table if required, then go ahead with anything else, augmentations.
Okay, let me bring your attention to this X-ray here. Again, you can see that it corrects when you give a varus stress, but when you do a valgus stress, there is gross gapping of the MCL. Do you think this MCL is going to hold? Vinay?
So once we are correcting this alignment,
yeah,
I think you bring that not at the Fujisawa point, little midline or medial.
No, the question is that will alignment alone suffice, or you need to do something more than alignment? You need to do alignment plus reconstruction. Considering
so MRI, what was there in MRI scan?
This is your MR scan. You can see that on the whole MCL is thin and stretched out.
Correct.
You see it is showing a nice wavy appearance there.
I will still go with correcting alignment only.
Okay,
nothing for MCL.
Lovely, fantastic. Right, so here we come to planning. That was her pre-op. These are her pre-op parameters. Her valgus is 13 degrees, her MLDFA is 82, her MPTA is 91, and her JLCA is 3.7, correct? So what do we have? We have an abnormal LDFA, we have an abnormal MPTA, and we have abnormal JLCA, right? So Manabendra, now what is your plan now? You can see that everything is wrong.
I'll still think this is a candidate for arthroplasty, and
so
the
you are
amount of medial laxity that we think is there can be balanced out. Maybe we need to add a augment medially, but I think it can be balanced out arthroscopically.
Yeah, I think
we really don't need a hinged implant.
Trust me, you will definitely require a constraint or a hinge implant in this because the MCL is really deficient. And she's 55, you want to give her a rotating hinge at 55?
No.
Kanchanda, your thoughts? Preserve. Okay. So this was my planning for her. We had to get a neutral alignment to 0. So she requires a double level osteotomy, both in the femur as well as in the tibia, because she's got abnormality in both places. And to counteract the JLCA, it's important that you do a ligament reconstruction as well at the same time. So it's important to correct where the deformity is. It's not correct to just do a femoral sided correction because it's valgus, or a tibial sided correction if it's varus. And there's a whole bunch of literature now which says that if you leave a joint line which is very oblique, more than 4 millimeters, then you will definitely have a poorer outcome. So this was her plan. She had a lateral opening wedge DFO. She had a medial closing wedge HTO. I did a same stage revision ACL reconstruction using her quad tendon, and I did a double bundle MCL reconstruction also at the same time using her peroneus longus graft. This is her arthroscopy view. You can see that the patella looks fairly preserved. Trochlea is a bit bashed, Chirag, so I don't think it was that bad as what we feel it is. Medial side, well, grade 2, some meniscus damage, not bad. Intact root, cartilage looks fine. ACL is completely gone. Osteophytes within the notch. Lateral side is grade 4, and that was her arthroscopy image, which I have for you. And I told you exactly what I ended up doing for her. I ended up doing a combined 4-stage procedure all at the same time. So this was her final outcome: open wedge, lateral DFO, closed wedge, HTO, ACL reconstruction, and also doing a double bundle MCL, and this is what we achieved. So this was her coronal plane final images 9 months down the track. She's back to her own practice. And this is a biplanar osteotomy for the DFO, which is also very important. And you can see that this was the pre-op and that was the post-op. Saurav, any comments? Any suggestions? Would you agree with what I've done, or you feel you would have done something different?
I would have sent the patient to you. I would not done this much big surgery. That's a fact. That's coming from the heart. Okay. But one question.
Yes.
Instead of doing a ACL reconstruction,
yes,
at a 55 years age with
yeah,
OA knee,
yeah,
just simple doing a slope correction would have helped? Or
Her slope wasn't too off. I didn't put all the images for lack of time. Her slope wasn't too off. She didn't have a high posterior tibial slope, and it was just a failed ACL because of an MCL which was not tackled at the same time. The surgeon repaired the ACL, left alone the MCL, and now we have enough data that the old concept of conserving the MCL and doing the ACL alone is absolutely does not hold true now. Even if there is a grade 2 laxity on the MCL, you have to do something to it, because all those ACLs in which you leave behind a lax MCL will eventually fail over a period of time, and this is a classic example of it, and that is what has gone through. Yes, Vinay.
So any reason for this obliquity of the left lower limb as compared to the right?
Come again?
Did you had any limb length discrepancy? On the first X-ray after the reconstruction,
yes,
left lower limb looks little oblique as compared to the right one.
So the contralateral limb.
Contralateral.
She's got tibia vara on the opposite side.
Okay, so there was no limb.
That's constitutional tibia vara. Yeah. Right. Case 2. She's a 20-year-old female. She's a runner and a housewife both. She's got knee pain with instability. She's had 2 ACL reconstructions on her left side. That's her long leg alignment. Okay, I'm just going to give it away very quickly. That's her monopedal stance view, which you can see here. And when you calculate her tibial slope, you draw a line which goes along the long axis of the tibia, and then she has got a high posterior tibial slope of 13. Now we know very well that when you have a posterior tibial slope which is more than 10 degrees, your anterior tibial translation, which is obligate, increases by about 6 millimeters. Kanchanda, in your practice, what is your cutoff when you decide that you need to do some bony surgery to tackle a tibial slope?
Only in revisions, and I've done very, very few of them.
What would be your cutoff? You would say that, okay, now I think I'm not going to take
6 millimeters thereabouts.
Okay.
I would only go beyond it is more than 10, 12.
Okay.
Yes, probably I would.
Okay, Saurav, you have, I come to your clinic, I have a lax ACL, you get an X-ray done, I have a tibial slope of 15 degrees. Primary ACL tear, 15 degrees slope. Would you correct my slope at the same time, or would you just do an ACL and just counsel me that, okay, you have a high slope and you're going to re-tear again?
I'll do just a simple ACL reconstruction at the first time. Obviously, we'll compare it with the other side also.
Both sides I'm 15 degrees.
I'll do simple ACL reconstruction. We'll go slow with the patient. Maybe keep him for a non-weight bearing for 6 to 8 weeks. And if it's a revision, I'll go for osteotomy. But for primary case, no.
Chirag, in this situation where I just spoke to Saurav about, will you add an extraarticular procedure just to protect the ACL?
In the primary scenario?
In the primary scenario, forget this case.
Yeah, primary scenario, definitely I would go for a BTB graft.
Correct.
If not, I would go for a 5-fold or 6-fold hamstring and a LET.
LET. Okay. Vinay, in your practice, how many anterior closing wedge osteotomies have you done?
So no.
Okay. Anybody who's done anterior closing wedge osteotomies? Okay. So when you do an anterior closing wedge, you can either do it above the tibial tubercle, you can do it at the level of the tibial tubercle, or you can do it below the tibial tubercle. Not such a good idea to do it below the tibial tubercle. You do it either above or at the level. The advantage of doing it above the tibial tubercle is essentially you don't touch the extensor mechanism, but the amount of wafer of bone that is left behind is so small that if unfortunately you run into non-unions, you have nothing left there, which is why the whole concept of biplanar osteotomy has come into vogue, because you get a decent sized proximal tibial fragment. If there were to be a non-union, you still have some bone to work on top. So my preferred technique is definitely doing a tibial tubercle osteotomy, lifting it up. The hinge is at the insertion point of the PCL. So 1 millimeter of bone removal corresponds to 2 degrees of correction. And this is the way I do my anterior closing wedge osteotomies. And this is what she was at the end of her final follow-up, which was 2.5 years down the track. And now you can see that this is the well-healed tibial tuberosity. I've shifted now to using 3.5 screws rather than 4.5 screws. And of course, she had a same stage ACL revision as well, using her quad tendon graft, which I think has become one of my preferred grafts to, especially in patients with such type of situation. And we've been able to reduce her slope from 13 to 6 degrees, and this is the final follow-up. MR scans showing well constituted cartilage, good ACL, and good restoration. I'll come to the last case now, and I'll ask Manavendra to take this case. So, Manav, I have a 35-year-old male who's an architect, BMI 27. He plays badminton. He really loves his game, plays 3 times a week. He had a left knee injury which was managed conservatively for 2 months. He complains of disabling knee pain, instability, numbness in his foot, and he seeks opinion for a stable, painless knee. Since we're talking about alignment, I'm going to jump straight to his alignment x-rays. Again, you see a valgus knee right there, and I'll bring out the planning for you. This has been done on, I think this is Medicad or PeakMed, I don't remember. So there's a valgus of 7 degrees, the MLDFA is 87, the MPTA is 91, and the JLCA is 3.6. Okay? Yes, Manav, your plan for this patient now.
MRI?
MRI. Let me see if there's an MR afterwards. I don't remember I don't think I have the MR with me right now.
So what's causing the pain really?
So the pain is because of cartilage overload. The pain is because, it is because of an MCL laxity as well. So the JLC is high.
So anything to do with the lateral meniscus gone, torn, ruptured?
I'll just bring out his MR scan. So I think, his MR scan is right here. 1 second. So, this is what I commented upon. Yeah, that's his MR scan. MCL torn from the femoral side, medial meniscus root extrusion. The lateral meniscus is fine, but there's a counter-coup injury on the lateral femoral condyle, and the extrusion of the medial meniscus.
Medial or lateral, is it? Oh, yeah.
See, that's his MCL. That's the medial meniscus extrusion, which is 4.5 millimeters, and that's his lateral meniscus. Cartilage looks not too bad. You come to his sagittals, ACL rupture, and what you have is cartilage loss on the patella, and you have a swollen common peroneal nerve. So the diagnosis for you is a valgus knee, ACL deficiency with rotatory instability, MCL laxity, medial meniscus extrusion because of a radial tear, a chondral defect in the patella, and common peroneal nerve neuropraxia. Your plan.
So what could be the cause of the common CPN neuropraxia?
I think
if
it was.
Got a valgus
I think it was just the force of the injury because he tore his ACL, MCL. It must be some kind of torque, or maybe if somebody has applied a brace and that brace was pricking onto it, but he just had tingling numbness, no neurological loss.
Okay, so I think you're looking at his angles. Both his distal femur and his proximal tibia looks to be slightly off. And we look at the angles again. Yeah. So both these angles, the distal femur is looking oblique, the proximal tibia is looking oblique. So this is like a bipolar malalignment.
So his LDFA is normal.
To the right side,
his LDFA is normal. His lateral distal femoral angle is 87.
Normal, okay. So, but it's looking abnormal. And if you compare it with the opposite side, his joint line is also lower on this side. Is it because of pelvic?
That's because he's in valgus, which is why his pelvis is tilted.
Okay. So I think he'll need reconstruction of the MCL and maybe the meniscus. I'm not very sure what's the status of the meniscus, but to protect that, I think he'll also need realignment in the proximal tibia.
Okay. So Kanchanda, all single stage or multiple stages? Yes. I don't know why he's got a CPN neuropraxia. Yeah, but there's no lateral sided injury, there's no lateral opening. So there's no posterolateral corner laxity that he's got.
Regardless of what we do, if we do any alignment surgery correcting the valgus, we are likely to worsen the neuropraxia situation.
Why would you say so?
Any valgus correction causes stretch on the lateral nerve. Any correction of valgus would cause an additional stretch if the nerve was well to start with.
It's a swollen nerve. You can always do a common peroneal nerve neurolysis at the same time. It's a neuropraxia. It's just a swollen nerve,
But for this? I mean, he's got an ACL injury and his primary concern is pain.
So it's ACL, MCL, patellar chondral defect, medial meniscus extrusion because of a radial tear, valgus knee, and a common peroneal nerve neuropraxia just thrown in for, just to add more flavor.
Everything else is in one plate about the pain, the other
Yeah.
one is about
Yeah. The pain is not the nerve, that's for sure.
Yes.
Yeah.
So for this, I think I agree with Manav. I'm going to do an osteotomy, and I'm going to add an Acl reconstruction as well. And MCL.
Okay. Saurav, let me show you his clinical picture. So that's how his knee looks. You can see that he's got a pivot. Surprise. He's got gross grade 3 Latchman, and he's got medial opening, which is grade 2 as well.
So all in a single sitting should be done.
All in a single sitting.
Correction, ACL reconstruction, MCL, and medial meniscus.
Chirag?
So I would definitely get NCV done first.
Done. Neuropraxia.
Okay. I would stage it. First cater the nerve.
Okay.
How long is the duration of the injury?
2 months.
2 months. I would definitely wait up to about at least 6 to 9 months time. Do a neurolysis if you want, if there is a conduction block in the nerve.
Okay.
If not, simply wait up for about 6 months and repeat the NCV or wait the nerve to recover.
Do you think the nerve is the biggest cause here? I'm just asking.
No, but if you worsen,
I've got pain, I'm walking in valgus, and I'm going to keep stretching my ACL, I'm going to keep stretching my MCL, my meniscus tear is going to worsen, my patellar cartilage is going to worsen. Do you think it's really required? I mean, I'm just asking. I mean, what is the philosophy behind waiting for the nerve when we know it is not a serious injury? There is no transection, there is no axontomesis, there is no neurontomesis.
but if you have a conduction block post-op, then again
you can always do a neurolysis.
You're supposed to be bracing it post-operatively anyways.
Yeah.
That's another risk factor you're likely getting into. So I
Okay.
would be patient with this. Probably do a neurolysis if it doesn't recover in 6 months, and then you can always go on with your ligament reconstruction.
Okay. Any more for neurolysis first and then?
I think we can take the nerve out of the picture actually.
Okay. So yeah, these were the angles as I just said. I just spoke to you about all the angles, just going through them one more time, just so that we don't forget about them. And since the deformity was in the tibia, the correction was in the tibia in the form of a medial closing wedge type of a deformity. This is his arthroscopic picture. You can see that that's his ACL tear which was there. Completely torn ACL. That was the flap tear which was sort of locked underneath the meniscotibial recess, which was probably the reason why he was getting pain. Another large flap which was jammed in the back of the knee, which was very hard to and difficult to get out. Another cause of his pain. A lateral meniscus tear, which one can observe. And this was my planning. I had to tackle the nerve, so I said I'll do the osteotomy, but I'll apply the plate from the lateral side. So I did a lateral, I did a closing wedge osteotomy for the tibia, but used a lateral incision and used a lateral plate to stabilize it. Again, because I had to do an MCL also at the same time. So a plate on the medial side and MCL on the medial side would have caused a lot of conflict. The graft of choice for the ACL was the central quad, and then this is what he is at the end of the procedure, having had a single stage procedure of all the 4 things done. The nerve was neuralized as what Chirag had suggested at the time of the surgery, so that problem was taken care of, and this is what it was. So I think the take-home message is that we should be gardeners, we should not be mechanics, we should look at joint preservation. We all love to do knee replacements, but I think it's really important that we don't forget the gardener's approach as well. And I thank the entire elite panel for their fantastic discussion, and hope to see you soon one more time in the next couple of months. Yes, Manav. 1 second, I'll have to go back. A lateral open wedge would have placed stress on the nerve, so that's sorry. You could have done that, but then you would have when you do a lateral opening wedge osteotomy on the tibia, you then start running into problems with the tibiofibular joint as well, which is something that you need to avoid. So the correction is, I don't know. You'll have to read it there for me. I can't read through my glasses here.
If you want to do a similar thing with the neuropraxia and the femoral osteotomy, you do an open wedge lateral or a
So for this case, you can't do a femoral osteotomy because correct. Okay. So Dr. Kanchanda's question is that if one had to do a femoral osteotomy and do a nerve, what would you do? Well, in that case, there are two things which are major determinants. You have to check the leg length. If the leg length is equal, then or if the leg length is short, then you can do a lateral opening wedge. If the leg lengths are equal, you are better off doing a medial closing wedge, and then you make a separate incision for the nerve. So I don't think you want to tackle, try and do the nerve and everything in the same incision, because that can create problems at times. Okay? Thank you very much. Thank you all. Huh? The slope was not abnormal, so there was no slope correction that was done for this patient. Huh? No, the wedge is closed medially. The plate is applied laterally. The wedge is removed from the medial side, but I have applied a plate from the lateral side, and it is a bicortical screw fixation plate. The reason being is because my MCL reconstruction is on the medial side. I would have run into conflict if I would have done everything from the medial side, a medial plate along with a medial MCL and a tunnel for the ACL. Too many things on the medial side, and that's why I chose to do a bicortical plate. So if you see here, the screws are bicortical. Otherwise, normally for an HTO, you will not go completely through and through bicortical, at least with the proximal screws.
In that bargain, the ACL would have balanced. That was if you correct the slope.
Once you close the slope, once you close on the tibia, the slope anyway decreases. When you open the tibia, the slope tends to increase. When you close the tibia, the slope tends to decrease. So anyway, because it is an ACL unstable knee, you are achieving.
Where do you start your osteotomy from? I would start it distal to the jig placement. A simple trick here is to place your underbutton reamer there and then introduce your bead pin so that you do not transect your tunnel of your root repair. I would then protect the posterolateral structures with either a translucent retractors or use stuff your posterior capsule with the gauze piece. Once that's done, go ahead, complete your osteotomy. I usually take a step cut osteotomy, which would also decompress your patellofemoral joint, and always I would use my HA wedges here. I'm opening up about 9 millimeters. How many of us would really want to use a HA wedge? Or is there any role for a bone grafting or a bone substitute here?
Till 7.5 it is not recommended. More than 7.5 you need to either do an HA or a bone graft.
Okay, so now if I'm opening up 9 millimeters, what is the wedge size you would introduce, I guess, sir? You would put in a 7.5 wedge or you would put a 9 mm wedge for a 9 millimeter opening?
I mean, I usually use a Puddu plate rather than a non-locking kind of plate, so they actually don't allow the collapse to happen. So for me, whatever is the size of the wedge, the same size of the Kronos wedge would go.
Okay.
Worst effort.
Yeah. Any other thoughts from the panel regarding using HA wedges? Or how many of us would use autograft here?
You said you're opening 9.
Yeah.
So then for 9, I think wedge would be better in our hands.
How many of us would leave it without any sort of bone substitute here? 9 millimeters opening.
Just up to 10 mm, there is no need for any bone grafting, anything to do there.
Okay. So any kind of fixation devices could be used, and once you have fixed your osteotomy, one would go ahead and then fix your root repair with knee in full flexion, either with the suture disc, or one could simply tie it with the device there, and this would be the final correction.
But if you produce the osteotomy is too low, it will be just like producing a deformity to mask another deformity.
Yeah,
because
so
as you come down, you will be producing a deformity to mask another deformity. If somebody argues like that, how will you?
Yes,
quadrant?
definitely. So what we do here is keep the jig angle less, probably about 40 to 45. That would give you enough space there for your osteotomy.
So how did you plan your ACL position and the osteotomy? So which one do you decide first?
HTO and
sorry, for root repair.
Root repair.
So where do you want to put your?
Yeah, first I would do my tunnel of my root.
Right.
And then
Do the osteotomy.
Yes,
So you
do
decide
the
the
osteotomy.
osteotomy site and just keep
Yeah,
your tunnel
below
just
that.
above that.
Yes, so that your tunnel is not transecting your osteotomy site.
So in some of these cases where he rightly pointed out, you actually end up doing an osteotomy quite lower down just to protect your root.
Yeah.
We discussed about it,
Yes.
putting an anchor rather from the posterior-medial
Yes.
portal, and not at all using a tunnel technique. So then you are free whatever area you want to put an osteotomy.
Yes,
so that's also a good idea.
Yeah, that's another anchor repair of your root is another technique which one could definitely use. And if you see my endo button here, I mean suture disc here, it is much above the site. So I've probably used about 40 degrees of angle for my jig. That would be a simple trick. Now quickly let me run through the second case. I'm not going to elaborate on this. It's just a continuation of the first case. 48-year-old housewife, minor twisting injury of the knee, pain, locking, moderately built, gross varus deformity, medial patellofemoral joint line tenderness, that's mostly posterior-medial. We get an alignment X-ray, similarly varus deformity. This is the MRI. There's a complex tear of the posterior horn of the medial meniscus. Patellofemoral joint looks fairly good and there's no lateral compartment involvement. This is intraop. As we enter here, the medial compartment, the lateral compartment and the patellofemoral compartment did look pristine, but this was the state of the medial compartment. Grade 4 OA on the femoral side and the tibial side, with the root and a complex tear of the medial meniscus. Now in this kind of scenarios where we have grade 4 OA, almost bone-on-bone deformity, would we just debride the meniscus and go ahead with the osteotomy, or just defer the osteotomy on the whole and go ahead and counsel the patient for a uni knee, or just do a high tibial osteotomy? This is the root which is retracted. Of course, I debrided this. What would the panel do, doctor?
Considering his A's and arthroscopic picture, I'll still go with meniscal debridement, then IT osteotomy.
Okay. So just a debridement and HTO. Would you want to add on any sort of a cartilage procedure here?
No.
No cartilage procedure. IPS, sir?
I don't think cartilage procedures would help too much in such case. It seems more like a global arthritis now. Yes, HTO and just debridement and cleaning. Maybe you can supplement with either a visco supplement on or maybe a PRP, something like that, till she's ready for a joint replacement.
Okay, you would still go ahead and do a HTO rather than counsel the patient for a uni. Pratik, sir?
I would talk to the patient what are the demands and what does he want, because with this kind of grade 4 changes, any cartilage procedure is not going to work. Whatever we are going to do is going to be temporary. So in some time, with the age and looking at the alignment, I would have thought of uni, talk to them about uni, and they are okay, then maybe think about it. She's 48.
Yeah, Tada, sir?
What is his profession?
She's a housewife. Housewife.
So better you can go for the HTO. There is no need for cartilage procedure here.
Gopi, sir?
So how is the compartment, lateral compartment?
Lateral compartment and the patellofemoral is pristine. There's no OA changes at all. It's an isolated medial compartment. And if you see the pre-op X-rays, this came in as a surprise. Pre-op X-rays look decently fair enough, but this was the intraoperative picture. Gopi, sir?
Since there is a global cartilage loss, even HTO may not help in bringing any symptomatic relief to this patient. So uni may not be useful because I don't know the ACL status. So presently you manage conservatively and convince the patient for a later arthroplasty.
Okay, doctor.
So I will do the same. I would debride it. I would do the microfracture of. I will try to clear those cartilage, and then I will counsel the patient, because she's a housewife. She's not an active person, but there retains a chance of the increase in arthritis over that region. So I will counsel and then wait and watch for her after debridement.
I did go ahead and do a HTO. With the literature reviews, we have very limited data. There are only short-term results available for simultaneous HTO with the root repair without any significant advantages in most of the papers. So it's a subjective decision to by the surgeon to either undergo root repair with the HTO or just go ahead and do a HTO there. Thank you, one and all.
Root fix anchors. When we are doing HTO with root repair, that is very useful.
Yes.
Chirag, how it looks like well healed, so she is down the line. Does she get good benefit? Like,
So it's
what's
about,
her
it's
feedback?
about this X-ray was just taken about a week back. She's okay, symptomatically better. But yeah, of course, we did talk to her about TKR in near future.
Yeah, because there was extensive involvement of the medial compartment.
Yeah. Thank you.
Of the patient. On the left side, he has MLDFA 88 degree, MPTA 81 degree, and JCA 4 degree. Now the Mikulicz line falls just on the medial aspect of the joint. So directly going to the arthroscopic findings, you can see there is a medial meniscus normal, osteophytes in the intercondylar area, a big chondral defect on the medial femoral condyle. The ACL is completely torn, and when we see the lateral compartment, the cartilages are normal. It looks quite okay. The drive-through sign is not that positive, so there is no abnormal laxity. The lateral meniscus is almost normal. So now, question 1, what are the treatment options? I'll start from this side. Dr. Bibhuti.
Sure.
So will you go for arthroscopic ACLR alone, or ACLR with a chondral procedure, or HTO alone, ACLR with HTO, or ACLR with HTO with chondral procedures?
Sir, I would go with ACLR with HTOs.
ACLR with HTO and will not do anything for
no, I will
the
try,
cartilage defect?
Yeah, I will try to clear off the cartilage, but I will
Okay.
not go for any other procedures for the cartilage.
Okay. Dr. Gopi?
Before going to the actual treatment, I want to know a little more about this patient, because as Dr. Sachin told, you have to look at the slope always. So ACL is gone, so we should be more focused to know about the preoperative slope of this patient.
Yeah, that
yes,
yeah.
yes. Can I continue? So if you do correction of the slope, if you increase the slope in this case, his ACL is going to be worse. So better for this patient is a reduction in the slope. So you can do an HTO at the same time, you should correct the slope of this patient. So if you reduce the slope, it is good for this patient. So HTO with correction of slope, ACL reconstruction and chondral reconstruction. So what is the slope?
The slope was 8 degree.
What is the age of the patient? How many
40 years. 40 years.
40 years. How many days old injury? This
1 year back.
1 year, sorry.
Your choice?
So my ACL with lateral closing wedge osteotomy.
Lateral closing wedge osteotomy. Okay. Why do you prefer lateral closed wedge?
That will be beneficial. 5 degrees with the lateral closing, you can have the opening of the tibial slope for the benefit of ACL. When you are doing ACL, work on the lateral side. So lateral closing better for the ACL.
So stability and will help to ACL. Dr. Pratik, what will be your choices?
Yeah, with this kind of thrust that we're seeing, definitely high tibial osteotomy with ACLR. Chondral procedure we'll have to see, because definitely we'll debride and do at least microfracture. Thinking of OATS, because it looks like quite a big lesion there. That's option there, but definitely minimum microfracture. So okay. HTO, ACLR and microfracture.
To Icrs?
Yeah, I think ideally ACLR needs to be done. HTO preferably a closing wedge osteotomy that will protect the ACL as well. And chondral procedures have to be added. It's 1 year, patient is still 40. We still need to do something about cartilage. So most probably an OATS for me.
With this varus deformity, you go with closed wedge?
Usually no. If you are doing an open wedge, you have to be very, very cautious about not increasing the slope. Okay. So you can do an open wedge laterally also, but you have to be really cautious about modifying the the slope, or at least not increase the slope. Yeah. You have tricks to do that.
Need to fix with the this one staple. Anteriorly one staple has to be put, otherwise it will displace.
In this setting, 40 years young gentleman with varus thrust gate so clearly seen, along with the ACL tear and the cartilage loss at the weight bearing region. I think ACLR, IT velocitomy and chondral procedure.
So the consensus is ACLR with HTO, with or without chondral procedures. So some would go with the closed wedge osteotomy, lateral closed wedge osteotomy, and when you are doing the medial open wedge osteotomy, you should be well aware of your slope correction.
What about the patellofemoral joint?
It's normal.
It's normal.
Yeah. So if you can see this literature, a combination approach of HTO, ACLR and a chondral resurfacing shows excellent results in a long-term follow-up in selected young patients, even in severe osteoarthritis. However, the role of the potential benefit of the ACLR and chondral resurfacing compared to HTO alone remains unclear. So if you see this article, so HTO with ACL gives a very predictable and satisfactory functional outcome in the post-operative period. And when you come to this meta-analysis, here it remains, they tell that it remains unclear if HTO with ACLR is superior to ACLR or HTO alone due to lack of comparative studies. However, it is observed that the patient is continued to have progression of OA despite combined HTO with ACLR. So these are the suggestive literature. The next question is which one first? Dr. IPS, whether you will do ACL first and then HTO, or you complete your HTO, then you do ACLR, or you mix both these procedures?
So I mix both the procedures. I mean, I would make a femoral tunnel, I'll take a graft, I'll make a femoral tunnel, I make a tibial tunnel, I put a reamer, I go in for an osteotomy, fix it later. So it's basically both the procedures done at different stages, but at the same time of the surgery. It's not a stage procedure.
Dr. Pratik?
Similarly, we decide our osteotomy site and also plan my tunnel site. I would do the ACL femoral side, do the osteotomy, and then the tibial tunnel afterwards, once I know. Sometimes if I find that difficult, then I make the tibial tunnel. I know my osteotomy site, make the tibial tunnel, put a reamer there, and don't fix the anterior screw of the plate, and do that at a later stage.
Okay.
So that's how staging.
Jaya Prasad.
So I do femoral tunnel first, HTO, ACL, ACL tibial tunnel, the bone which has taken from the, if this is a closing wedge osteotomy, I will put at the.
No, you do the tibial tunnel first, then keep the reamer and do HTO, or you do HTO and then you are creating the tibial tunnel.
Tibial tunnel, correct.
First you are doing HTO, then
No.
tibial
First
tunnel.
femoral tunnel, ACL femoral tunnel, HTO, tibial tunnel.
Okay. The next one is which implant? So we know there are different implants. Maybe it's a Tomofix or a this Pudu plate or peak power plate or new clip plates. So there are different other plates also. So what are your preferred implants, Dr. Gopi?
In this case, I would rather do a lateral closing wedge osteotomy. Any plate will do, but for medial side, a Pudu plate is the choice.
Pudu plate. Dr. Vibhuti?
Yeah, Pudu plate would be better, sir.
So Tomofix is better because it is off to the bone, so it doesn't violate the MCL. So that is the advantage of the Tomofix.
Okay. Dr. Pratik?
Yeah, I use Tomofix. I would prefer Tomofix.
Eyepiece?
So small tibia, small patients, Pudu plate, bigger patients, peak power plate.
Okay.
Tomofix, usually it is the first screw that is disturbing the tunnel. So first screw at the last after the tibial tunnel.
Yeah, Dr. IPS, how you put your screws? How you manage your screw placement?
Pudu plate is not at all difficult. I mean, just 4 screws, so you can actually cheat the tunnel and put the 4 screws.
Okay. When you are putting
in P power, there is an issue. So what basically do is we're going to fix the femur first, the upper part of tibia first, put a reamer, and then finally change the direction of the screws, maybe cheating by around 15 to 20 degrees only. You can actually oblique the plate instead of putting a direct lateral plate. The plate comes in a bit oblique manner, and then you try to cheat it. So that's the only.
Yeah, you put the enter screw first and then take out and then do the rimming. Or after rimming directly you put the enter screw.
No,
because in peak power plate you cannot change the screw direction.
Yeah, you just put first screw. Yes, your plate is still in your hands, and then once you put the distal screw and then you cheat the tunnel, and then you finally fix the configuration.
You go for a biplanar or uniplanar osteotomy?
Yeah.
The chances that the anterior tunnel and the anterior biplanar osteotomy can sometimes stay close.
That is why I said when you have a very small tibia, you actually do a biplanar osteotomy but fix it with Pudu plate. But in a big tibia, you actually go for a peak power plate.
Okay. When you open this, it should be better that you open up more on the posterior side, less on the anterior side, so that in this case you can adjust the slope.
So you keep your plate on the posterior side and
open up more on the posterior side, less on the anterior side, so the slope will get increased. That will be good for this patient.
Yeah, so the consensus is you try to put your plate a little posterior side, keeping space for the tibial tunnel, and then you put your last anterior screw. But ideally the screw should be in a divergent manner if you are using this in your plates, and you can very well come in the center of these 2 screws. Okay, next, to suggest this, you can see this biomechanics of new implants for STO. They are suggesting that both the mechanical static and the fatigue strength increase with wider proximal T-shaped plate design together with the diverging proximal screw. The wider plate is better, proximal wider plate and divergent screws are better for this HTO. Now question number 4, how many of you routinely address this posterior tibial slope while doing open wedge HTO? If you change the slope or you keep it as such and do the HTO, or what you do?
So if
the slope is normal.
Yeah, if you are doing a open wedge osteotomy for a patient which has got a PLC or a PCL deficiency, it's beneficial because then you are going to actually modify the slope. The problem happens when you are doing with ACL, and that is the point which actually Gopi also raised, that you are in danger of altering the slope. So then you have to be cautious And as JR rightly said, you actually put a staple in anteriorly, and then when you do osteotomy, it doesn't open much anteriorly.
Okay. So you should not end up with a high increase in posterior slope in case of a ACLR with a STO. So always check with your posterior slope when you are doing the surgery and keep small alteration. But when you are doing a medial open wedge STO, if you see this literature, the magnitude of the change after open and closed wedge STO was similar and very small, up to 2 degrees, suggesting that both the osteotomy techniques may have very little effect on the biomechanics of the cruciate ligament. So unless until you do a error in your technique, it will not going to change much if your slope is normal.
But the point is you should make conscious effort to alter your slope.
Okay. Okay. Now the last question is ACLR. You will go with a conventional technique or all inside technique. Now taking into consideration of the advantages of all inside technique with a narrow tunnel and with a conventional technique wider 8, 9 mm, 10 mm tunnel. So which technique you prefer? Dr. IPS.
Yeah, I think this is one of the indications where all inside is a good option, because you don't want to put any screw in the tibial side. So it's a good option, and you have a very small socket, and then rest is a small tunnel. So this is one of the indications where I would do an all inside.
Jayaprasad?
Yeah, you can go with the conventional one. You can put an anchor distally, extra fixation. All inside is always good here.
Okay.
If you are able to do all inside, that is a better in HTO.
Okay. So in HTO, if you are able to do a all inside technique, it's better considering the creation of the bone sockets.
The problem is your screw, once you are putting the Tomofix or any implant, with all inside you cannot check that your screw is going through the tunnel. With the conventional technique you can put a drill.
No,
a reamer is there. Yeah, but in all inside it's not possible. On all inside, because
in all inside you just pass your flip cutter,
yeah,
flip inside the knee joint and keep it inside the knee joint, and then you pass your screw. So you can do that very well. So in our case, we did a pretty similar way. This was the case where we first give the incision for this STO, and then identified the pace, and then both the tendons were identified. On the medial border of the patellar tendon, the incision was given, and the soft tissue was removed as a flap, just erasing from the bone surface. And gradually you pass a blunt retractor. Always it's advisable to pass some radiopaque gauze pieces to protect the neurovascular bundle. Then you harvest the graft, and this is the flap you can see. So now checking the stability of the knee before doing intra-articular procedures, we went inside the knee joint, and for this cartilage defect we did a simple this microfracture after removing the loose chondral flaps. So once the microfracture is over, then on the notch we removed all these osteophytes and did a gentle notch plasty to create a U-shaped notch instead of this V-shaped notch. And these osteophytes were removed, and then the femoral tunnel was done in a conventional way. Creation of the femoral tunnel, passing of the suture, and then after creation of the femoral tunnel and tibial tunnel, we go with the osteotomy. So here we come a little bit down below from the tibial tunnel so as to avoid any interference with this tibial tunnel. The second guide wire was passed. A biplanar osteotomy was planned at an angle of 110 degree. and the normal tibial osteotomy was also done. And key is to just cut the posteromedial area and keeping the gauze piece on the posterior side. And this is the osteotomy. Then you open up the osteotomy, and with a special osteotome, you introduce the osteotome, check under the C-arm, and gradually open up this osteotome and check the alignment, how much you are opening. Now after checking the alignment, then you put a spacer bar हैंग हो गया है.
By the time that video is by the time that video is ready, instead of elevating the flap extensively like that, you can do a minimally invasive procedure anteriorly, and you can put another incision on the posteromedial part of the tibia, and that can be elevated posteriorly, so that it will protect the neurovascular
bundle.
So that is a better technique, especially for the beginners, because neurovascular bundle will get never affected.
Okay. Okay. Then quickly we'll just finish up. Then keep the spacer bar. Again you check the alignment, and if it falls on the lateral tibial spine, then put your spacer plate, that is a poodoo plate, and put the screw on the distal and proximal posterior, and then keep your reamer in the tibial tunnel, and then put both the screws and go ahead with your graft passage of your ACL, and this is the final intra-articular procedure, and distally you fix with a peak screw, and you can see the wedge shaped opening more on the posterior side and less on the anterior side. Since the opening was more than 10 millimeter, it was 11 millimeter, so we decided to give a bone graft in this case. So follow-up was the knee mobilization and quad exercises from day 1. Weight bearing was avoided till 3 weeks post-op because of control procedures. Gradual weight bearing after 3 to 6 weeks, and full weight bearing and strengthening exercises from 6 weeks to 3 months. The 6 weeks follow-up X-ray, and at 3 months you can see the MPTA was the scanogram shows MPTA was 90 degree, MLDFA was 88 degree, and JCU was less than 2 degree. So take home message: ACLR and STO is the treatment of choice if the patient presents with both pain and instability along with varus alignment. If pain and malalignment, no instability, STO. If instability with short history of without pain, only ACL. Both pain and instability with malalignment, ACL with STO. It's always preferable to do arthroscopy first and finish with the tunnels before doing the STO. And it's always safer to put the proximal entry screw with the reamer in situ in the tibial tunnel. The entry plate placement leads to increase in tibial slope, and hence the posterior plate fixation is preferable when combined with ACLR. However, with newer implants with variable angle screws, this issue seems to be less significant. Thank you.
One problem with this particular technique is that you may produce excess valgus on the tibia. So one option is an orthofix type of external fixator where you can adjust the correction post-operatively.
Okay, how many of the panel use orthofix for the correction of this kind of injuries?
Yeah, we are using that, but the only problem is you cannot adjust the slope. Slope adjustment is very difficult with the orthofix type of external fixator, but you can adjust the correction post-operatively. So if you produce excess valgus in this case, it is valgus forever. In the other case, you can adjust the valgus or varus, and then you can take check X-rays and assess the progress of correction.
Okay, thank you.
Okay. I'll try to be quick with my case. So all this while we've been seeing cases wherein we have like predominant medial arthritis and unstable knee. This case was a little bit different. I had to really look for a lot of literature around to figure out what should have been done, and we'll go over quickly what I ended up doing. So I'll come straight to the case. So this is a 47-year-old female, BMI 27. Who presented with a persistent progressive knee pain. It was more on the right side than the left. She consistently reported of persistent calf pain, mainly in the night and on standing. On examination, the right knee had a range of motion. There was an extension lag of 5 degrees, medial joint tenderness, no patellofemoral crepitation, and partially correctable varus. So this is the standing X-rays that we got, and as per the patient, she had more symptoms on the right side. She wanted to discuss the treatment options. She's 47-year-old female. So looking at the X-rays, what I can see is like it's predominant medial OA, and it's minimal osteophytes, not so much like a lot of osteophytes. Dr. Vivek, do you have anything more to comment, like anything bad, ominous that you see on this X-ray apart from a predominant medial OA?
So first thing I would be needing in this is long length X-ray, the scanogram.
Yeah, we'll come to that, but just looking at the standing, these are standing X-rays.
Okay. By looking at the standing X-ray, I can see that one is right?
Yeah, the one on the right is the right one.
There is in bilaterally those we can see predominant medial compartment osteoarthritis,
right.
more in the right side with some subluxation. I think the TBI is subluxated little lateral than the other side. The joint looks okay, and slope is more on both knees, more in the right side, I think.
Exactly. So IPS. So looking at the X-ray and hearing at the patient's symptoms, what would be your first Would you like to explore the option for preserving the joint, or would you be more in favor of trying to do a replacement with her?
I think we need more X-rays. We would probably need a scanogram. We would also need a patellofemoral skyline views.
Okay.
And possibly an MRI as well.
Okay.
In a younger patient, try to preserve as much as possible.
Right.
Osteophytes are minimal. We think that this joint can still be preserved.
Okay. So we got a MRI just to make sure that it is what we are thinking about, predominant medial OA. So except for the first image, looking at the second image, we see that the patellofemoral joint space is well preserved. There is joint space reduction. So this image, the one on the bottom left, so that image is the medial joint compartment, which has significant erosion. The lateral side has good cartilage, and over the coronal images, if we see, she has a extruded meniscus, which I was kind of expecting, but the root attachment was somewhat preserved. So the root attachment was stretched. She had a complex pattern tear in the medial meniscus. But this was something which was bothering me, is the mucoid degeneration of the ACL. And I guess this was the reason why she was having so much calf pain, because one of the consistent symptoms of having a mucinous degeneration is patients typically complain of having a lot of calf pain when they go to sleep or while standing. And through the various cuts, we could guess that the whole ACL was degenerated. These are the standing, this is the scanogram image. We have the measurements for you. So the deformity was mainly in the tibia. The JLC, the convergence angle was 5 degrees. On the right side, so right now I'm more focused with the right knee. This is the knee which was bothering the patient more. The posterior tibial slope on this one is 13 degrees. What options would you offer to this patient at this stage? 47-year-old female, more medial pain, night pain, and this is the MRI that you have. Pratik sir.
Sure. So we have significant medial compartment involvement as we see in the MRI, and ACL already showing changes with posterior slope of 13 degrees. So we have to, looking at all, think of joint preservation. And if we are going to preserve with the varus alignment, we would go to an osteotomy, thinking, doing arthroscopy, address the medial compartment, high tibial osteotomy, and at the same time correcting this 13 degrees as well. That will help the ACL, which we saw. Obviously, in arthroscopy, we'll address that also.
Okay. So I think, yes, this is a pretty standard discussion that we had for the previous cases. But my question to Jay sir is, what's your way of treating the mucinous degeneration? When you see a patient who's symptomatic, the whole ACL is degenerated, do you offer a complete resection? Do you do a partial resection? Do a ACL reconstruction? So how do you go about them?
In my experience, mucinous degeneration of the ACL, when you are resecting, if you keep it little of mucinous degenerated tissue, it will be painful throughout the, even though you have to take out the entire thing. So entire thing to the bottom, to the top and bottom. So that is a very important thing. Here is 13 degrees around towards primary correction you have to do towards 15 degrees. That is the indication here. And MPTA is 82, definitely medial opening wedge osteotomy with the slope correction. ACL, I do mobilization of the meniscus to the center, and central anchor also I will put on the medial side. Even though it is not having a root repair, I will mobilize the meniscus, put an anchor, okay, take the meniscus inside the ACL, and the slope correction, and the medial opening wedge osteotomy.
Okay, so we have a very strong comment from Gopi sir, who was suggesting that if we have, and this has been my experience too, that in mucinous degeneration, if it's a complete ACL involvement, like doing little is burning your hands. So I have learned it the hard way. There were enough literature which talked about ACL debridement and doing a partial reconstruction, but it's a difficult assessment to make on table. And if you end up like preserving some of the meniscus, the ACL, you might end up having a patient who will continue bothering you with knee pain. So it's a good idea. I have had consistent good outcome with ACL reconstructions. Even if it's a housewife or a patient who's 47-year-old, you can do a small bundle. Don't try to get a 9 ACL on even a 7 will suffice just to take care of the instability. So what we totally agreed with Dr. Gopi was saying. We were planning for a HTO with slope correction. So we calculated, and the angle of correction that we needed was 11 degrees. We'd need an open wedge of 12 millimeters. And our target was to have the axis pass through the Fujisawa point. We wanted some extra correction because the medial side was bad. As he said, we were wanting to do arthroscopy first, get over with the meniscus, and then come back and do the HTO and finish off with the ACL reconstruction. So these are the images. As he said, that the patient has had a degenerated meniscus tear, which we took care of. The medial compartment was totally abernated. We can see that it's almost bone on bone. And I have had good experience with even these. Though the results are like most of them have 3 to 4 year follow-up, but these patients have been happy with the HTO in my hands. The lateral compartment was very good. The lateral meniscus was good. So 2 minutes, I'm done. So we took down the ACL. Finally, went ahead with the ACL reconstruction. So about the tibial slope, we were trying to be more oblique with the tibial tunnel placement so that we could avoid messing with the osteotomy. Once we had that, we started with the osteotomy. So after the osteotomy, you can see our ACL entry point on the tibia is approximately 5 millimeters above the osteotomy site. So we were able to manage that, went ahead, we put in a bone graft, and exactly what I was trying to show, that we got a significant slope correction. So there's a plate which has an option for correction of the slope, and it dials in 4 degrees of slope correction, and that was precisely what we wanted. The next image shows that we were able to put the plate, as IPS sir was saying, that you can cheat around with the plate, especially the Pudu plate. It's not a locking implant, so you can adjust the direction of the screws, and it's not so tedious actually doing a ACL with a Pudu plate. So this is the final picture that we got. Reasonable correction, perfect restoration of the anatomical axis to the Fujisawa point. 5 months, let's come straight to 5 months. She has a good run. As we started, she was having an extension lag of 5 degrees, and that was stemming from the posterior tibial slope. So the extra tibial slope was probably adding to the extension lag. Once we got that corrected, her range of motion is 0 to 130. She has no extension lag. She's already happy with the pain relief, wanting to get the left knee also done very soon. So the other knee is thankfully a straightforward HTO, but we are looking forward to it. Thank you.
Thank you, panelists and Dr. Ryan. Now we'll have some online session. So Dr. Raju Boisho will talk on the publication of Arthroscopy journal, Road to Success. He is also the editor of the Indian Arthroscopy Association. So we'll have his video. So Raju Boisho. Sudip Boiddo na, Raju Boisho. This one.
Good morning. I am Raju Boisho. I am editor-in-chief of Orthopedics, Orthopedic Report, and Journal of Arthroscopic Surgery and Sports Medicine. I take this privilege to share my experience and give you some tips about how to publish in the field of arthroscopy and sports medicine based on my experience. I am associated with several journals and hence I am in a position to give you some tips and tricks how to publish in the field of arthroscopy. The first and foremost important question that you should ask yourself: why should I publish? What should I publish? Which type of publications do I need to do? And how to publish and where to publish? All these are very important once you go into the research and publication field. Why you should research? Because we are all clinical surgeons who see patients, operate and do different procedures, but it is our duty to analyze what we do and then report these for other people so that you become a clinical scientist. Research and publication helps you to break the monotony of your profession by repeatedly seeing the patient, operating and doing the hospital jobs. And if you go into the field of research publication, not only it gives you satisfaction, but also it breaks this monotony. It is also useful to audit your work so that you know how you are progressing, what right things you are doing, what things are going wrong and how we can improve. It also helps you in building your career, especially for young people. If you have done any publication, it may give you better job opportunities and career enhancement. It also helps you to develop analytical power, not only in the field of research publication, but also in the field of your clinical work, and then you can provide better solutions to your patients. The prerequisite steps for research publication include, first and foremost, you should have a will and wish to do it. You must also have passion to do it. You need to put a lot of effort in conducting research and then getting it published. And hence perseverance is important aspect if you are into the field of publication. Since these activities require time, you need to manage your clinical work, and hence time management is important. You should give adequate time to both these fields, and you should have a good teamwork to support you. And some people have developed the art of multitasking, where they can do both clinical and academic work equally well, and you must learn to develop this special feature. There are some research tips. First and foremost is that you should have a temper and attitude to do research. You should set goals, big goals, by taking small steps. And everybody has to take a small step to reach to big goals. Don't be afraid of reaching to big goals by taking small steps. Start with adverse outcome analysis, and this is very useful. Suppose you're getting some problems or complications in one particular procedure that you are doing, it will be a good point to start your research and analyze why you are getting such problem and how to overcome it. And do not have the fear of rejection, because most big journals have very high rejection rate of more than 90%. So you are likely to be rejected, your work may be likely to be rejected initially, but once you learn the tips and tricks and follow the guidelines of your journal, you are likely to have higher acceptance rate in future. The most important thing in research and publication is you must be confident that I want to do it, and you must also feel that I can do it, and you must have the determination to say that I will do it. Once you have all these three components, you can surely do a lot of research and publication and have good name in your academic field. In your research team, you should have thinkers, you should have doers, you should have people who can audit your work. You should also have statisticians and people who are computer friendly or computer wizard, because all these things require different skills, and all these are required for good research and publication. It is often said that publish and or perish in academic field. If you do not publish, you will perish. But I would say that if you publish, you can also prosper in your academic career. Writing a scientific article is one of the major and final product of all research and scientists, and hence if you do any research and it is not published, it has no meaning. So try to publish your research to a good journal as far as possible, because the highest value of any research is reached when it is published and it becomes a world fund of knowledge for the rest of your career. But often research is repulsive because most people hate it or do not like it. But I can tell you, if you have done research and if you have published a few papers, then publication becomes addictive for most people. There are more advantages of publication. It not only gives you personal pleasure and sense of satisfaction or achievement, but also provides an additional line to your CV, which is a very important thing for the juniors to enhance in their career. It also helps you to share ideas and results with your colleague, and that becomes a permanent record in the world of literature. It helps you to get your name out in that field and build your academic reputation, and it's an overall important career step for you. But there are several barriers to publishing. Most people think it's not my cup of tea because of their fixed mindset. They feel that they are short of time. There may be language and communication related barriers. And there are several types of research that can be done. As you can see on this pyramid, the type of research on the top of this pyramid are the ones which have higher recognition because they have higher level of evidence, but they are difficult to do to start with. And hence you can start with simple case reports, case control studies, and so on, and gradually move up in your career as you get the idea of research and publication. There are several dedicated journals which takes arthroscopy and sports medicine related articles, and you should try to submit your work in these journals related to arthroscopy. These are British Journal of Sports Medicine, American Journal of Sports Medicine, and these are listed as per their reputation and impact factor. There are various type of publications that you can do, like writing a scientific paper of different types, as I have already mentioned before. You can write a chapter in a book. You can also author a book either as a single author or as an editor. You can also publish video atlas of arthroscopic procedure. So think about it and keep collecting your material. Try to publish it and share it with your colleagues in these ways. I tell you my example, I have published more than 50 articles related to arthroscopy and sports medicine. Just give you an example of, let's say, knee. So I have published on ACL, PCL, meniscus, cartilage, sports medicine, and bibliometric studies. This will give you an idea what type of publications you can give, you can do. These are some of my publications related to ACL and PCL, and you can see this comprises of original research, review articles, case report, a letter to editor, and so on. Similarly, on meniscus and cartilage injuries, we have published various types of articles which you can also do. Then another area which is very important is bibliometric studies, where you analyze the published literature on a specific topic, like trends of publication in ACL over last 40 years. This was published in OJSM, publication trends of PCL on PubMed, published in JCOT, trends of arthroscopy publications, and so on. It is important to know what type of publications that editors usually consider for publication. That articles should be novel, should have a clear, useful, and exciting message. It should be presented and constructed in a logical manner. It should be easily grasped by reviewers and editors, because nobody has time to go into the nitty-gritty or complex writing of an article. It should also be practice-changing, novel, and maybe a very hot topic or current topic. So consider these important points when you are submitting your research to a journal. There are several pitfalls related to publication and research, because it takes time, but I can tell you it gets easier with practice. First few publications may be very time consuming and challenging, but as you grow in your career, it will become easy. So don't wait any longer and start writing your paper that is in your mind now. Thank you for your kind attention.
Yeah. Thank you. Thank you, Raju sir. Excellent talk. So any question? Yes, Gautam wants to ask one question. Gautam, please. Yes, Gautam.
Sir, as I'm a
Please talk.
এটা দাও প্রেজেন্টেশনটা দাও
Sound.
During the same time in 1970s, Haygroves published his work on ACL reconstruction. Later that year, Palmer popularized open primary ACL repair, and that became the most popular performed procedure in 1980s. But Fiagan and Curl were the first to note that deterioration of result at midterm follow-up in 1976. So why this paradigm shift happened? In early 1990s, several randomized controlled trials were performed showing superior result of reconstruction. Let's look at the evolution of primary ACL repair through the prism of modern day understanding. The turning point happened when Sherman in 1991 understood and re-looked at the result of primary ACL repair, and he divided ACL tear into 4 subgroups. Type 1, which is proximal tear less than 30% separation. Type 2, more than 30% separation. Type 3, mixed substance. And type 4, from the tibial sided avulsion. And he found that type 1 and type 2 tear have the best result. Through the literature in 1980s to 90, the results showed in mid substance to be the worst and higher failure rate. But during the same time, other studies by Kone, Janelin, and Ronest showed much better and satisfactory results in proximal tear. Janelin found that in 42 patient proximal tear at 5 to 7 year follow-up, 86% of patients were satisfied. So what were the factors that played a role in this paradigm shift from a repair toward reconstruction? During the early 80s and 90s, Google and Embase were not as much popularized and easy to use for orthopedic surgeons. The language barrier was another concern. Majority of the literature was written in a foreign language. Arthroscopic companies were focusing more on developing equipment to support reconstruction rather than repair. And as we know that the repair was done openly, it was not popular among surgeons. But before this, one should know that has ACL the potential to heal? The healing potential of ACL tissue has been read and studied by Sonnery, Cotet, and Murray. In their study, they took the samples and looked at the histological and cellular evaluation. And they found that the ruptured end of the ACL has got well-vascularized synovial tissue, numerous fibroblasts, and myofibroblast and mechanoreceptor. Along with our histopathologist colleague, 20 damaged samples and 6 normal samples. We use CD34 immunohistochemical staining, which expresses cell surface marker, and we also identified fibroblast. We used hematoxylin and eosin staining, and when we compared the cellular characteristic in total of 52 biopsy samples between a healthy and torn, partial and complete ACL tear, we identified that in a torn ACL there was a significant higher values in synovial angiogenesis, ligament angiogenesis, and fibrocytes. But the most exciting part of the study was time-specific response, that the remnant angiogenic potential significantly decrease 1 year after the injury. So either you intervene early to preserve the stump or repair. Our study was published in the Knee Journal, and we also presented during the ICRS. So what's happening now that we are back to the future and primary ACL repair is becoming more popular? There are various options to do primary ACL repair: suture anchor repair, bridge enhanced ACL repair, internal bracing, and dynamic intra-ligament stabilization. We do not have huge amount of literature so far, but we are seeing interest toward publishing more and more work on primary ACL repair in the last 2 years. My inspiration came from Gregor de Phillis, a dear friend who has published most of the work on primary ACL repair using suture anchor and internal brace. In his technique, he uses 2 swivel lock plus an internal brace to repair his primary ACL repair. Bridge enhanced ACL repair was published by Murray and studied, in which you take a sponge of a scaffold attached to the torn end of the ACL, take a patient blood, infiltrate into it, and in the trial which was done in 2016 of 10 selected patients, in 2019 the published result of 2 years showed similar outcome to ACL reconstruction. Internal brace was developed by Gordon McKay from Scotland, in which the concept of an internal brace is exactly like a seat belt. You repair the ACL, and like a seat belt, it will prevent the graft from rupturing. A 68 patient case series at 1 year follow-up showed 1% failure and 4% revision. Dynamic intraligament stabilization has been studied the most. The largest case series on humans, over 300 patients, has shown much higher failure rate at 5 years follow-up. The intraligament stabilization fixes on the proximal part with endo button and dynamic stabilizer onto the tibial side. But the issue is that you have to remove the screw 6 months following surgery. So the patient potentially needs to undergo 2 surgeries. When I developed my technique of primary ACL repair, my concern were drilling the tunnels, removal of hardware, ease of during surgery, and cost. So I decided to use a single anchor, focus mostly on type 1 and 2 tear, no tunnels, and easy to revise. And that was my approach. So my indication was type 1 and type 2 tear, age over 25, because I feel they do much better than a younger age. Clinical exam plus MRI scan, arthroscopic exam to proceed. Good tissue quality to hold the sutures, and in grade 2-3 cartilage damage and multi-ligament, we excluded our patient. So I will quickly take you through the procedure, how we do our primary ACL repair. MRI scan is showing proximal tear. And as you can see, rest of the ligament is still attached. With the help of arthroscope, I use 3-portal technique, anteromedial, anterolateral, and the central port. The central port is important not only for visualization but also for suture management. Examine the ACL tissue, and then basic instrumentation is used: suture cutter, suture passer, drill bit, drill guide, suture manipulator, and suture. I only use 2 suture. With the first suture, which is the locking stitch, you hold the tissue, and the running stitch is the second suture. It's very important to be very careful not to take the suture alongside the BCL, so you have to rotate your arm or use a probe to bring the loop or the Bunnell stitch more proximal as possible, close to the footprint. Once all sutures are done, with the help of the drill guide exactly at the position of the footprint, you drill and then use your anchor. I use relax anchor that can accommodate 4 ends of the suture. It's technically easy to use. And once all 4 ends of the sutures are deployed, you insert the anchor into the area of the drill part of the anchor and then tension it so that there isn't any slack. And finally, you can insert the anchor up to the black dotted line. You remove the white end of the sutures and you do the tensioning effect to allow, if there is any minimum slack, to be removed. Once that is done, the anchor is removed. Nice and stable graft. You can feed it with the probe, as you can see. Looks nice and stable. Cut the suture end, take the knee through range of movement. Perform microfracture to allow pleuropotential cell to fall onto the graft. And with the 3-portal technique, the ACL primary repair has been done. 24 months follow-up is showing nice position of the anchor with completely healed ACL tissue, and clinical examination is showing stable graft. We have done so far 52 patients, no failure, no revision at almost 2 years follow-up. We are following them with IKDC and Tegner score. MRI scan is done at 6 months, and we will be running our first randomized control trial by end of this year. You can also consider repairing type 4 tear, which I have done in quite a few cases with successful result, but if it is done acutely and in a very young age rather than chronic cases. So in conclusion, the way we preserve the nature, we should save the ACL. And thank you very much.
Thank you, Umar, and thank you for this fantastic talk. Always exciting to hear from you, and I hope you're doing well.
Thank you very much.
Any questions? Yes, there is one question from our secretary, Dr. Sundarajan from Coimbatore. He has one question for you.
No, congratulations for your study too, because you have shown 52 cases and no failure, and that is a 100% success, because a lot of literature shows that even type 1 and 2 around 10% failure. And so what is your take on that, tips and tricks to avoid that 10% failure? Yeah, I got it. Thank you.
Okay, Umar, thank you so much, and hope to see you soon. Right? Bye. See you. Cheers, mate. Bye.
Thank you, Umar, for being with us. I think next talk, Sachin sir.
Yeah. We'd like to next call upon Dr. Swan Kumar from Colombo,
Sri Lanka.
in Sri Lanka. Dr. Swan Kumar is the current president of the Sri Lankan Orthopedic Association.
Yes.
And it's a great pleasure to hear from you. He'll be speaking on double bundle, double tunnel, looped anatomical ACL reconstruction. So Dr. Swan Kumar, the screen is all yours to share, and nice to virtually meet you.
Good evening, and first I would like to thank our organizing committee for giving me this opportunity for sharing my thoughts in double bundle procedure in orthopedic practice. And ACL reconstruction surgery has walked a long road from open surgery in the middle of the night to a delicate elective arthroscopic maneuver with two bundle reconstruction. That's the update I want to talk to you. As far as the ACL is concerned, it has two bundles, AM and PL bundles. In my view, when we reconstruct both in the anatomical position, the patient has a better outcome and good recovery with good function of this. For this, we must know the anatomy perfectly. Both tibial and femoral footprints, we must know exactly where it is. So femoral footprint is just posterior to the resident ridge, where PL and AM bundles are attached. In the tibial side, the ACL has a long attachment as a footprint, PL and AM bundles as separately. So here we make our tunnels. In contrast to the single bundle, we have to make the tunnels exactly in this position of PL and AM bundle when we are reconstructing this anatomical position. So why anatomical double bundle is considered? There are some literature support. Single bundle technique has no better clinical result than double bundle technique. In another meta-analysis, it is shown that double bundle reconstruction leads to a better restoration of knee laxity and subjective outcome than single bundle ACL reconstruction. Double bundle technique has few degenerative rechanges proven radiologically than the single bundle technique. Another advantage is using femoral independent drilling techniques. The surgeons prefer this procedure. Almost 68% of these surgeons, they prefer this. This is not a new technique. It was published in JBJ since 1975 as a star operation using semitendinosus anatomical reconstruction. So in my practice, I use the same way of doing arthroscopic procedure for other procedures. The patient is positioned with a C-clamp and it should allow adequate flexion of more than 120 degrees, and other leg is supported with another stool. And in our setup in government sector, because of cost involved, we don't use arthroscopic drapes, we use our conventional drapes. And as far as the portals are involved, 2 routine arthroscopic portals are made to do this reconstruction. The special instrument what I need is the femoral re-entry jig that is used for femoral tunnel preparation from outside-in technique, suture passer, tibial jig, cannulated drill bit in the size of 5.5 or 6 millimeter, and there are suture passers and suture materials. So once we use this arthroscopic technique, we use arthroscopy first to confirm the diagnosis, and I would like to stress here for the trainees, sometimes this piece ACL, when it is detached from the femoral side, it is fused with a PCL, giving a wrong information or impression that ACL is intact. So you have to probe it and see whether it is laxed, and you have to make sure that, and you can see there is no attachment in the femoral attachment of this ACL. So this is the way I make the incision. It's an oblique incision. I make over the attachment of this semitendinosus and gracilis, and routine exposure of this tendon, and it is harvested using open tendon stripper, where I have to stress here, we are not going to detach it from the tibial attachment. Both these tendons are attached to the tibia. In other normal techniques, we take this graft and give it to our assistant. They prepare the graft and they give it to us. During the time, we do our arthroscopic procedures, making the tunnels and shaving and everything. But here I have to do this preparation myself, so it takes another additional 10 to 15 minutes for preparation of this both grafts. So here I use scalpel and scissors to remove the muscles and fibers from the graft, and then tubularization with 2-0 Icrs and braided of coarse sutures with number 2 Icrs is used for preparation, and then we have 2 grafts ready for. Next step, I go in the lateral aspect of this distal femur, where the incision is made along the posterior border of the femur. Splitting the IT band, we approach just above the supracondyle area, where the distal femur attached to the condyles. This area is prepared subperiosteally, and making the approach or exposure to the joint from the posterior part of the capsule. And this femoral jig is passed from outside in, and it is positioned exactly in this PL bundle position, just posterior to the resident ridge, and tunnel is made after using the guide wire, and drilling is done with 5.5 or 6 millimeter drill. And this decortication is done for accommodating the graft around the femoral condyle, and then tibial tunnel is made using first for PL bundle I use 55 degrees, and AM bundle I use 65 angle, and this is the exact position of this AM and PL bundle guide wires. And then drilling is made. After that we pass the suture passer from the tunnel made in the tibia for PL bundle, and it reaches the femoral tunnel. This is the suture passer between the femur and tibia for the PL bundle. So then we pass this number 2 Icrs and take the graft through the PL bundle and femoral condyle tunnel. And again we pass the suture passer through the AM bundle tunnel in the tibia, and it reaches the intercondylar notch, and posteriorly it is taken up, and graft is passed around the femoral condyle as a loop. And at the end, this is the position of the graft, and it is attached to the tibia using 4.5 millimeter cortical screw and a spike washer, and it is tightened in the position of 45 degrees of knee bending for achieving the neutral position in both flexion and extension. At the end, this is the position of the graft for representing AM and PL bundles and looping around the condyles. And this is one of my patients. He is a national player in the cricket team. He had an ACL injury while he was playing, and he was taken out of the ground, and he underwent surgery. And now after about 9 to 10 months now, he has started playing as normal team member in our team. These are the advantages. First, it is a cheaper technique. We use only a spike washer and a cortical screw. So it is very convenient in our setup, because our cost is our main factor in South Asian countries. And it is stable as far as the laxity is concerned. And I prefer for using revision surgeries, because femoral side attachment is very firm, and tunnel is not a problem in revision surgery. And there are no implants inside the joint or inside the tunnel. And thank you very much for listening.
Thank you so much, Dr. Swan Kumar, and thank you for attending this IS Saarc Congress. It would have been a pleasure actually to have you in person. We have a question. Dr. Prateek Gupta, our past president, would like to ask you a question.
Thank you, Dr. Swan Kumar. Very nice talk. I just wanted to find out this technique you said you've been doing for last many years. So comparing that, have we compared it to the usual technique of single bundle, and do you find it has any same results or better than those, because we have double bundle and has a better foothold, at least femur side? So what is your experience? Thank you so much, Dr. Swan Kumar. Nice meeting you and listening to you. Thank you so much for attending. Thanks. Thank you.
Yeah, good evening now. Dr. Shantiram Dhakal from National Hospital, Bhutan. This is Dr. Sachin Tapasvi here along with Dr. Pratik Gupta and Dr. Sundarajan and Dr. Rajiv Raman. Thank you for joining and tuning in with us. And we'd like to hear your presentation on ACL reconstruction, a recent experience in Bhutan. So we all look forward to your presentation. The screen is all yours to share. Thank you so much.
Hello and good afternoon. Greetings from Bhutan to all the esteemed members in this forum. I am Sanjiram Dhakal, orthopedic surgeon at Jimmy Doji Wangshu National Referral Hospital in Thimphu. I am honored to be given this opportunity to speak in this forum, so thank you. Instead of making a formal presentation on ACL reconstruction, please allow me to tell you a story about ACL reconstruction in Bhutan. As strange as it may sound, it's a recent experience for us because it was not before about 3 years ago that people here saw ACL reconstruction in the country. As you all know, that we are a tiny kingdom located between two giants, but because we have a brotherly Indian hand on our shoulder, we feel less intimidated. We are a population of about 700,000 people. I think that's roughly about the number of COVID-related deaths in India in the last 2 years. We are a relatively new country to the world, and we are slow, but we are learning. I say we are slow because after years of internal conflict and fights, the first king of Bhutan had just ascended the throne when the first open ACL reconstruction was performed in 1916, and 3 years later, an arthroscopic examination of joint was performed in Tokyo. In 1962, when the first arthroscopic meniscectomy was performed in Japan, Bhutan was just starting to open its door to the outside world. When in 1980, somewhere in the world, the first arthroscopic-assisted intra-articular ACL reconstruction was performed, Bhutan's first national airline was established and people started flying in and out of the country in aeroplane. In early 2000, when the world started debating on double versus single bundle ACL reconstruction, national television had just been introduced in Bhutan in the year 1999. Year 1999 was particularly important to us because that year we got our first orthopedic surgeon in Bhutan. Dr. Tsoang completed his residency program in Bangkok. Hence, the Department of Orthopedic Surgery was formally established in Bhutan that year. There are no private hospitals or private treatment clinics in Bhutan. It is not allowed by law. All health cost is borne by the government in government hospitals. For that purpose, the country is divided into 3 regions with the regional referral hospitals each. Cases that cannot be managed in the district hospitals are referred to the regional referral hospitals. More complicated cases are then referred to National Referral Hospital in Thimphu. Cases that cannot be managed there are referred to specialty hospitals across India, all free of cost to the patient, including travel, stay, and hospital expenses, etc. We provide free treatment. In orthopedics, trauma and infections were always the priority till recent years. Most meniscal and cruciate injuries most probably were treated by local quacks. Those who were diagnosed in hospitals were given conservative treatment. So it was not until 2009 when Dr. Sonam Dorji, the pioneer of arthroscopic surgery in Bhutan, came back from Bangkok after completing his fellowship that arthroscopic surgery started taking better form in Bhutan. The arthroscopic set was understandably highly underutilized since only 2 orthopedic surgeons, Dr. Sonam and Dr. Tsewang, manned the entire country at that time. Dr. Sonam started referring selected cruciate injuries to India for reconstruction. Dr. Sonam Dorji is retired and is on contract service at JTW Hospital now. On Dr. Sonam's invitation, Dr. Rajiv Raman came to Bhutan with his team on his own expense through his goodwill and performed 27 ACL reconstructions for free during 3 ACL camps in 2018 and 2019. That was the time I met Dr. Rajiv sir and assisted him in his surgeries. I was inspired by his work and I went for a 6-month fellowship in arthroscopic surgery the following year. After completion of my fellowship in arthroscopic surgery at the Medical College of Wisconsin, when I came back in the January of 2020, COVID-19 also followed me in Bhutan. Lots of restrictions, sealed borders, numerous lockdowns followed. We just could not put things on gear. I spent that time practicing my skill on model knee, which a volunteer orthopedic surgeon, Dr. Sam from the US, had donated a few years ago. It took us a full year to move forward with ACL surgery. March 24th, 2021 was a big day for us because we were about to do the first ever arthroscopic ACL reconstruction by all Bhutanese team in the country. We started the surgery around 10:30 a.m. and completed the surgery around 2:30 p.m., a whopping 4-hour surgery. Of course, I saw stars that day. We faced a lot of issues, most important being the inexperience of the team as a whole. Fortunately, 2 of our orthopedic technicians had assisted Dr. Rajiv during ACL camps. They were assets, and thankfully Dr. Sonam could also join us later. I learned many things that day, those things I did not learn during my entire fellowship. We had to release the tourniquet twice during the surgery. There was intra-articular bleeding impeding clear vision, the graft wouldn't pull through the tunnels easily, the pull-out graft suture snapped with endo button stuck in the femoral tunnel, and so on and so forth. But we completed the surgery, and at the end of it all, the graft size, position and fixation was satisfactory, I would say. It was not a surprise that the patient developed tourniquet pain and paresthesia of the involved leg, which improved after 1 week. We discharged him on day 10 post-operative after suture removal. I saw him 1 week later in the OPD and never since. He called me up 2 months ago. He said he wanted to see me. He is a policeman. Hopefully the officer is not coming to arrest me. But we have had lockdown ever since in our country, so he could not come. It has been exactly 1 year since the first case, and with numerous lockdowns and routine hospital services being affected, we could do 20 ACL reconstructions in approximately 9 months now, since then. We decreased the average surgical time to roughly 1 hour 45 minutes, and we don't keep them in the ward for 10 days anymore. Fortunately, we have had no SSIs till now, and I'm working on a clinical report after 1 year of ACL reconstruction in Bhutan. Well, that was the story. Now, let me quickly take you all through the technique we have adapted here in Bhutan for ACL reconstruction. Not surprisingly, almost all of our patients give a history of Bhutan football injury. After clinical examination and X-ray, MRI scan is done. We have only one MRI machine in the country. The waiting time for MRI therefore ranges from 2 to 6 weeks, sometimes even longer. And when the machine breaks down, which happens, there is chaos. We have one Storz arthroscopy set, which is 18-year-old. It gives glitches here and there, but we manage. We just hope it does not break down during surgery, so I always start my arthroscopic procedure with a little prayer in my mind. We sterilize the camera, cable, scopes and shaver in Cydex solution for a minimum of 20 minutes, and the rest of the instruments are steam sterilized. We use reusable linen drapes. We do all our procedures under spinal anesthesia and tourniquet, while our anesthetist friends do all theirs in the phone. I suppose that's a universal phenomenon. My preferred graft choice is quadrupled hamstring autograft harvested from ipsilateral thigh. If there's a specific indication for patella tendon graft, I send them to India for surgery at the moment. We don't have patella tendon graft harvest kit. Besides, I thought it would be best if we'd be well versed with hamstring graft technique before venturing into other techniques. Since I did not have a lot of hands-on practice during my 6 months of fellowship in the US, I'm being careful, choosing one step at a time. For femoral tunnel, I use transportal technique and try to locate the anatomic footprint. I drill the femoral tunnel with the help of a femoral offset guide. I aim for a low and posterior tunnel site. For tibial tunnel, I set the jig at 55 degrees and locate the anatomic footprint. Generally, a point at the junction between anterior 2/3 and posterior 1/3 is chosen. But I extend the knee fully to make sure that placing the tunnel at the chosen point is not likely to cause impingement of the graft later. I check once when placing the jig and also when the tip of the drill comes intra-articularly. I do not routinely do nosplasty. I use endo button and interference screw for graft fixation at 20 to 30 degrees of knee flexion with slight posterior draw force. Before fixing the graft, I put the knee through 20 to 30 cycles of flexion and extension to tension the graft, a technique I learned from Rajiv sir. Post-operatively, a simple knee brace is worn in full extension only during ambulation for 1 month, and weight bearing is allowed as tolerated with or without crutches depending on patient's comfort from post-op day 1. Active and active assisted knee range of motion is started on post-op day 1. Knee flexion beyond 90 degrees is allowed only after 1 month. Rehabilitation is continued with a general goal of achieving full range of motion by 2 to 3 months and return to sports by 9 to 12 months. We are fortunate not to have encountered any serious intraoperative and immediate post-operative complications till now, except for the first case, of course. I hope we won't see any major long-term complications as well in the future. We know that we have a much to learn and a long way to go. If the esteemed members here have any suggestions or directions for improvement, your feedback would be highly regarded in Bhutan. It will be interesting to see how we do in the next few years to a decade. We will not stop trying our best. Like I said, we are slow, but we are learning. I'd like to again express my deep gratitude for this opportunity. Thank you, Rajiv sir, and thank you all. Have a good evening.
Thank you, Shanti. Indeed, very inspirational, and I'm very sure that in years to come, we'd see more and more of such inspiring stories coming at your end, and I don't see the day, which is not going to be too far, when I think you'll be presenting your data, which is completely going to parallel data anywhere else in the world. So, congratulations, all the very best, and you can count upon all of us here sitting in this room. We're just a shout away, and you have Rajiv as an excellent friend. He's a great person, and he continues to inspire all of us with his energy and his enthusiasm. Lovely meeting you. Hope to see you in person very soon. Thank you so much.
Thank you.
Yeah. Everybody's open. Yeah. Yeah. Next, I'd like to call upon now in-person talks. We'd like to call upon Dr. Sudeep Vaidya, a very close friend from Bharatpur in Nepal. He's recently taken over the presidency of the Arthroscopy Society of Nepal. A very accomplished surgeon, a leader for orthopedics in his country. And Sudeep is going to speak to us today on cost-effective meniscus repair. Over to you, Sudeep.
Yeah. Thank you, Dr. Sachin. and you have taken care of us from each point. We are really happy about it. Thank you, Dr. Rajiv. And today's my topic will be little repetition of today's morning's presentation by Dr. Amit. But there are few points I have reasons to present this case once again. That is cost-effective meniscal repair method, sutured shuttle technique. It is my experience with this. So I will tell you why I am presenting this case again. This is none other than Dr. Amit Joshi and this team devised this technique in repair of longitudinal tear of medial meniscus, the sutured shuttle technique. Many times what we have seen is it works very well in the hands of the originator who publishes a case, but sometime over the time it does not work. So when any procedure has to be successful in the long run, it has to be reproducible, so it should work in all the hands, and it should have a predictable outcome. So now we know meniscal preservation is absolute need of the time, and finding the cost-effective method is today's challenge. I think today itself I could hear from so many a friend from Jharkhand, and actually Raju was talking that even Nepal, India, cost is a big factor whenever we are repairing meniscus. Particularly when we have to do all inside techniques, we really have to count even Nepal. And I'm sure in the most part of India, we have to, one suture is costing around 25 to 30,000. So if I have to use 3 to 4 sutures, I think majority of my patients will not able to afford it. So we have to find some solution to it in our continent. I come from a place called Chitwan. It's magnified view, and we are surrounded by 7 districts. So Chitwan is basically a developing medical city. It's around 140 kilometers from Kathmandu. It is also famous for Chitwan National Park, one horned rhino. It's only available in Asia. In India, it's available in Assam, and in Nepal, it's in Chitwan. It's, so next time, my friends, if you visit, you must visit Chitwan and be our guest. Nepal is known for its cultural heritage and pagoda-style temples, and it's known for its majestic Himalayas, that's Mount Everest. But life is not so simple as it looks in the photos. Life is quite difficult. And what we are talking today about the sports medicine, we are talking about so many technicalities, but this small girl, around maybe 18 years, Dr. IPS has visited, I think, most of the difficult part of Nepal than me, that if she tears medial meniscus or if any part of meniscus, it is not that simple that we can try to use all the technology. We have to have some solution in hand. So that is why I thought of presenting this, re-presenting the case. Some of the slides may be a little repetition. Please forgive me for that. But some of the techniques and some things I would like to add to that techniques and add my video to that. And another cause of presenting is like cost is issue not only in Nepal, I think Indians, most of the subcontinents. But I was a little surprised to know just now, Bhutan, everything is paid by the government. That was really news to me. It is like, it is not so in Nepal. And of course, I also know that in India also most of the major cities insurance coverage there, but I don't know about the interiors. But Nepal, 95% of the people are not covered with the insurance. So meniscus repair is still a very big challenge for us. So this slide is a little repetition. We have 3 methods of repairing: all inside technique, inside out, and outside in. I'll be talking more about outside in techniques, which the few things are already explained by Dr. Amit. Inside out technique, as you go on compressing, we have a problem that it opens in the inferior surface. In all inside techniques, when you compress, it opens from the lower side. So in that, Dr. Justin had described a technique that all circumferential techniques, but it was all inside repair techniques, and the instrument required for it was quite costly and not amenable to us. So circumferential he had applied to this. Yes, this is how it explained this. But the techniques we have used today Dr. Amit had devised, and why I wanted to present was whether it is reproducible or not. Even today morning, Amit presented, and many of us are trying to use this technique in Nepal. Many of us, my juniors, seniors, they are using, and it is given consistently, it is given a good result. So, and it all requires is the epidural needle and few suture materials. Initially, we used to use ethibond now, but that is a little thicker, this thing, so we have changed over to orthobond. So this is a little video with some animation. This suture turtle technique. This you have seen. Sorry for repeating this again. Suture pass from the superior surface of the meniscus. It is pulled out. Another suture is passed from the lower surface. This does not go through the meniscus. It is pulled out from the inferior surface and tied. This is a video presentation. This is a medial meniscus bucket handle tear. First of all, we have to identify the tear and extent of it. Pie crusting is very important because I think almost all cases of our medial meniscus we do pie crusting. It gives really good exposure. And remove all the unstable rims to make it fresh because there may be a lot of adhesions. And we use low suction shaver. Sometimes we don't use shaver at all. This is mainly to abrade the adhesions. That is followed by a diamond rasp. Usually inferior surface of the meniscus are quite vascular. It needs to be abraded very well. After that, we put a cannula into the medial portal and a scope into the lateral portal. Epidural needle is passed from the superior surface, taken inferiorly. Protein suture is passed from that. Sorry, I had a little edited because I thought the time slot is very short, so I had edited little videos. It's pulled out, tied with the orthobond sutures. Opening is running from the outside, and we open till the capsule. That is one of the very important technique to avoid any interference in any tissues in between the two sutures. Mosquitoes are used. And it is pulled out from the inferior to superior passage with little bit of thrust, and it goes very easily. Another bite is taken from the inferior surface of the meniscus. Same steps is repeated. Proline is retrieved outside and tied with the orthobond. Initially we used to use ethibond, but nowadays we are using orthobond. The ethibond is a little bigger sutures. It has its own complications. Now once it's pulled out, you can see how nicely it sits. And one of the very important part is we have to constantly use a probe so that there is no crushing of the. Once you are pulling the suture from the outside, use a probe to control the force of the suture. In a similar fashion, multiple sutures can be put at the distance of around 5 millimeter. And this is how it nicely sits outside. SMC knot is used tied from outside. And when you are tying the SMC knots from inside, always use a probe from inside so that there is no cutting through from the meniscus. This step is, I found it very important. And each sutures are tied from the different stab incision outside. This is how it is repaired. Thank you very much. And initially, our initial author had this thing, used this technique only for the longitudinal tear of the medial meniscus. We are trying to use it even for the lateral meniscus anterior to the this popliteal tendon. And some of our friends are using, even trying to use it in the posterior lateral corner. Let us say over the years, we might come out with these techniques. And it has its own disadvantage and disadvantage. Cost is a very, very important factor. It's low cost. Horizontal and vertical sutures are compatible, and it is most important, it's reproducible in most of our hand, and most of the longitudinal tear can be repaired. But it has its own setback, this thing, disadvantages. Pike restraint is almost always required, but that should not be a big issue. Orientation may not be vertical, particularly when you are repairing the posterior horn repair. Little large knots can be damaged. So these are the Saarc countries, and there are a few things we have common. We have similar mythology, similar culture and beliefs, similar food habits, and of course, similar problems. So with this, I would like to, of course, this will be coming later on. We are planning to have a Saarc arthroscopy meet with the ASON, and we want a big support from friends of IAS into 2023. We propose this, and if you are willing to extend your helping hand to us, I think we can really make it a big thing. And we just saw a few of our friends from Pakistan, Bhutan, Sri Lanka. I think we should try to call upon Maldives and so. And I think initially it was Dr. IAS had taken initiative, and we have all the big stalwarts of the IAS here. And if with your helping hand, we can definitely make it a big success. We are planning this. It was basically our national conference, but if you give us a support, we'll be able to make it a big success. So for success, we need to join hand. And this is our beautiful Darbar Square in Patan area of Kathmandu. Thank you very much.
Thank you, Sudeep. Any questions? Any question? Rajiv, any question? Yeah.
Mic to the.
Yeah.
What are your criteria when you think, yes, I will go for this meniscus repair in patients? What is it's a age, duration of injury, or sometime when you put your scope inside, you plan, yes, I will go for a balancing or a repair?
No, usually most of the time we get this kind of longitudinal repair, bucket handle longitudinal. That's most of the time they are associated with the ACL, and we have pre-operative diagnosis that we are most likely to get this kind of this thing. But yesterday itself, I think we saw Kanchan sir doing ACL and found a big bucket handle tear. Many times it is surprising to us also, because sometimes the MRI cuts are not adequate and we miss out on that. That is why I said our epidural needles, my wife is anesthetist, so she always have epidural with her. And few sutures are always there. And really too, if I am not planned, I don't have all inside sutures. And convincing my patient that I'll use all inside is 90%, it's difficult. So I'm sorry? Yeah, yeah. It's a different needle effort, definitely. That's right. Yeah. Thank you, Rajiv.
Thank you. Thank you so much. Next, we'd like to call upon Dr. Parvez Hassan from Bangladesh. And Dr. Parvez will be speaking to us on impingement of the shoulder. Dr. Parvez is the head of Department of Orthopedic Surgery at the Medical College in Dhaka. And all yours. Thank you.
Welcome to you all. Greetings from Bangladesh. First of all, injects cortisone injection, and nowadays it is very popular of PRP injection in the shoulder to reduce the impingement syndrome. The most popular is arthroscopic surgery, and the physical therapy both before the surgery and of course after the surgery is applied. I want to see some of the patients. We usually do subacromial decompression and acromioplasty, positioning of this patient in our setup of our hospital, giving the traction, 45-degree abduction and 30-degree forward flexion with laterally. This is some picture of how you give the portal, and there are anterolateral portal and posterolateral portal. You usually doing the subacromial decompression and acromioplasty. This is some arthroscopic views of the subacromial decompression and acromioplasty. So take-home message is history, proper history and proper physical examination and relevant investigation sort the cause of impingement. Medical treatment and physical therapy plays a vital role for improvement of the condition, but arthroscopic procedure is the treatment of choice for resistant and mechanical block-induced impingement. Thank you very much for patient hearing. Thank you very much.
Thank you. Thank you so much, Dr. Parvez. Yeah, Pratik, you had a question?
This subacromial impingement, you said, how often do you treat that non-operatively, and how often do you think you would want to go in and do decompression? So what's your...
So we criteria, every patient we try to treat in conservative way. We used to give NSAID, gives physiotherapy, but there are some resistance cases. After examination and after investigation, we found that it doesn't improve after giving cortisone or therapy. So that cases we select for subacromial decompression.
And pre-op MRI evaluation?
Yes, evaluation, proper evaluation.
Yes, Mukesh, you had a question? You wanted to ask a question? Achha, okay. Thank you so much, Dr.
Thank you very much.
Thank you very much. We now come to the last talk of today, and it gives us great pleasure to invite our current president of the Indian Arthroscopy Society, the ever dynamic, ever running, flying Sikh, Dr. IPS Oberoi, who has now taken a liking towards climbing chadna on mountains. So IPS or yours, and please let us know of all your endeavors as to what is beyond orthopedics and on the mountain.
I think thank you, Sachin. I think hobby is something which gives us energy. Beyond orthopedics, and it's just a 10 minutes presentation where I take through the things which give me a lot of interest, which is actually mountain climbing. And I think mountain climbing is something which is a passionate sport. It requires quite amount of fitness. I was introduced into health fitness by Anand Joshi, who is past president of Indian Arthroscopy Society, and we were in a conference in China 2008-2009. That was an Asian Arthroscopy Congress. By end of the meeting in the evening, we went to scale the Great Wall of China. And this guy, who is maybe 12 years senior to me, he ran and climbed the Great Wall of China to the area where they allow us to climb. And I was really panting hard because at age of 42, I was still unable to do that. And I thought, how this guy is going to do this? And then he gave me a lifelong lesson that you have to be really physically fit to enjoy the life, as well as this actually motivates you more into the passionate things which you want to do. So just a small presentation of my passions for mountains. I think mountain climbing is Mountain climbing actually started with a lot of climbs in Himalayas, and as rightly Sudeep was telling, and Ishwar knows about it, and a lot of my Nepalese friends know about it. I have been coming to Nepal for last so many years, trying to climb smaller peaks and bigger peaks. The first big thing which was actually an Everest base camp climb. Everest is a paradise on earth, and I think it takes 14 days for you to reach a base camp. You need to be physically fit. At the same time, you need to acclimatize to the altitude, because that's killing. And when we were climbing, we had a lot of climbers who had to be evacuated down because of altitude sickness. People underestimate their fitness, and mountains spare no one. Everest Base Camp actually started, this climb actually starts at Lukla. So you fly from Kathmandu to Lukla. It's a very, very dangerous airport. It's supposed to be the most dangerous airport because the runway is just 100 meters. And if your flight misses it, then you're in heaven. You're not on mountains. So going to Tenzing Hillary Airport itself is an adventure, and the climb actually starts from here. Nepal is close to us. I mean, it's historically so nice. You have stupas and you have wilderness all around, yaks, and there's such altitude. You really feel very, very close to the nature. The thin altitude, the thin air gives you a fresh breath of life. And I, coming from a city like Delhi, which is one of the most polluted cities in the world right now, I think going to an Everest base camp was a life-changing thing. And once you summit for 9 days, and when you reach the Everest base camp with your group, you really feel good. The temperatures are sub-minus, it's a snow all out, and you really feel like a man when you're standing in front of the Everest base camp. And I think that's something which is very, very inspirational. It changes the way you look into the life, and probably Nepal is one thing which has ever motivated me to do more and more climbing. Next climb which I did was Mount Kilimanjaro. Kilimanjaro is the highest mountain in Africa. It stands at around 19,340 feet, and it is supposed to be a difficult mountain to climb, especially if you're trying to climb the shortest route. The longer routes take 14 days. The shortest route is direct straight. It takes 6 days. Being an arthroscopy surgeon with a bit amount of practice, you can't spare 14 days again going to Africa. So I opted for the straight route. On the same day of climb, when you have to enter through the climbing area, you actually drive and fly to Kilimanjaro airport. So there's a small airport which is a Kilimanjaro airport, and this is an area where you actually enter to start climbing. They take all the entries, they check the bags which you are carrying and the food material you are carrying. From this route which we were climbing, I was the alone climber on that day, because they say this is one of the dangerous routes. 6 days you need to go high, acclimatize, and it's more like a vertical route. So better avoid this route and go for a longer route. But then I think when you're crazy, you start to do crazy things. I opted for the straight route. This was the guy who is a mountain guide with me, and he guides you through the climb. I think Kilimanjaro has a very, very nice flora and fauna. The amount of trees and vegetation which you are going to find in Kilimanjaro, you cannot find anywhere in the world. These are all primitive, ancient kind of trees. If you could see into some holy books, that such kind of trees are there, and you find it in Kilimanjaro. You start to climb. The problem in Kilimanjaro, you don't have water, so there are small water channels. You need to go and bring water and probably cook food for yourself. Sometimes you are lucky, you do have a cook which can go with you and he can cook food for you. But the food which you get is basically potatoes or fried pasta, and you need to survive on that. You need to camp yourself, and then in wilderness you just sleep there. Climbing, as you start climbing up, you reach to place where you can actually see the mighty Kilimanjaro right in front of you. You start from a tropical zone and then go to a subarctic zone, and finally you're into Arctic zone. So in the single 6 days, you are actually transitioning from a different vegetation every single day. So as you go in an arid zone, the vegetation actually changes, and you start to see these cacti coming up. And these are strange kind of cactus which you can see in the subarctic zone. The climb is more mountainous. It's called as a Branco wall. It's like a straight wall, and you are actually, again you sleep, you eat some potatoes, fried eat, and you take some tea bags and just survive on the tea bags, some pickle and maybe some fried potatoes in the night. The climb actually starts at 12 in the night, and you need to reach there in around 9 hours or so, because when the sun starts to rise and the water and the snow starts to melt, and high amount of avalanche starts to happen. So we start climbing at night at around 12. It's a 9 hours non-stop climb, and when you reach summit, it's all snow. The whole body is actually covered with snow and blizzard, and that's the picture. You see the amount of snow which is actually deposited over the whole body, and that's the backpack which is actually stuck to me with all snow. Your whole body weight actually increases by 8 to 10 kgs with the amount of snow which is you're carrying. We reached there by around 9:30 or so. That's me with my guide on the summit of Mount Kilimanjaro, and that's with the Indian flag there. And it's actually a manner of pride to be on Mount Kilimanjaro, the highest mountain of Africa. When you come back, they guys songs for you. Hakuna Matata means no problem. I mean, they think it's, and they are happy about it, and they sing their songs for you. Everybody is so happy. When I finished the Africa, I thought, let me go to Europe, and let me start climbing Europe and Asia. So highest mountain in Asia, which is actually not the geographical Asia, but the Asia per se continent, is Mount Elbrus. Mount Elbrus is 18,510 feet, but it is snow right from down. Unlike Mount Kilimanjaro, which is more rocky, this one is more snow right down. You fly to Moscow, to the airport Moscow, and then take a small connecting flight to another small airport, which is called Mineral Vody. And from Mineral Vody, you start climbing. We were 4 climbers. My age was 47, 48, and these other 3 climbers are 21. They are students from London School of Economics and young, fit guys. We started climbing, and again, it is a 6-day summit. You start climbing right from down. The problem here is that you can't do any kind of tenting. It's all snow. You can't sleep in a tent. During World War II, there were these oil chambers which were made, and the Russian Soviet army actually left these chambers, and they have been now converted into sleeping bunks. So all you can do is you can open that small window which they have made, go into the sleeping bunk, sleep there, and then start summiting in the morning again. It's a difficult summit because you don't get hot food. It's essentially a cold meat which you need to eat. It's very, very difficult to be in open air because air is thin and there are a lot of snow and blizzards. By 3rd day, there are these boxes which are there. They are something like coffin boxes. You need to go into the coffin box to sleep. You don't get tents to sleep, and it's not warm at all. The temperature outside is around minus 40 degrees or so. And the summit itself is around 12 hours of summit. Again, you start summiting at 12 in the night, and by around 11:30, you are on the summit. Unfortunate thing was that out of the 4 climbers, when we started summiting, by around 5:30 in the morning, 2 climbers became sick. And my co-guide had to actually bring them down because they started having nasal bleed and they started having vertigo. So what was left was my guide, my co-climber, and myself. We 3 were left. And as we were reaching more and more close to the summit, so we were actually maybe just an hour away from the summit, the climber which was with me also dazed off. He fainted, and now my guide said that, man, now we cannot summit it because if I leave him here, he's going to die. And I can't allow you to go up because it seems like clear weather and you are going to climb it. But the snow is so soft that we need to actually rope both of them together. I mean, both of you together. If I'm going to fall, you need to save me. If you fall, I need to save you. So you can't climb alone. It is a rope to rope we have to climb. So even after walking to around 11 hours in the night, we had to take this guy back down so that, and our summit was not possible that night. When I reached down, it was around 5:36 in the evening. And I asked my guide, can I attempt the summit again tonight? He says, nobody has done that before. And anyway, I have been walking for 16 hours, so I am tired. There is only one way to do it. You can request the co-guide. If he is fit enough, he can walk with you. But I would not advise you to do that kind of thing. I requested the co-guide, and he accepted some money, Russia, so you can give some money and get things done. So it costed 500 euros, but he agreed that we can walk back again tonight. Again, he said that it is up to you. If you think you are unable to climb because you already walked 16 hours in the day, if you are unable to do it, just let us know, we'll come back. We started again. Incidentally, the weather was better the next night, and me and my co-guide were able to actually climb. There was a huge amount of snow, again frost bites, but we were able to reach on the top. in around 11:30 in the morning, and again hosted the national flag there. So that indeed was, and when we came back, they threw a party actually. They said, we are going to throw a party because never has anybody attempted a summit for 2 days consecutively. And for an Indian to do that, we just can't believe it. Because it's usually American guys or Australian guys who are tough and they can do it. But for Indian guys, Sardar nahi dekha unhone. Russians nahi dekha tha. I thought then when we have done that, I think let us do some alpine climbing. I went to France and wanted to summit Mont Blanc. Mont Blanc is the highest alpine mountain. So though the height is 15,000 meters, it's much feet less than Everest Base Camp, less than Elbrus. But alpine climbing is different from the climbing which we do on flat areas. Alpine climbing is more like vertical climb, and it has got a lot of avalanches, and you actually walk on a ridge. And it's more dangerous. So even at a lower altitude, Mont Blanc climb is supposed to be much more difficult climb. So we start at Chamonix. Chamonix is a small village. It's a ski village close to Geneva. So you go to Geneva and then go to Chamonix. And from Chamonix you start climbing. And there are 2 huts which come in way, Refuge de Gour and Echo de Dilla. You can sleep in those huts. These are small huts. So initially the climb is a rocky climb. There are routes to climb it. But as you start going up, then it becomes more icy climb. In the way, there are small mementos which shows the climber which previously attempted and died. And they keep on putting these nameplates there just to scare you off. So if you think you don't want to do it, you can actually climb down. So we climbed 2 days and we reached this hut which is very near to the last summit attempt. When we entered the hut, there are flags of people who have actually summited Mont Blanc. I could find Argentinian flag, Chinese flag, American flag, but not an Indian flag. So that was quite surprising because I thought somebody would have done a Mont Blanc. I think they would have done, but there was no Indian flag there. So that's the night summit which we need to do it. Now, as I was telling you, unlike the other summits, you have to walk on this small ridge all the way up, and the guide is going to guide you on the ridge. The weather usually is very bad. It's very difficult to see what is happening in front. In the night, we actually start walking with a night headlight up. But as the sun starts to set in, then you start seeing easier way to climb. But these are small ridges when you climb, and there are high chance of avalanche to happen. So you and guide are actually roped to each other. You are walking very, very close to each other. And you can't walk away from him because if you fall down, he has to do it. Otherwise, you need to know the avalanche rescue yourself. You need to know how to arrest yourself. Otherwise, you go rolling down and you cannot be retrieved then. So we were walking hand to hand. And finally, after 11 hours of height, we were on the summit together. And again, an Indian flag there on Mont Blanc, which is the highest alpine mountain. And when coming back, that was the date when we summited Mont Blanc, and I put the Indian flag, which was never there, and followed by a nice Mont Blanc beer, which helped us renovate ourselves. Another alpine climb which I attempted was Matterhorn. I think Matterhorn is like a horn, and if you eat Toblerone chocolate, the picture on Toblerone chocolate is the Matterhorn. Matterhorn is the iconic mountain of Switzerland. It's at 14,692, but it's essentially a technical climb. You need effort, but you need all the technical skills like rappelling, rope climbing to climb Matterhorn. So this is how it is. You need crampons on your feet. You need ice axe in your hand. You have to rope yourself, the guide up. He puts a rope, then you rope up yourself, and you put ice screws and start climbing. It's a very, very hard climb because, again, as I said, the snow is a bit more soft, but it is more like a vertical climb. It takes 2 days. You actually start climbing in the afternoon. You reach at the night. You climb the whole night, and by morning you are in Matterhorn, on the top of Matterhorn. So this is summiting the Matterhorn, and if you look into it, it's got a rocky climb with a lot of ice there, and it was a difficult climb. After this, I have climbed 3 more mountains. I have not put those in the slides. That's the highest one in the Switzerland, which I climbed just a couple of months back. That is called Beaufort Spitz. And I have also climbed Elbrus from the north side. This one we did from the south side. I have done from the north side. North side takes 9 days, and it's much more difficult climb to happen. But again, preparation is a big game, I think. We cannot be fit on mountains. You have to be fit in gym or in home or in places. So I train myself quite a lot in gym. These are only mainly CrossFits where you can do reverse crunches, which will help you, rope climbing, which helps you in actually getting a lot of power in your hand. And these are very, very important because when you do all these climbing activities, your upper limbs should be actually strong enough to hold your body. I do a lot of reverse crunches, a lot of box jumps, because you really need your legs to be enough. They don't get tired because you need to walk between 12 hours to 16 hours non-stop. And sometimes you're starving, you don't eat anything because in mountains, you take the water bottle, it's like an ice. You take a bread out, it's like a loaf of ice. You have to break it and eat it. There is absolutely no way that you can actually break the winter. And then doing a lot of flexibility exercises like pulling yourself up on a rope, and then flexible exercises for hip, because as an orthopedic surgeon and sports medicine surgeons, we realize that the more flexible you are on your joints, the better it is that you don't get tired. So a lot of these rehabilitation exercises, physiotherapy, which we do ourselves, we know about it, help us in actually overcoming the muscle strains. I train myself a lot in parks also, doing a lot of hanging activities because you need rope climbing. And I also do a lot of tree climbing, because it's also helpful to do a lot of upper limb and lower limb strengthening. I think it's important whenever you do these activities, you need to be trained properly also. So I have done a rock climbing course in Spain. They teach you all kind of rock climbing on dry rocks. I know how to do ski. I have done a lot of skiing courses. I've done downhill ski, uphill ski, touring courses. And I've also done a lot of ice climbing courses and avalanche rescues. You can't go into mountains when you are married, when you have kids, without actually guaranteeing that you will come back home safe. Your wife will never send you on the mountain like that. So to do all these things, you really need to learn the tricks of the trade. And finally, you should not be afraid of heights. And that's again Nepal. That's a bungee jump from the last resort into river Bhaktkoshi, or is it Dudkoshi? Dudkoshi. So you jump into the river, that's a bungee jump. You have to overcome the heights as far as possible. And they take you on to the bridge, and 1, 2, and 3, and you do go down. Yeah, it's a bit scary, but every year I go to Nepal, I do a bungee jump just to overcome that kind of fear of height and falling down from mountains whenever it does that happen. So friends, I do got motivated from my mentor, Anand Joshi. My talk was just to motivate all of you so that we can together maybe motivate each other. Thank you very much.
Thank you, IPS. After this talk, there are no questions. Okay?
No. Next year, Sachin has to say which mount he climbed.
Earlier, Sachin sir has proved that no question.
I'd like to invite our Organizing Secretary, Dr. Sunit Hajira, to be here. Please, Sunita.
Thank you, Rajiv. I think after a very exhaustive scientific session throughout the day, I would like to keep this inauguration session really short, because only few of us had the opportunity to sit on the can. Majority of us are still craving for it. So I would like to invite the President of the Indian Arthroscopy Society, Dr. IPS Oberoi, to please come on the dais, please. So I would also like to, Okay. So I would like to invite the Indian Arthroscopy Society Secretary, Dr. Sundar sir, please come on the dais as well. The Vice President of the Indian Arthroscopy Society, Dr. Sachin sir. Sachin sir is still going back, I think. His voice coming. So I would like to also invite Dr. Sudip Vaidya sir, and the President of the Assam, Nepal. I would also like to invite Dr. Parvez Hassan as a representative of Bangladesh Orthopedic Society. And and also the President of the Calcutta Orthopedic Society, Dr. Kanchan Bhattacharya sir. Please come on the dais, sir. Dr. Chandra, Secretary of the Asans, I would like to invite him as well. So, I think we'll start with some welcome address by after Kolkata Arthroscopy Sports Society, Dr. Kanchan Bhattacharya sir. So, I would like to request him to give him the welcome address, sir.
This is a privilege and a pleasure to welcome all the delegates here for the first Saarc Sports Meet with IAS. We have a plethora of guests, some virtual, and I think this is the best of two worlds as we move forward to the new normal. And I hope you are enjoying it as much as I am, and tomorrow promises to be just as good. I welcome all of you again and thank you for coming.
Yeah, and now we will go for the welcome notes sent by on video from our various SAP representatives. So may I request to play the video.
Hi and greetings from Kabul, Afghanistan. I am Dr. Imal Vardak, head of Department of Orthopedics.
Sorry, I think there is some problem with the video.
Hospital, and immediate past president of Orthopedic Association of Saarc countries. Proud member of IAS, and I'm very glad to know that the Indian Arthroscopic Society is organizing the most wonderful sports Saarc conference in the beautiful city of Kolkata, which I had the pleasure to be there when it was IOACon there. I was having fond memories of the hospitality and the people, the food from there. I would like to welcome all the faculty and delegates from all around the Saarc region and abroad, and the local, of course, faculty and delegates, and I would like to congratulate the organizing team, especially Dr. Raman, Rajiv Raman, for being such a nice, fine organizer. And I am sure that this academic feast will be joyful. Hi and greetings from.
Stop. Next. Go to the online thank
you
for your kind.
So now I will like to play the video by Dr. Sonam Jarji from Bhutan.
Good day to all. It's from the Saarc countries. I am Dr. Sonam Dorji, bringing greetings from the Kingdom of Bhutan to all the participants at the first IAS Saarc Sportsmedcon 2022. At the onset, I'd like to convey my sincere gratitude and thanks to the Indian Arthroscopic Society for inviting me to participate at this very prestigious scientific meet. Of late, Bhutan has been experiencing a surge in COVID cases, and we have been under lockdown for about 2 months. We have started opening up slowly, but our cases are far from under control. Therefore, I like to convey my deep regrets for not being able to participate in the conference in person. I have fond memories of attending the IAS Sportsmedcon 2016 in the City of Joy in the year 2016, during which I had the great opportunity of meeting some of the big names in the field of sports medicine. In Bhutan, our sports medicine is still in its infant stage. It is only towards the mid of 2018 that we wanted to move ahead, and therefore we plan to conduct arthroscopic sports surgery camps, and in collaboration with Dr. Rajiv Raman, we managed to conduct 3 such arthroscopic surgery camps by the end of 2019. We had also planned to conduct sports medicine conference in Bhutan towards the end of 2020. Unfortunately, because of the COVID pandemic, everything got derailed. We hope someday, with the COVID gone, we'll be able to do it in the future. Lastly, I'd like to send my best wishes to all the participants there. Thank you and Tashidale.
Yeah, I think now the message by the Dr. V. Saranakumar from Sri Lanka, President of the Sri Lankan Orthopedic Association.
Good day to all members and distinguished delegates from Saarc countries. I am Dr. Velayutham Swarnakumar from Sri Lanka. It's my pleasure in participating in this prestigious conference, first IAS Saarc Sportsmedcon. I bring you warm wishes from the country called as Pearl in Indian Ocean, that is Sri Lanka. First, I would like to thank organizing committee, especially Dr. Rajiv Raman, for inviting me and giving me this great opportunity to be as part of your faculty in order to share my experience in this historical conference. I could not participate physically, partly due to these COVID restrictions and also partly due to my personal agenda. I am really missing meeting many prominent figures in sports medicine and arthroscopy. I can recall the day when I contributed as a faculty in a Zoom meeting platform during the period of pandemic in 2020. The sports medicine practice in Sri Lanka and an arthroscopic surgery has been widely performed in. Good day to all members and distinguished delegates.
Orthopedic Association of Saarc and the past presently President of Bangladesh Orthopedic Association, Dr. Abdul Ghani Mullah.
Good day, all the distinguished delegates from the Saarc countries. I am the President of the Orthopedic Society, Director Nico, welcoming all of you at the first IAS Saarc Sportsmedcon 2022. From the very beginning, I would like to convey my best gratitude from the core of my heart for inviting me in this prestigious scientific meeting by the renowned arthroscopic surgeons are attending. Today is the memorable day for our country. It is 26 March, 51st Independence Day of the People's Republic of Bangladesh. I remember our great leader, father of the nation, Bangabandhu Sheikh Mujibur Rahman, and 3 million of people who sacrificed their lives in the liberation war in 1971. I convey my gratitude to the entire participants in this very special day. We have passed critical situation for last 2 years due to COVID pandemic. Now the pandemic situation is under control. Last week, we the Bangladesh Orthopedic Society conducted our annual scientific congress, Boston 2022. successfully. Hopefully, in coming future, we all can participate in this prestigious conference physically and enrich our knowledge and skill. I wish you all the best. Thank you very much.
Thank you, sir.
And distinguished delegates from Saarc countries. I am Dr. Velayudham Swarnakumar from Sri Lanka.
Yeah. So I think now we have over by the welcome notes from the majority of the Saarc countries. We would like to request everyone to please do the line planting ceremony, sir. Sir, please.
Everyone on dance, please.
Yes. Words from everyone, so would like to start with the IPS sir. So please say a few words, sir. So you can.
Friends, I think it has been a very eventful day today, and it was a dream come true because we always wanted all the Saarc countries to come on a single platform. We had been cooperating with Nepal for so many years, I think more than 10 years now, and Nepal and Indian Arthroscopy Society have been working together. Even Bangladesh, we were lucky to have been in Boscon previously in the previous year, just before pandemic. It was a wonderfully organized conference with live surgery and panel discussions and a big conference with lot of attendees. So Indian Arthroscopy Society has always been close to Bangladesh, Nepal, Bhutan, Sri Lanka, Afghanistan and Pakistan. And we always wanted a Saarc group to be associated because, as rightly Sudeep said, our geography is same, our mythology is same, and our problems are same. So our patients' needs are same. And I think this was a platform which really provided all the key opinion leaders of the country, of the Saarc nations, to be on a single platform. We are lucky to have you from Bangladesh and Sudeep and his team, Ishore, from Nepal to be here with all of us. Rajiv Raman has done exemplary work. He is really the father of Saarc. The amount of love and cooperation which he gets from each one of us, be it Dr. Dorji from Bhutan, Imal Wardak from Afghanistan. I mean, it's really, really very good, and I think we were lucky to have him leading this and helping us to organize this meeting in such a short notice. Thank you very much, Rajiv, for making this dream come true. And I think as we progress further, and we have key opinion leaders of Bangladesh, Nepal, Bhutan, all around, we can have more and more meetings coming up and make a Saarc a big forceful group to be together. Thank you very much.
Thank you, sir. Thank you. When I request Sundar sir to please say a few words.
IPS said everything. So anyway, I want to thank Dr. Rajiv and Kolkata Arthroscopy and Sports Association, the society. Agreed to host this within a short period of 1 month. 1 month he has organized everything because IPS was his dream was to do an IAS Saarc meeting for the last year. We were planning, we were supposed to do it in Bhutan, that was stopped because of the first pandemic. But this time, I think it is possible because of only one man, because of Rajiv. And at the same time, I want to thank all the Calcutta members to cooperate with the Indian Arthroscopy Society to do this meeting in the short notice. Thank you very much.
Thank you, sir. So may I now request Dr. Sachin sir to please say a few words, sir? 30 seconds, sir.
I echo the views said by my colleagues, and on behalf of all of us, thank you for organizing this meeting. It is nice to be in person again, and we look forward to such many more endeavors in the future.
Thank you. Pratik sir, you would like to say a few words?
Yeah, it's already been echoed, and this summit of Saarc was tried, as IPS said, twice, and then finally this time we were able to, Rajiv helped, and we were able to do it. And thank you, Cass, and everybody else here to organize this wonderful meeting. And as I said, this is a fresh of breath air, because breath of fresh air, because we've been able to do in person and sitting on the computers and doing it for 2 years. Thank you so much. Wonderfully organized.
Thanks. You, sir. Thank you. Sudeep sir, I would like to hear a few words from you.
All Saarc messages were given in the transfer position. So am I also supposed to be in this transfer position and be direct?
Online was transfer.
Transfer. Okay.
Upside down.
Yeah, I'll try that. Okay. It was a wonderful experience from the time we landed in Calcutta. Thank you, Rajiv, and your entire team. And we really enjoyed the stay for last 2 days. Each and every point you have taken care of us, and we are really enjoying it. And I just wanted to say that why in Saarc we are related. I mean, how many of you have thought that mythologically how we are related? You know, the Ram married Sita. Ram was from Ayodhya. He came to Nepal from Mithila and married Sita to Ayodhya. And she was abducted by Ravana and took through Sri Lanka. See how we are related. And then the war, and Lakshmana was hit by this thing. And he was unconscious for his treatment. The Hanuman came all the way to Himalaya again, And Janaka, and for all the important dry fruits used to come from Afghanistan. And Ravana, he wanted to have muchli, he used to come from the Maldives. So it was all related. So now also our problems are similar, our cultures are similar. I think let's join hand, let's enjoy it together. Yeah. Thank you very much.
Thank you. Again. Thank you. Chandra sir, would like to hear a few words from you.
I've already said my bit.
Oh, you already finished.
First of all, I'd like to give big thanks to the organizing committee and Dr. Rajiv Brown for inviting us. So I have many times visited. I never, I always attend IAS conference every time I come. I have visited most of the cities in India and attending the conference. So I love to attend every conferences that will be held in India. So likewise, we are planning to conduct international conference and we are like to invite you. We are planning to do Saarc conference in Pokhara. Pokhara is city, very beautiful city where I live in. So I like to invite you all if we get a chance to hold meeting. Thanks for that.
Thank you. So Parveza, would like to hear a few words from you as well at last.
Thanks the organizing committee of CAS and Saarc Arthroscopy Association newly formed. Actually, in the year of 2014, Rajiv Raman came to Bangladesh. At that time, only 2 arthroscopic surgeons was in Bangladesh. And after coming, he just worked with us, and we had a joint, forum, and he used to see the patient, selecting patient we jointly organized, and we used to do about 20-25 arthroscopy in twice in each year. Then after that, he had a thought of forming an organization like Saarc, and he told me about 2016 that we'll go for forming the Arthroscopy Society Saarc. He then went to Nepal, sorry, he went to Bhutan, and the work that has been shown is done. Same work we had done every year, but due to COVID, this work was stopped and webinar was continued. We used to invite a lot of surgeons from Bangladesh, and webinar was continued in association with Indian Arthroscopy Society, especially IPS Oberoi was conducting this program. That means the Rajiv Raman always making us wake. We always try to sleep. By his stimulation, we become wake up. But still, what we have that about 11 surgeons were invited for this program due to government restriction of going outside the country. They didn't come to this and attend this program. But what we have seen, the standard of program become very much developed this time, and I become overwhelmed and charmed, and I feel that again Rajiv Raman have to go to our country and making us wake up. And due to Rajiv Raman, I want to say that about 25 arthroscopic surgeon is now in Bangladesh.
Thank you.
And not his team. Rajiv not only he used to take another two surgeons, and the shoulder surgeons also went to Dhaka for performing a lot of work. So we are grateful for everyone. Indian Arthroscopic Society, we become life member of Indian Arthroscopic Society, about 10 or 12%. And everyone, especially not from Kolkata, from Delhi person and Mumbai, Roshan Wada also came to Dhaka. And we are really grateful to everyone, every arthroscopic surgeon and West Bengal arthroscopic surgeons, Kanchan Bhattacharya, Devashish Chatterjee, and Sonandu Samanto, everyone, we are grateful to them. Thank you very much to giving the opportunity to coming here and to say something for you all. Thank you very much.
Thank you, sir. Thank you. Now I would like to call Dr. Sundarajan, sir, for the conduct of the change of collar ceremony. Thank you, sir.
Thank you, Sunit. I forgot to mention Dr. Sunit Azra and Samjit Datta, who have done exemplary work coordinating with Rajiv Raman for this program. So they are the backbone of Rajiv. So I thank both Sunit and Samjit Datta. At the same time, we want to take this opportunity because this is an official meeting of Indian Arthroscopy Society. Our dynamic leader, IPS Oberoi, is finishing his term as a president of Indian Arthroscopy Society in this March 31st. So we thought it is an opportunity to do the change of color. So I invite Dr. IPS Oberoi to give his speech and do the changeover. Thank you.
Thank you very much, Sundar. I think it had been a very eventful last 2 years, COVID. The day I took over as president of Indian Arthroscopy Society, lockdown was all around. Everything just stopped, and first we were depressed what to do, because when you take a chair you really want to do a lot of things, and when there is lockdown everybody comes to a standstill. However, I think we became wiser enough. We started doing some online work, and it actually picked up quite fast. We gave a presidential line which is called digital education, the way to go forward, and I think then we really stick to the word by the spirit. We made a IES YouTube channel and started online educational programs. These programs included lectures from the authorities of arthroscopy all across the world. We were lucky that we had the best of the people who were sitting idly, and if you just call them, Lateral, sir, we want your presentation, ready. Richard Villa, we want you to speak, ready. Everybody was ready, and we were lucky to have one-to-one interaction with the top arthroscopy guys of the world who actually write books, and we had one-to-one interaction. We archived every of these webinars, videos into our IS YouTube channel, and now we have 173 videos on IS YouTube channel, which includes itself is a big data bank of arthroscopy education available to every person across the globe who can just click on IS website. We have got 3,400 plus subscribers to our channel, which is actually nearly the same number of people which are members of Indian Arthroscopy Society, and the number of hits are close to 2 lakh hits. So it's indeed a very well objective which was done. Secondly, we also asked for videos from the key opinion leaders. Top guys of Indian Arthroscopy Society actually made their videos of different surgical procedures, edited them, did a voiceover and sent it across to. We have 63 videos which includes almost all indications of arthroscopy, be it ACL, PCL, MPFL, whatever you talk about, you have a KOL speaking with a 5 to 7 minutes video which is there. I meet so many young people in meetings and they say, before going into OR, sometime we have any confusion, we go back to the YouTube channel, try to search for that video, and it's easy to search, knee, shoulder, everything is easy to search. Find that video and listen to that video, how that master showed that he does this kind of meniscus repair and then reproduce everything back home. So this was a very good initiative which we were able to take. Second big initiative which we were able to take, and that had been our dream for so many years, was coming out with an Indian Arthroscopy Journal. I think JASSM, which is Journal of Arthroscopy Sports Medicine, is a national journal, is an official journal of Indian Arthroscopy Society, and we were lucky that in elections Raju Vesh became the editor, and he is the one who is actually having knack of publication. He took up the lead, we arranged money, and he started with IES journal. We already have 3 journals coming up, already published and well read. It's already an index journal now, and it is reaching heights. And the best thing about it is, again, the leaders, the world leaders in arthroscopy have their article in JSSM. We always come with the journal way ahead of the timeline. So if we think we are going to launch it by 6 months, by 5th month it is already online. So it's an official journal of arthroscopy of Indian Arthroscopy Society, and that was the second big thing which happened to all of us. And the third big thing was registry. I think we were doing huge amount of work in India, both in ACL and shoulder, and I think we took up that challenge of continuing and starting that registry program. We were lucky again to identify Dr. Armugam. He's leader of thought process in registry. He worked really hard with along of his team of 4 or 5 people, and they really worked hard and were able to launch the registry, and it is actually going well, and we would request all the members of IES actually to actively involve themselves into registry. So looking into last 2 years of academic activities, we were lucky that we got use the time which this pandemic was giving to us to digitalize our arthroscopy education to a certain level. We also did a lot of cooperation work with both Bangladesh and Nepal and other Saarc countries. So we had a lot of webinars with Saarc countries, both for knee as well as shoulder. It also increased the help and cooperation. We did a lot of webinars with state chapters, even the city chapters like Nagpur. I mean, everybody contributed. Each and every member of Indian Arthroscopy Society contributed some way, either as a webinar or as a case presentation or as an innovative techniques to be on that platform. And I'm very, very happy that last 2 years have been very eventful for Indian Arthroscopy Society. We launched our website, made it a new website. We made all the official work of IES paperless now. It is a back office on the website where you have accounts, where you have income tax returns, everything is on the back office. I think this was a vision which we were thinking to streamline the Indian Arthroscopy Society and bring it to a new height. I would actually be very, very happy now because the people who are going to succeed me are one which have got a global vision, they have got a wider vision than me. They are Sachin Tapaswi, and after Sachin it's Dr. Armugam. Both of them have been passionate about Indian Arthroscopy Society, passionate about education and teaching and training, and I think the Indian Arthroscopy Society is going to grow much more further with leads of people like Sachin and Dr. Armugam after him. I have a best of honor of handing over this medallion to my dear friend Sachin Tapaswi. Sachin, please.
I think everybody's waiting when I stop speaking because everybody's pretty hungry and want to go ahead. But I think this comes as a huge burden on my shoulders, a huge burden because it's going to be very difficult to reach the summit of probably the tallest academic mountain and the tallest peak that the Indian Arthroscopy Society has scaled in the last 2 years. And I think your last motivational talk has really motivated me in all aspects, and I will try my best to, at least continue the good work you have done, and I promise you that your guiding force will stay behind all of us, since you still continue to be with us as an official member over the next 2 years. It will be important that we reach out and ensure that all of us get heard, all of us get seen, and all of us contribute to developing this society for its basic values of academics, education, and also importantly looking at creating new memberships and creating new opportunities for people to express themselves, to stand up and develop new friendships, new bonds, and take the whole science ahead so that we can serve our patients better. Thank you so very much.
So that's the end of the inauguration ceremony. Thank you everyone for being patient, and we can now join for dinner. And at the hotel on it, first floor.